मेडिकल इंक्यूबेटर सेंटर फॉर मेडिकल इनोवेशन, जो कि किसी भी मेडिकल संस्थान में पहला है, उसकी यहाँ पर स्थापना की है, जिसमें कि उन हॉस्पिटल में जितनी भी समस्याएं हैं उसका समाधान देख सकते हैं। उनके लिए आइडियाज़ को वी कैन कन्वर्ट इनटू द प्रोडक्ट्स। और इसके साथ साथ अभी हमें बायोमेस भी इस बार अवॉर्ड हुआ है। तो हमारा चार में एकेडमिक्स में और रिसर्च में जो भी ज़्यादा से ज़्यादा काम है वो यहाँ पे हो रहा है। और मैं सभी को ये रिक्वेस्ट करता हूँ कि जिम्स में जो भी फैसिलिटीज़ हैं उसका पूरा लाभ उठाएं। धन्यवाद।
गवर्नमेंट इंस्टीट्यूट ऑफ मेडिकल साइंसेज, जिम्स, विश्वास का नया नाम।
Welcome to the very important panel of the day. We have the poster background. So welcome you all to the BFI Pavilion, the panel 1, where we started discussing about the opportunities of AI for healthcare, keeping very, very specific and very centric to patients, very centric to ethical challenges. We'll be talking about the software medical devices, the deployment challenges, how does the clinician understand your tool and technology, if at all you're a startup. We'll be touching all the important parts. So the panel 1 says that India to the world, designing patient-centric, ethical and clinically safe AI. AI in healthcare is no longer an experiment. It is entering hospitals, influencing diagnostics, shaping public health deliveries, and guiding clinical decisions. But the real question is not that can we build AI, because what we see here is that India is already building it. The real question is, can we co-design AI that is clinically validated, ethically governed, workflow integrated, and scalable from India to the world? Today's panel discussion represents the full innovation stack: the government leadership, Government of Medical Sciences, global investors, deep tech founders, academic researchers, social health organizations. As the moderator from Center for Medical Innovation, Government of Medical Sciences, Greater Noida, I will be talking about the 4 different pillars: the clinical safety, ethical data governance, the scalable deployment, and the patient-centric outcome. I'm very proud to have in our panel Dr. Brigadier Rakesh Gupta sir. Sir is Director, Government of Medical Sciences. Our medical institute right from 40 kilometers from where we are sitting, one of the finest medical schools of Government of Uttar Pradesh. We've ranked the best performing institute in COVID-19. We teach medicine, we teach nursing, and we have also established country's first Section 8 Government Section 8 Incubation Center, which is not only an incubation center but also our Stanford By Design Center, and now also our BIRAC Center. On our panel, we are very happy to have Mrs. Saud. Mrs. Saud is CEO of Link India, co-president for now French Tech India France. She brings all the dynamism to the first panel, all the way from her experience in France. Global startup ecosystem, cross-border collaboration, supporting responsible innovation and international partnership to scale ethical AI across markets is for what Mr. Saud is known for. Then we have a very special startup. Yesterday, our Prime Minister Modi ji and President Macron, they announced that year 2026 would be named as the Innovation Year for India and France. We are very proud that the very next morning, the very next morning here, we have 2 important people right from France, where we are giving a very clear example to the world that if you just put your hands, one hand out towards us, we'll come and hug you. So that's the message, that if you want to come down to India, you want anything that we have, collaboration is the key. We together can do a lot of things which as an independent single country it might take a little longer time. Mr. Gautier is the CEO for X company. Welcome, Mr. Gautier. He is one of the startups that has traveled with the president delegation to India, and we're very proud to inform them that we will also be doing a POC. We'll be giving them an intent letter that the product which they have, Gyms will also be doing a POC. Already a hospital in Bangalore has done it. So we'll be the government hospital doing it, probably the first government hospital in the country doing it. Their AI product development and international market execution, designing robust, regulation-ready AI product, which is very, very patient-centric and global deployment readiness. Our next important guest is Dr. Satyashil Pawar. Sir is a professor at IIT Mandi. He is also a mentor at GIM. He was ex-director, the IPR cell at IIT Mandi, and also was heading the Innovation Center as the director. Sir, we will be talking to you regarding your AI researches. In an era of AI, how do we preserve the patent? And if I have created a patent out of my understanding using AI, will AI ask for an equity? So I will go to you with that question. And last but not least, the most important man on the show is Dr. Rajat Jain. Dr. Rajat Jain is the president for Doctors for You, a philanthropic organization in the country. He's a radiologist, a social deployment expert, a community healthcare, ensuring the AI solution reaches the undeserved population, and has been associated with our institute for a long time. And we together, along with Gyms and Doctors for You, have proven what collaboration can do during COVID-19. Thank you. First part of the session, we'll go to every individual talking about one important part. What does the patient-centric AI mean to you? And ladies and gentlemen, everyone in the crowd, when the hospital talks about AI, our understanding of AI is really different than what the technology world understands it. When we say that hospitals will use AI for basic and the better patient outcome, you have to convince the doctors that it is ethically safe, it is clinically sound, and it is patient-centric, and it is helping me in taking my decisions, not replacing me. We'll be talking about everything, but the first round is a 1-minute session where we go on to everyone and ask, in 1 minute, what does the patient-centric AI means to you? Primarily, first I'll go down to my own director, Brigadier Dr. Rakesh Gupta. Sir, from the public health and the government lens, and you also represent the government of UP, one of the finest medical schools. From the public health and the government lens, what does the patient-centric AI in a larger public hospital ecosystem like ours look like?
Thank you, Dr. Rahul, and thank you, BFI, for making Gyms as a part of this event and helping in various ways, BFI. Now, Government Institute of Medical Sciences is already using AI. And being a public hospital, we also started first AI clinic in the government hospitals. And I'm very proud to say that more than 15 startups or people who are actually involved in AI is helping Gyms in various capacities, various ways. There are devices which are helping. There are AI system which is actually helping. So Gyms is actually using AI in a big way. So if I see the patient's satisfaction, that is the ultimate goal. Outcome of the patient is improving AI. AI, I always call it as augmented intelligence, not the artificial intelligence. And actually, the moment patient enters, he goes into the various public hospital where is demand is more, supply of doctors and resources are less. So AI is actually augmenting our capacity to do more for the patient. Now various fields which we are actually using it and AI is helping. One is of course the clinical decision making. AI is making us diagnose much early compared to when patient started symptoms. So it is helping us, especially the cancers, oral, breast, and the cervical cancer are early diagnosed by help to the AI. That is also helping in our radiology department when we take the X-ray or CT, when volume is high, it is not practically possible to see each X-ray or each CT scan in so detail, but AI is giving us a ready-made solution. Yes, these are the red flags which actually are need to be picked up so that we can start early. So the turnaround time is also actually reduced. Same thing is for in lab investigations, that is helping and without various examination of peripheral bliss may have a other investigation which is actually helping. AI is also helping in pricing because number is more. We are not able to give sufficient time to each and every patient. So it is pricing which patients are high risk, which patient need to be given more time. So I think AI is helping in those areas also. AI is also helping in patients. When the patient tender, there is a big problem of queuing. So AI picks up the patients. AI helping and early their appointment. AI is also helping patients overall journey from entering till exit. At everywhere we see there are problems which can be facilitated by AI. And AI is also safe and of course again last I say is not going to replace doctors, but there are lot of work which doctors has to do repeated works. Writing same advice given to all patients, same thing writing, patient doctor is telling something, you got a ready-made prescriptions, you got a ready-made discharges. So I think AI is a big way it is helping patients, especially in a government setup where its volume is very high. So it is facilitating in very ways. It is safe and it is ethical. Of course, we should not misuse it, but I think it is going to help in a big way.
Thank you so much, sir. Thank you so much. Next, I'll go on to Gautier. Gautier, you are a very, very important startup, and from yesterday's what my PM has sent a global message of the global friendship that he has announced with France. I want to understand from you, from a product guy, who's making products, what is the most important way to deploy AI in hospitals today in your country? And then we'll be talking about it, how we do it here. And then I have one more question, because you can address it together. There's a lot of noise around AI. What is the real state of AI in hospitals today, and where does it truly create measurable values? I want you to answer from the France and the global perspective. The Indian perspective, we know.
Okay. Yes, thanks for these two questions. So, my background is I worked for 10 years in the US company. We deployed AI in hospitals, and now we have H company in France doing it from the France perspective. Just so you know, we deploy in a lot of different industries, government, industry, manufacturing, energy, and also healthcare. I think, first of all, adoption of AI is not the most important to me, because if it's just creating a new technology, it doesn't really serve a purpose. So what's most important is really having real results. And how you do that? The way we do it in France, and the way I've done it in the US as well, is you have very specific expertise in doctors, in nurses, and that's an expertise that if you just create a new AI tool and you give it to caretakers, you're not going to capture that expertise. So that's the reason why we send engineers. They are sitting next to doctors, sitting next to nurses, and iterating with them multiple times a day so that you build a product that is exactly what is needed. And it's different in every hospital, it's different in every specialty. So that's the first very important thing. The second one is in a hospital, as you know, and I'm sure it's the same in India, but in France you have a lot of different software. And these software are serving a specific purpose. One is pharmacy, one is admission, one is taking care of the supply, one is diagnostics. And these software have been built over the years, but they don't communicate well between each other. So what we end up seeing in France is 60% of the time of nurses, of doctors is spent in front of a computer. So they're going to click, they're going to type on a keyboard instead of spending time with patients. And that's the main thing that we are reducing, so that they can focus their energy into what is really needed for the patient. So that's the way we do it is because very often this software is a custom for the hospital, or you need to connect to an external website, or they are old software, new software. So the way we do it is with a technology that doesn't require months and months of projects, because it's going to interact the same way it will interact with a human will interact with a computer. So it takes a couple of days to deploy that. So these are the ways we are doing it. And the state, your second question, the state of AI in healthcare and in hospitals, I think is very it's very early, obviously. We are just at the very beginning, and we are seeing real results, including so when hospital we deployed, I was able to reduce by 30% the waiting time in emergency room. Not with more money, not with more people, just with more efficiency in the way the doctors and nurses can focus on patients. And obviously, if you wait longer, your chances decrease. If you wait shorter, so that's like having a real impact on saving lives and saving chances of patients.
Perfect. And probably one more part that I would understand. What does it mean when two head of the nations come together and they announce year of innovation together? This has never happened, right?
Yes.
What does it mean to somebody? I'll be asking Saad as well from a startup perspective, because from an Indian perspective, we see that the entire France market is open for my startup. How do you see this as an opportunity?
Yes, so I think it's not it's not a chance that France and India are building that partnership, because we share a lot of values that I've been learning to discover India over the past few trips. I think to us, as you said, Director, the values are very centric to our approach. So the values of not only privacy, but also taking care of the patients. So that's one thing that I think is bringing us closer. We have a lot of blocks now, US, China, India, Europe. And I think Europe and India, and especially France, have a lot of things to do together. What does it mean in concrete terms? It means I'm sitting here. It means we have these connections, thanks also to Swad. But yesterday in Mumbai with your Prime Minister and our President was a great way to just meet, get to know each other. A month ago we were in Davos in Switzerland as well, with India through a big party with a lot of good food as well. But these are the small things that I think are bringing our countries together. Getting to understand the differences, the similarities. India is the biggest country in the world. You have the best engineers, some of the best engineers in the world. In France,
The best doctors as well.
and I'm sure the best doctors. But I'm starting to realize it now. But yeah, it's. I think we share in common an interest in science. Doctor in France, being engineer in France is a big deal. It's a very prestigious thing. It's not the case in a lot of countries, but we have that in common, and we are not that far away. 7-hour flights, so.
Perfect, thank you. So I am waiting for a day when getting to France and coming down to India will be visa free. So soon that day will also come.
Yes.
At least for startups, right?
It's not my power, but I'll try to push that.
Thank you. So next I'll go on to Madam Saad. Madam, you are at the junction of two nations, right? Whatever I can study about Blink and you, right? Creating a funnel between two countries, right? But the question that I have for you is, from France and India Innovation Corridor perspective, how do we ensure that AI is ethical and scalable across borders? And I'll just substitute this because after this we'll be going to Dr. Rajat. What happens is, there's a very disparity in understanding of opinion in trials. I was talking about it as well. Here in Indian hospitals, we are very clear with clinical opinion and clinical trial. Clinical trial in India means institutional trials. It does not mean that a group of 4 friends come together and they say it looks good. That is not trial. I want you to tell me from this perspective, how do we ensure that this AI is ethical, scalable, and across the borders it is the same?
Thank you so much for First, I would like to thank you for inviting us. So it's very, very important for us to be with you and to be with partners like you. So thank you so much. We're very honored to be here. Second, I would start by maybe telling you a little bit about my story in India. So in fact, I don't come from either medical or background. I work in energy, in nuclear engineering projects in India. I started working with India in 2009, spent 10 years in Bangalore. And so, I've been leading acceleration programs, and today with Link, our goal is in fact to make sure that large companies, large multinationals, foreign, French, Indian multinationals, leverage the Indian technologies and the Indian ecosystem. So for the past 12 years now, we've launched in 2014 what we have seen between India and France. First, I need to assure you that we are much closer than this 9 hours I could say. We have the same underlying principles in the way we conduct our business, in the way we are, in the way we are in fact building our nations. So for us, when you say what is patient centricity, for me it starts with data sovereignty. It starts by putting the patient at the core of everything that we are building. Same in France. In France, it's very important. Again, like what we are doing with France and today with Europe, we are trying to prove that regulation can go with the AI innovation. It's not slowing down, it's making sure that at the end, the return on innovation, the return on investment on these technologies will come to the public, it will come to the people and to the patients. So we have the same values in terms of academic excellence. So when we know that it has to go through this if we want to be together. So for us, I think what we have heard yesterday in Mumbai, Betsy and I, our leaders, the Prime Minister and the President, the Prime Minister of India and the President, what they were telling us is that today it's not about are we going to innovate together or how are we going to innovate together. It's mostly how India and France will scale innovation together and we will be a beacon for the rest of the world. In fact, we are building a third wave. Today, we cannot count on the rest of the world. If India and Europe are not aligning, if India and Europe are aligning, this is going to be very strong for everyone. And so, I think for me, I go back to VIXAT 2047. If in our story, in our history with India, the French and Indian history, when you became an independent country, a strong independent country, we were the first to congratulate you because we know that it was really important for India to change and to develop and to become one of the global leaders, one of the leaders or maybe the leader in the world. So VIXAT for us in 2047, we will be your partner, we'll be there. And for us, we know that supporting, in fact, the scale of India is also making sure that we will be able to scale our technologies, our innovations in India. So for the corridor, for the Indo-French corridor, you were talking about the visa. I want to say also that La French Tech, those red roosters here, the rooster is our animal, the symbol in French. And so the red rooster is in fact the symbol of the La French Tech, the technology, the French ecosystem. And so we have what we call the French Tech visa. Today the French Tech visa is much better than the H1B visa, I can tell you that. Doesn't come there. So the French Tech visa is an open innovation for innovators and for entrepreneurs from India. We are really welcoming you with open arms. The French Tech visa is very, make sure that your spouse will be able to work in France, to make sure that you will be really hitting the ground running, that it's possible. So this is really something that we want to build. So thank you.
Thank you so much for putting it all together. Next we'll go down to Dr. Rajat Jain. Rajat sir, you are president for Doctors for You. It's a philanthropic organization, has done wonders in COVID-19. GIMS has been a very important part of your on-ground work. You are a radiologist, a social deployment expert. You understand the community, you understand the access to the community, and you have been doing it for some time. I want to understand, how is that the AI deployment in community. And what is the challenge that you see from somebody who listens to so many ideas every day? That everybody wants to do a pilot at the community. Sometimes people take the community pilot as a shortcut to trial. What is your take from a clinician? Because you are a clinician at heart. We clinicians want that it has to be ethical, safe, regulated, patient-driven. You know, what is your take on this when we talk about deployments and what are the challenges and probably the possible solutions?
First of all, thank you, Dr. Rahul, for raising this point, and thank you, Brigadier Gupta and BFI for inviting me over here. So I am very, very useful about saying a statement that India is very, very diverse, and we can find, like what I say, we live to India. So I say to India, on one side, we are talking about buying a house of worth 100 crore rupees at Gurgaon, and on the other hand, out of 800 districts, 112 districts are still considered aspirational. And the second unfortunate part is, if I talk about the aspirational district, then if I talk to the audience that can you name 10 aspirational districts of India, I can bet that not even a single person can name 10 aspirational districts. Similarly, if I say that in 5 seconds, can you tell me the 7 sisters or the 7 states in the northeastern part of the country? And few people can name, but if I say that tell me the 5 districts or the 5 cities of the Nagaland, I don't think that apart from Kohima and Dimapur, any other city that somebody can talk about. So this is a very, very big challenge. Another area that I always talk about, that we talk sitting here that the sanitary pad causes pollution, their safe disposal should be there. But on the other hand, 2/3 of the Indian population do not have an access of menstrual hygiene. So those are some real challenges which are there in our country, and after traveling extensively, what I have realized that when we talk about AI, we talk about that do you think that AI will improve healthcare? I don't think that's even a question. AI will definitely improve healthcare, there's no doubt about it. Now the question is who will benefit? Will it increase the inequality? So that's a question that one should consider. Uh, I believe that all the solutions that we are building up for AI should be first focused on how this tech inequality can be taken care of. The, the, when we talk about the solutions of the AI, specifically in the healthcare, they should be focused on creating or understanding last mile challenges rather than for the privileged tier. Brigadier Gupta has mentioned a very interesting point that for him AI stands for augmented intelligence. So I can break it down that yes, it can be considered augmented intelligence, it can be considered artificial intelligence also. So I believe that artificial intelligence is intelligence when the natural intelligence does not exist. Right? That's an area where we have to go. So for all the tech driven which we doctors for you is trying to do is to bridge those gaps, making sure that the technology is reaching to the last mile. Technology is reaching to the people where they do not have an access to the basic medical services. At this stage, we can say that oh, a gastroenterologist is not available 24 hours in a day. But on the other hand, there are areas in our country where even an MBBS doctor is not available. They also have a right to live. They also have a right to get the medical access. So what kind of solutions we can provide so that the last mile connectivity, the medical health can be reached to the last mile. Now, as you mentioned about the everybody is now thinking about deploying it to the community. All the solutions are we developing. Do they have the data taken from the problems that are there at the ground? Sometimes when we are looking at an urban population and developing a technology on the basis of that, the challenges that we're going to see at the ground will be far, far different. For example, I remember that we developed a tool and which we tested on the ground that was related to reading of the chest X-ray using the AI software. And when we tried to deploy it at the ground, we realized that most of those tools have been developed, which was a real-time learning on the basis of an internet. A specific width or the bandwidth of the internet was required. But then we went to those areas where the internet facility was not available, so we could not deploy that. So then that went back and the feedback was given, and then these tools were redrafted in a way so that
the interpretation can be done even without the need of internet. Then the storage, then the second problem that was facing again was the internet, that the data has to be transferred. And then the tool was developed when the even if the access or the internet is not available at a particular area, the local storage can happen on that particular device, and the moment you reach to the internet area, then the data can be fetched and can be transferred. So the first is that any solution that is being developed, I believe that this is a model, and I am very happy the way that the James is doing. Specifically in the matter what we say the private health sector is booming in India, but still more than 2/3 of the population has to go to the public hospital. So what I believe is that this is how it should happen, that the innovation centers should be in the public hospitals, the tech people should come, they should see the challenges which are there in the system, they should develop it, it should be vetted first in the hospital, the feedback mechanism should go back to the tech people, and what we call as an in vivo and in vitro testing. Once the testing has happened, then on a small scale, it should be given to us. I am very happy to say that presently Doctors for You is present across India, from Kashmir to Kerala and from Gujarat to Nagaland. So we have our team which is there on the ground, which work with the community on the basis of the requirement. We can deploy that at the ground and making sure that to give the feedback on what are the challenges that we are facing, to give it back to the center, then center can give it back to the developer, and together we can make a product which is adaptable not just to a particular sector but to a much larger part of the country. Thank you.
Thank you, sir, for making it very simple for the understanding of the audience. James has established a Section 8 company to run innovation center, which makes us UP's first incubation center in a government hospital. And we have been able to create a single window system for startups. If at all you want to have trials, you want to have clinical opinions, you want to have a POC understanding whether this POC is going to work or not work. From your primary document, that what you need for CDSCO, your test license, everything end to end, we have a single window system at the incubation center. The model is here building up. So India today, when we talk about India today, is where everybody is participating. And when we say the country had business incubators, the country had technology incubators, country had technology business incubators, then the country had bio incubators. The new trend is the medical incubation centers, the medical incubators. And we are very proud of leading this show at the first in UP. And okay, so let me go down to very important part of the session. Innovation has always been thought about creativity. And this question is to somebody who holds good number of patents. He's a professor at IIT Mandi, was heading the innovation center at IIT Mandi, was also the director IPR at IIT Mandi. From somebody with your understanding, when we appreciate innovation, we understand that it is an individual innovating and getting a license to protect the IPR. In an era of AI, suppose I create something using AI, how tough it is to infringe it, to make another one, and who will be the owner of that patent? Will someday AI, Sam Altman will come and say that he also owns the patent, a part of it? If you are developing an IP using AI, how do you see this changing? Because it was humans initially innovating. Now it is humans along with assistive technologies. How do you take up this question, sir?
Yeah, thanks for this question. This is a very important question, almost on all the forums. And before I answer the question, I would like to thank Dr. Rahul Gupta and also BFI for inviting me here. Coming back to the question, I would always say that AI has now, even now in this conversation, we got at least 2-3 different names to it. Augmented intelligence, you mentioned assistive. So I also prefer to call it as assistive intelligence because it assists you to do things in a smoother way. And we should not surrender it to AI to make it a decision maker. So we should not let it take the decisions. It should assist us to take the decisions. So even for doctors, it should help them to prioritize, because when it comes to even as a layman, because I'm not from medical education system, but even as a layman, I feel that while for doctors it's a very complex job. It's not just one X-ray that tells you about everything. There is a lot of other things that doctors look check. before giving you a diagnosis, whatever the diagnosis the doctor has thought about. So that's why the AI will assist you to accelerate or to fast or to prioritize. So that's the reason I would call it as assistive intelligence. When it comes to infringement, patents, so as per the law, it is the innovator is always a human being, and the applicant is always a human being or a legal entity. So the legal, of course, in all these cases, the artificial intelligence or assistive intelligence doesn't come as a human being. So the AI cannot be the inventor of any invention. So there is always a human being behind that AI. So you are the one who is commanding it, you are the one judging it, and judgment has a lot of value when it comes to innovation. And then you are drafting that patent, whatever patent it could be patent, it could be trademark, it could be copyright. So whatever it is, you are drafting that later on, you are giving it a shape, and that's why you own it. So as per the current state of law, there is no way that AI could be the inventor at this stage. This could also change, I don't know. So this is like something that we should watch for. When it comes to infringement, the infringement has various different ways. So for example, somebody who obviously if you are developing, because these days when we talk about innovation, innovation is not just limited to the product, it's not just limited to a way of processing something, but it is also an algorithm now. So algorithm has also taken a place. So you are developing new algorithms and you are then creating that as a, let's say, in India again the algorithm cannot be patented. It has to be a combination of hardware and software, and then this can be patented. So even if you are patenting that, you still have a lot of challenges because you are publishing a lot of data. Then whatever AI tool that you have developed, people can continuously ask questions and understand the methodology behind it, and then influence that. So there are obviously these set of challenges. Then the other challenges is more than the infringement. What I feel is the data, the training data. Where does the training data come from? There is also still, at least I'm not the expert of this particular area. That's why I feel it's a gray area. That whatever patient data that we are using for training that models, is it like who owns that data? Because the hospitals are custodian of that data. They are not the owner of that data. So the patient, whoever is that data comes from, could be the owner. So in that case, in that particular case, we need to have a consent from that the owner of the data, from the patient that whoever that data belongs to. So that's why this sort of ethical data, that this is where I feel like it's more challenging in today's world when it comes to the IPR, when it comes to the creation of innovation and using that data, generating the models and using that models for decision assisting, I would say decision making.
Perfect. Thank you so much. So, moving towards the last part, but then I want to understand that 5 years from now, nobody could ever, this was one of the widest dream possibly that something like AI will change everything. I want to understand what could be the next thing apart from AI. Well, the world need to be happening with the new technology. Technology is changing everything, the way we use phone, everything. To few of my panels, I say that AI is the new electricity. Everybody needs it. But then, I want to understand, can we say that it is the awareness of the intelligence? When we say AI is awareness of the intelligence, so that I know the other car who is driving towards me is not going to hit me, is my intelligence. I am aware of my intelligence. I am also aware of his intelligence. His driving mode can tell me whether he is drunk or not. So awareness of intelligence is what we can think of when we want to be validated in a longer era. Something more frugal than this, something more powerful than this will disrupt healthcare, not just healthcare, every technology field. I want to understand from the France perspective, what could be the future skill? The future skill is very important because when AI came in, doctors are adopting AI, right? When computers came in, doctors adopted AI. When STEP came in, we adopted AI, the STEP, right? We have been an adopter of the technology. I want to understand from your perspective, what could be the one future skill that we think of could be may not have been seen, right? That you feel, this could be the future of the technology, may not be technology. Somewhere I was sitting, I said, possibly 10 years from now, people with humanity background, with more empathy will rule the world. Because technology will anyway overtake humans. So human empathy will rule the world. So what is your understanding of what will be the future of the technology that people do not understand, do not know? So AI engineers tell me that they knew that AI exists. Now it has become popular. I don't understand from you.
Do I have an hour?
You just have 2 minutes.
Okay. So yeah, I think in terms of the future, there is a 2 year, the 5 years, the 10 year, and it's a very different story. I think a skill, when I'm talking to young kids or students, a skill that is...
Just to give you one example, I see internet as important as the development of the fire. The fire development changed everything for the mankind. The electricity development changed everything for mankind. Now, the internet changed everything for mankind. Something like this AI will do to mankind, or something else is going to do that?
I think it's going to be a big change. It's a new tool that is encompassing a lot of things that we saw humans were the best at. So I think in terms of like the skills that are going to be most important, in my opinion, agency is a big one. So like making the decisions, this is the direction we want to take. The AI can take some of these decisions, but it's very early. We also have 5 billion years of evolution, maybe more, in ourselves. So we have that survival instinct. We have a lot of things that are specific to humans. So I think creativity, we see AI can be very artists as being an artist, but creativity in the sense of imagining what is good for humans, what direction you want to take is a very important skill that we should all foster and develop. Also, criticism, not criticism as saying everything is bad, like we are known for in France, but critical thinking in the sense of critique. Because as you've all experienced, sometimes AI is hallucinating, they are not always right, there are ways to secure it, but still having a sense of critique, saying, okay, I'm being told that, but I'm going to investigate, I'm going to ask that question, I'm going to go in that direction, it's very important. And then I think it's interesting, my grandfather is 95 years old, from Bordeaux, he's been making wine and drinking a lot of wine, and he's healthy, so I encourage you to do the same. But he was telling me one day I was walking from his house, and I was doing all these video calls, and he was like, at the end of the day, so you haven't walked today, right? Like you've been talking to people, laughing with people, like when do you actually do your work? And because he was known, like for his work was going in the fields and cutting the crops, and then it was like manual labor and a lot of things that had to be done. And I think it's going to be the same for 100 years when we'll be very old. We see our kids and they'll be doing things that we don't consider work, because AI is going to take care of a lot of things. But for them, it's going to be the new work. Like, oh, I wake up at 10, I do 5 hours of sports, I spend time with my kids, I spend 2 minutes checking an AI agent doing something, and then I go back to something else. I can't predict the future, but I think it's going to be, we are heading in a direction where a lot of tasks, I don't see humans spending time in front of a computer in 5 years. Like, I don't see keyboard, mouse being a thing. I think like AI is going to take care of all that sort of like manual IT work. And we will just be there for intention, checking, or interpersonal relationships, and for a lot of other things that I'm completely ignorant of. But I think that the direction we are heading is also the way we should deploy AI. We shouldn't deploy AI to replace humans, it's not going to work, but we should deploy AI where humans are doing a job that they are not really made for. Like, are you made for going to emails and copying and pasting into another software and clicking on something and writing another email, and like, not really. You are made for like doing what we do now, discussing, having discussions, spending time in healthcare with your patients, trying to understand what's happening. The thing that AI is maybe not really understand, because it's through a discussion, through a small gesture that someone is going to make, that you may go in one direction because you are human as well. So yeah, I think that's the way I see the future.
Oh, thank you so much. Let me go down to our own director, sir. One very important thing. For example, if you know to drive a bicycle and your father gets you a car, the first thing you do is go to a driving school, learn the basic of driving, and then apply for a what you call a test driving license. Test driving license. So if it is, and then after some time you get the license. I'll tell you one very good article which we saw a week back, where one of the patients, they took the hospital prescription, they modified the prescription using AI, they included the narcotic drugs and got the medicine from the pharmacist. This is a real challenge because in a country like ours or anywhere, wherever there is a constitution, whatever wrong goes with the signature of the clinician is to be held accountable. In a technology like this, what should be the policy? I want to understand from Director sir, these challenges, how should we regulate it? Should this be considered as a very regulated tool for healthcare? Not like a WhatsApp for everyone? What's your take on this?
Thank you, Dr. Rahul. I think this is the biggest challenge I see in my own institution to accept AI. Right? Senior clinicians actually it's very difficult convince them कि उनका prescription कोई और लिखेगा, आपकी दवाई कोई और दे देगा. Right? So I think it's very difficult. And secondly, if I see the collaboration between engineering and medical, doctors have to be motivated. They have to bring down their ego lower, and they have to understand actually it is not replacing. But it is human touch, what is empathy, not going to, AI is not going to do it. So we also have to have motivation, we also have to take help of engineering. If the engineering work with the medical, I think that is a perfect combination. That is what we are actually going to do. At some of the engineering colleges, we are trying to have a collaboration so that together we can work for the ultimate welfare of the patient. So one, we have to understand, if I tell कि आपको पहले ये सीखो, उसका license लो, उसके बाद if you do so many regulations, whatever little bit that so one, we have to work together as a team. And you have a model CMIS where everyone coming together and working for the same single goal. I think so. We need to encourage this type of culture, this type of setup in various medical institutions. Or like engineering, they have got a 6 months sort of electives or internship to the industry. They should also come to the medical colleges, medical institutions, where they should try and work with the clinicians. That way they can see the problems and see how we can actually help without compromising that empathy part or without compromising that counseling part. So I think this is going to change. Initially computer came, then also we had a little hesitation why we should use it. And it is going to interfere, it is going to take our jobs. That is not so. But in the overall interest of the patient, we have to adopt it. We have to collaborate. I think this is doable thing, and I see a very bright future of AI helping hospitals, helping doctors, helping a patient which actually needs a better care, affordable care, accessible care, and ethical care.
Thank you so much, sir. And toward the last, I'll go down to Madam Saud. What is one future skill the healthcare professional must develop by 2030? Next 4 years.
2030.
Yeah. Then you feel that doctors should must. No, because here in India, we have started courses to teach AI to doctors so that we enable the capacity building. So the government is very on it. We want our doctors to learn AI so that they can differentiate between the ethical and non-ethical AI. Right? How do you see it? So deadline is 2030. One future skill, and then last part is what that we can think of where we see now, because we are friends when our Prime Minister and President has announced it. What is that we see that your intention of working with gyms in a government hospital when we think of creating more corridors with our medical institute? Just a vision of it.
Thank you, Dr. So, in terms of skills, I think today it's about, and I think like the first point about critical thinking is absolutely important because again, like you should not just take this new technology for granted and just say that okay, so whatever this can do for me, I will just absorb it. In the meantime, what you were saying about empathy is absolutely important because it's one thing that nothing will replace in the way we interact within our organization, with each other, with our clients and patients, etc., etc. And I'd say what we have seen, at least in my job, on a daily basis, when we try to integrate new technologies within organization, value chains of organization, is the resistance to change. And so this is a very natural reaction to change, because in fact I think the resistance to change has saved us in our history as humanity. But I think being risk averse is something that maybe we have built in our education. So follow the protocol, do what your seniors were doing. Don't innovate, like stay within the boundaries of what I told you because I'm your boss and so I told you to do this. Today, technology is moving too fast for that way of thinking. So what we are doing in my company is blurring the boundaries of organizations. When we work with the Mercedes, when we work with Michelin, Volvo, or Honeywell, what we do is we tell them, you have very, very intelligent people internally. You have higher talented people. Now, blur the boundaries of your company, integrate with external talents, but go fast to it. And so iterate, create MVPs, etc., etc. So I think it's something that today, anyway, doctors will always be in the loop. This is not like the essence of the skills of the doctor will not be changed or taken from them, but we have to behave a certain way, different way towards technology, towards new ways of doing things. So I have a very good friend of mine in Paris. She's a doctor in emergency rooms. And in the middle of the night, she has issues because she cannot call her colleagues who are radiologists to come and look at the x-rays. And she told me, very recently I took a coffee with her and she's saying that, I don't know what others are saying about AI, but for me, I'm going faster to diagnosis, I'm going faster to helping a patient in the middle of the night because I have just found this tool. It just tells me I'm not a radiologist, and she's saying so I need help. I need help in identifying where is the broken bone. And it's just a help, as you said, doctor. And it's very, and I will quote you a lot this week. I think it's augmented intelligence. It's the way that I'm being a better doctor and I'm being faster to doing my job by using these tools. And she has this tool basically that says, okay, so don't look everywhere, look around here. And it's her eyes as a doctor with her medical history, with her medical learnings and studies. You can say, okay, in this zone, I can see it. And so it's just being, I think it's about changing the time the time parameters. You need to go faster in doing your job because the world is just going faster, and so AI can make you do your work faster.
Perfect, thank you. And as we got as company here through Link, we hope that soon we'll be having a delegation to France where we'll be hosting Assembly for our.
Sorry, Doctor, I have to answer your last question about how we can work together. I think it's about creating the safe place for our innovators and yours and your doctors to work together. So in fact, it's how do you work? How do you make sure that everything is ready there? In terms of IP, in terms of clinical trials, in terms of incubation of these medical software and medical tools, before the pilots, before the innovators come to India or innovators from India go to France. This is something that really is about making sure that everything is set up so it happens.
Oh, perfect. Thank you so much. And towards last of the session, I'll be showing a video. So, 19 when PMOD and President Macron, they were announcing the year as the innovation year. Japan used China to came down to India to cover a government hospital. But are they using AI and if what, how? So this is the question.
Country's use of artificial intelligence.
Can we restart it?
Particularly in rural state of now to India, where AI is reshaping frontline healthcare. The northern state of Uttar Pradesh has opened an AI-powered clinic, marking a major step forward in the country's use of artificial intelligence in medicine, particularly in rural areas where doctors are few and far between. The clinic was launched last month at a government institution. India faces a shortage of medical facilities, especially in the countryside. Securing specialists to diagnose and treat conditions such as cancer and heart disease remains a challenge. The clinic uses an Indian-developed AI diagnostic system. It analyzes patient X-ray images, blood test results, and genetic data submitted by doctors. Using the AI's findings, physicians aim to detect serious conditions at an early stage. They also hope to support doctors in remote areas by sharing treatment plans and providing expert guidance.
This AI clinic was not just an awareness campaign. It's to create access to the last village, access to the top class clinician. We have this capacity where we see almost 2,000 patients every day.
AI is expected to play an increasingly important role in medical imaging and drug development. But some healthcare professionals are cautious about its rollout due to potential privacy violations and information leakage risks. Now to India, where AI is reshaping frontline healthcare. The northern state of Uttar Pradesh has opened an AI.
So thank you so much. This was just a small glimpse that when people used to say that private hospitals were the only standard, we are revising the standard. So basic access to care is what the government hospitals will have to do, and they will have to set the new standards of patient care. GIMS is an exceptional example. If at all you are in Delhi, come down to our hospital, to our innovation center, not as a patient, right? Toward the last part, we have a small token of appreciation for everyone. I request our director sir to give a token of appreciation to Madam Saud. Next we have Mr. Gautam. Thank you so much for the panelists. We'll go down to the very next panel, although we are running a little late. Can we have a group picture together before we leave, all the panelists? The next panel that we have is again Arun, Dr. Gupta, Director GIMS, Dr. Sumer Sethi sir, the founder of DAMS, Dr. Avnish Khare, he is an AI expert and also a faculty with MD to teach AI in medicine. Dr. Harsha, he is a pediatrician and AI expert. Dr. Ananta Lakshmi, a gynecologist and IVF expert from Chennai. Dr. Abhi Chatterjee, Vihat Director from Awaz Bali Innovation Network, IIT Dhanbad. And Dr. Sharvana, entrepreneur, startup and a business advisor from Chennai. Can we all have you?
Now? Yes. Okay, perfect. I thought we should do a better soon. Yes, sir. Soon.
Can we have all the panelists seated, please? With respect to time? Yes.
From the parliament.
And again, repeat the name.
He's one of the main officers who takes care of innovation and IT.
Avnish Khare sir, Harsha sir, Ananta Lakshmi ma'am, Abhi Chatterjee sir, and Sharvana.
Sir. We'll go back again to a very interesting panel, majority led by doctors, and this has been our agenda since panel 1 and will remain till the last panel. We want to create a doctor-driven ecosystem in the country, and the message is very, very clear. But the message also says that we're not complete without technology people. We're not complete with, it is incomplete at understanding the essence of it. But it is very, very important that doctors should understand that we have to understand technology for better patient outcome. The patient outcome will only increase if we understand whether this technology is going to help me and not help me. We'll have to ensure, because the patient has a lot of trust. When the patient comes to a doctor, the patient eats anything that you write. That's the godly feel. That's where the patient sees a doctor as a god, right? Because whatever you advise in the prescription with your sign, the patient goes, buys it and has it. That is where we have to ensure that wrong prescription do not enter our system. That is where we understand that wrong technologies do not come to the system. Wrong technologies in the name of access should not be allowed. And then technology should not be a barrier in creating opportunities. For example, you are using XYZ so that you do not go to the doctor initially, you get scanned with this. But what if it is not regulated and not very high quality? The opportunity to get access was lost because of the technology. We need to understand. We'll go to the session in depth. We'll talk about all the parts of it. But initially, this session is about something very, very fundamental. That is trust. AI is entering the consultation rooms, the operation theaters, ICUs, the fertility clinic, even medical classrooms. It promises efficiency, predictive insights, and better outcome. That is what it promises. But medicine is not just science. It is judgment, it is empathy, it is accountability. So the center question for this panel is, how do we ensure that AI strengthens the clinical decision making without weakening the doctor's-patient partnership or relationship or the trust? So the entire session will revolve around the trust which technology is not bringing. But we have to ensure that this technology is helping me in creating the trust better. Because no technology has come in the world which promises trust. The enablers are the doctors, enablers are the human being. Trust, empathy comes with human beings, right? Certification comes with the devices. Today we focus on 5 pillars. AI as decision support, not replacement. Ethical use of AI in the daily practice. The institutional governance, the capacity building and the AI literacy for doctors. and the measurable patient outcome. That is AI helping, and if what scale? Can this be scalable? Can we have models which can be replicated? Let us begin with 1 minute reflection from each panelist. Before I go to the panelists, again the theme is going to remain same. What must every doctor understand about AI today? The very clinical, simple question. Let me go down to my own director. From a governance and public health perspective, sir, what must a doctor understand before AI is introduced in the institutional workflow?
I think mere the fact that GIMS has established AI in our CMIS, our intention is very clear. And we actually wanted to prove that if you have to go forward, you have to go in the right direction, you have to go in a more ethical way. I think AI we have to adopt. We always tell doctors, our own staff, that you adopt it, not adopt, it is your choice. But if you have to compete with the world, if you have to compete with the, better doing doctors, please adopt AI. AI is not going to do. You actually wanted to give back to the patient your empathy, your counseling, your communication with. Under the background, we will facilitate your patients, how the patient satisfaction can be increased without compromising your own, way of dealing with the patients. So that is what your patient does not mean ki just write prescription is one, consultation is one, but when the patient is entering the hospital, especially public hospitals, patient is getting appointment, patient is getting support from the other, technology or staff doing investigations, and the patient gets early results. He does the X-ray. We have deployed one EGO5 where it is helping us in giving the X-ray report in not more than 10 minutes. So patient is very happy in the same visit, rather than coming today, giving X-ray or doing CT scan. Next day he comes and the doctor's consultation day after 3 days. They twice a week or thrice a week. So he is actually doing everything the same day. So I think it's a big help to the patient, and that is what our own doctors way, patient, how we can benefit patient. So I think there is no two ways about it. We have to understand, we have to adopt AI, and if we tell in that way, probably they also accept it. But yes, it is a team effort, and there should be a will from the top. There should be a budgetary constraint which need to facilitate. So I think this is a doable thing. Doctor has to adopt it, and it is going to help in a patients in a big way.
Thank you, sir. So you kept it very, very direct that doctors will have to learn AI. That's very, very simple, because you have to learn the rules of the road before you start driving. So that's very, very important to understand that who drives good, who drives bad. So for that we need to know that do I know the driving so that I comment on. That's very, very important. I'll go to Dr. Sumer Sethi, sir, and I have two questions from her. Sumer Sethi, sir, is a very popular figure in the entire medical industry. He is the founder for DAMS, Delhi Academy of Medical Sciences. He started his DAMS some 20 years back, 25 years back, when there was no startup fund, no policies, but then he created a model. So if you see, almost I guess out of 10, 4 or 5 students who have studied at DAMS across country. Few of them are at the panel as well. Yes. So very, very proud to have you, sir. And when you say it matters the most, you teach almost more than 2 lakh doctors across country with your platform. So you're a very, very important voice. My question to you is too, when everybody across country who's studying medicine, who's preparing for PG and wants to understand from you, from a medical education standpoint, are we preparing doctors to critically evaluate AI or merely just use it? That's one part. The second part is, why specific AI competency should now be mandatory in undergraduate and postgraduate medical training?
Thank you, Dr. Rahul and Brigadier Gupta, for having me here. And it is such a pleasure to talk to all of you today. And I have been an educator for last 25 years. And in the last 6 months, I've seen a massive shift into the way we are working. I'll give you an example, and it is mind-boggling, and I think everybody has to see how it works. Earlier, my day as an educator used to be, I have to give a lecture, then I have to create a synopsis of the lecture, I have to create notes from the lecture, I had to create a mind map or something for the students, a post-class test. Now, for me, on my own app, it happens automatically. Now, I give my lecture. After the lecture is delivered, everything is created for me. There is a synopsis, there is a golden points for the students, there is a mind map for which he can follow based on my own lecture, and a test that is given to the doctors. And now I find myself free. What do I do when I'm free? Now, because I got free, I decided that I'll talk to all my students every day on the mobile app. Now, I want you to extrapolate this thing for everybody now. Technology would free you. Then what would you do? Then you bring back the human touch that is more valuable, and then the skills like you said, decision making, critical thinking, and probably we might have to redefine the entire medical education itself. So far, all of us doctors are looking at knowledge as the moat. Like we think, I know, you don't know, I am valuable. Now you also know, I also know. What is more valuable will be my ability to make a decision, my ability to say critically, why not this? And that is very important. And I feel, I have seen this groundbreaking thing happening, that whatever I thought I bring to the table, I bring to the table the ability to make up paper, ability to predict the questions, ability to tell them what is it. Now it is all available. So what do I bring to the table? So we all will have to think it, and that is how the education would evolve. And coming back to your second question, we definitely would need AI literacy in every sense of the word. But even beyond that, we would need human literacy. You know, technology would do everything. What about us? Decision making. Decision making. Am I ethical enough? Can I say yes or no? That, I think those were the big questions for future.
Thank you for making it very, very simple. And again, we all echo that we'll have to learn AI. That's the need of the hour. Going down to our another panelist, Dr. Avnish Khare sir. Sir is an MBE faculty from Government of India to teach AI to doctors. Very celebrated faculty across countries. Sir is an anesthetist. I have got two questions from sir. In the respect of time, I am just combining the questions. In anesthesia and the pre-operative care, where every second matters, where does the AI and where does AI add the real value today? And where should clinicians clearly rely on this or not? So when it is all about life and death, should we use AI, or what is the answer to it? That's the question.
So thank you, Dr. Rahul, Brigadier Gupta, JIMS and BFI for having this kind of an event. And it's really great to see that we are in the middle of the expo, and we are like at the heart of the event, just like JIMS Incubation Center is at the heart of the hospital, which I saw yesterday. That is where all action happens. I have been educating, and many of the colleagues of mine are in anesthesia, critical care and pain management. That has been my background. So this question always comes up, that where can AI be used, where I can use it immediately, where can I use it in future, can I rely on it or not. So I think it's to think of it in a structured way. Anesthesia, critical care has always been a field which is like based on life and death decisions. And AI is good at two things, which is classification and prediction. And this is the two things which I feel an anesthetist is doing 99% of the time. They are either classifying patients, they are classifying airways, or they are predicting whether any complications would happen inside the OT, outside the OT. So I think the immediate areas where AI can help us, and we should definitely rely on it, especially in the pre-operative kind of an environment where you are trying to assess and make a classification, whether it's a difficult airway. We have some measures which are quite subjective. So we have the Mallampatti scoring, for example. So I tell the patient to open the mouth, and I say it is Mallampatti grade 1. Someone else will say Mallampatti grade 2. and there's no objectivity in that, right? So AI is a tool which can bring objectivity to such things. Then predicting which patient will have post-operative nausea, vomiting. So maybe I can give some better prophylaxis to that patient. This is another example. Moving to intraoperative. Intraoperative is a field where, like, it's like flying an aeroplane. Like, if everything goes right, it's absolutely boring. And if something happens, that is the worst day of your life sometimes. So it's like that. So if you have some kind of a co-pilot with you, just like autopilot or some kind of a tool which is giving you insights in real time from the data, but a lot of data is coming in. We are looking at so many monitors, just like a pilot is looking at so many gauge, fuel gauge, altitude, all those things. So if something can filter those insights and give me actionable kind of information which I can act upon in a small amount of time, because every second matters, is where another area of AI comes into anesthesia. And finally, the post-operative, where again, when I send a patient from the OT to the post-op area, I am always worried whether the patient again needs some kind of an ICU or maybe the patient might develop a complication in the post-op area. So if I have some kind of a technology which can classify or predict these same patients, that okay, this patient is more prone, this patient needs more eyes, or this patient needs continuous monitoring even in the ward. So all those things can help making anesthesia and perioperative care safer. Finally, not relying where you need split-second decisions. There are a lot of situations in anesthesia critical care where it's about, like, if you don't act within the next second, patient is gone. Please, the technology right now is not so well developed. It's all, of course, evolving, but to place those decisions, like flying an aeroplane, you have to decide whether I should cut off at this point or not. We still need more, better, reliable, validated AI, of course with clinical trialed in those situations, whether they perform in our population or not. Then maybe we will be able to use hypoxia. Please follow the basics. Don't wait for any AI tool at that point of time. This is what I would say.
Perfectly said, sir. That is where my director also says that it is medical science, right? But when we practice it, this is an art. So studying medicine is a science, but practicing medicine is an art, which nobody can take away from you, right? That's very, very important. Next we go down to Dr. Harsha sir. Dr. Harsha sir is a pediatrician. He has been into clinical practice for a long time, and also he is helping in the capacity building of clinicians. I want to understand from you, sir, in pediatric care, when patients are vulnerable to, there's a constant layered and delay. What ethical safeguard must be in place before we use AI?
Okay, sir. Thank you.
Or let me reframe it from the last part of what sir said. What should be that cut point, what he talked about? In a pediatric care, where there's a multi-department coming together, there's a delivery and immediately after post-delivery care, right? When multiple departments come in, where do you see that, no, yeah, this is where we leave AI outside my patient? You're happy? Because patient has come down to your OPD with your experience, to get it treated with your acumen, right? Is it not quackery to use, and very important, is it not quackery to use unrecognized AIs?
Thank you for the question. And first of all, I would take it like that ethics is taken as a speed breaker. अगर किसी स्टार्टअप वाले से बात कर लो, they will ask कि ethical वाले तो ना रोकने के लिए आए हैं. Am I right? But I'd say that ethics is a speed breaker, yes, but with the help of speed breaker only you can run Vande Bharat. If you don't have the covers technology, you can't run at speed. Like a mother explaining his adolescent child that your father used to scold you for all the things because he wants you to reach at heights. Same is with that. If we start using AI without applying the principle of ethics, without the regulations, you are going to cause disaster. That is a fact. And in pediatrics, what is mostly extrapolating adult data. Adults में पिप्रासिलिन लग सकता है, बच्चे में लग सकता है, just dose modify कर लो. It happens, but it is not possible with AI. AI is going to be data biased. It needs pediatric trials. It needs specific age group trials. You cannot just extrapolate कि adults में हुआ है, so it will be working in pediatric also. So there is much strict need of ethics, especially in pediatric practice, as you are saying. And the immediate decision making, I don't think AI is going to help in near future. It is going to help in maybe the elective decision making. It may be going to help when human in the loop is there. It will never be that AI is saying कि ये intubate कर दो. It will always be human in the loop. He will applying his mind, taking the help of AI and then taking the decision. So ethics is a speed breaker, yes, but endorse it with whole heart and you will go at a higher speed. I would say like that.
I have another question just follow to it, because you teach AI to doctors. In the clinical practice, how does a doctor understand, for example, somebody has come down to my OPD and wants to sell me a AI tool that this will, is going to help you out. ये post op care बड़ा अच्छा कर देगा, right? How do, as a doctor, ask few questions? For example, अगर आप पूछते हो कि आप डॉक्टर हो कि नहीं, तो पूछते हो कि भाई लाइसेंस नंबर क्या है, किसी मेडिकल काउंसिल में रजिस्टर्ड हो, डेंटल काउंसिल में रजिस्टर्ड हो. AI में क्या सवाल पूछने चाहिए उन डॉक्टर्स को कि अनरेगुलेटेड प्रोडक्ट मार्केट में नहीं है? I want to understand from, because you run your own center, IVF center as well. As a clinician in the private healthcare setting, जहाँ रेगुलेशन बहुत आप पे मैंडेटरी नहीं है कि आपको जेम से खरीदना है, you'll buy with the जो भी पॉसिबल है. How do you as a clinician put it up कि यार ये जो है ये पेशेंट सेंट्रिक है, एथिकल है, आप हेपा क्लियरेंस है नहीं है, ट्रायल लाइसेंस दिखाओ, क्या क्या सवाल पूछने चाहिए? That I want to understand from a very layman perspective.
Sir, I am sorry to say, but doctor will not ask this. This is the work of you people as a regulatory bodies. You have to ask it, and when you are an administrator, you have to ensure that technology should be invisible. If you ask doctor to change की practice, तेरे को पेन ऐसे नहीं, पेपर ऐसे रखना, he will not adopt it. As a regulator, as a developer, you have to develop technology like this कि डॉक्टर को अपनी practice change नहीं करनी है. It will be an invisible, like UPI. Google Pay चल रहा है, but backup में कौन कर रहा है? UPI. But nobody knows about the national digital system and all that. That should go behind the scene. And I tell you, no doctor is going to ask this question कि तेरे पास क्या है? That is the work of the authorities. That is the work of you people and the government कि regulate करके देना है या नहीं देना है. The doctor will just ask कि मुझे मेरी efficacy कैसे बढ़ेगी और मुझे कुछ change तो नहीं करना पड़ेगा. These are the two questions that doctor will ask. As a private practitioner, you are asking specifically. He will not ask about the compliance issue. He will not ask about the certification. It is that your duty कि market में आने देना है या रोक के रखना है.
मैं समझ गया. आपके क्वेश्चन का एक और सवाल है. इंडिया में we have CDSCO that governs everything. Software as medical device, hardware as medical device. Now we have hospital-based incubation center. ये सारी चीजें हैं. मेरा सवाल आपसे अभी भी ये है कि in a AI world, data is everything. Now there are two ways of getting data. One is coming down to James, facing me when I tell him all these regulations, research committee, ethical committee, PI, and will not do it without this. एक ये है. दूसरा है ये सेम बंदा आपके क्लिनिक पे जाता है कि सर मैं डिप्लॉय करूंगा, आप बस यूज करो ना, पेशेंट वहां से फीड हो गया. अब ये मार्केट में कहता है कि हमने जी ये तो वैलिडेटेड है, इनकी क्लिनिक पे किया था. This is what is happening in the market. How do we tackle this? A very practical problem.
That's what I want to say. It is not my duty. It is the government duty to regulate it. कि वो मेरे को किसने लाइसेंस दिया कि मैं कर सकता हूँ? मेरे को सिर्फ DPDP ने बोल दिया कि तेरे को de-identified डाटा देना है. That's it. बट मेरी बात की वैल्यू कौन करेगा अगर डॉक्टर राहुल का स्टैंप होगा तो. Okay, so there must be some authorities with the power. I don't have that power. I may be a trial point, taking the consent from the person जिसका मैं डाटा यूज करने वाला हूँ, but I cannot say कि मेरे यहाँ पे .ai वाले ट्रायल करके गए हैं तो you can use it in the world also. हाँ, डॉक्टर राहुल की स्टैंप लगी है, डॉक्टर गुप्ता की स्टैंप लगी है, then you can use it because that is by a certified agency. I think I'll take it in that way. This is the most practical thing I'm telling.
No, sir, I will just want to add what you said is partially right. See, we are all government. Government अलग से कोई entity नहीं है. We all form the government. इतना फर्क है हम थोड़ा इस तरफ बैठे हैं आप उस तरफ बैठे हो. But it is everybody's duty in the interest of patient. Right? Please do not use unauthenticated चीजें. यूज है तो लाइक दे ऑल्सो कम टू अस कि सर हमारा वैलिडेट करा दो या हमारा ऑपरेटर यूज़ करो. मैंने कहा कहाँ यूज़ हुआ है, कहाँ पे इसको वैलिडेट हुआ है, कहाँ की फिगर्स हैं, पेशेंट डेटा आपका यूरोप का है, बाहर का या यहाँ का डेटा हैज इट बीन यूज इन द गवर्नमेंट इंस्टीट्यूट, है ना. व्हाट इज़ द एविडेंस, व्हाट इज़ अगर आपका कुछ है एविडेंस तो कोई पेपर पब्लिश हुआ है क्या इसका. सो दे आर वेज एंड मीन्स विच ऑल ऑफ अस हैव टू हेल्प इन द गवर्नमेंट टू द गवर्नमेंट so that actually जो good product should come to the market, not कि कोई भी बना के ले आए and that we use.
I fully endorse you. Just want to add that will depend upon my ethics. Maybe Dr. Anish is very ethical. मुझे लगता है थोड़ा सा कर लेते हैं यार. There is no regulation on me. There must be the regulation must be there, and you can't rely on मेरी ethics. मेरी ethics आज मूड अच्छा है, आज मूड अच्छा नहीं है. But Dr. गुप्ता के ऊपर 4 बंदे बैठे हैं. If Dr. Gupta is putting a stamp, there you are responsible to someone, and I am not responsible to anyone. This I want to say. So your work increases, and of course, मैं जब तक ethical हूँ ठीक है, but अगर मैं ethical नहीं हूँ तो फिर क्या करोगे? Yeah. Then only because you have to answer to someone. मुझे क्या, मुझे कुछ नहीं करना, मैं फायर नहीं, मेरी बात पसंद निकल जाओ, मैं वो रख लूँगा. So there must be some regulations. Regulations are must for developing as a society. You cannot develop a society based upon someone's ethics.
तो इसको हम ऐसे समझे कि we need to have more capacity building of clinicians to understand it,
Yeah.
which we are doing.
And the regulation.
Yes. Regulation की भी हम capacity building करें कि आपको ये पता होना चाहिए.
Yeah.
That's very good. Okay.
Thank you.
In the interest of time, we'll directly go down to Madam Anita Lakshmi ma'am. She is practicing gynecologist in Chennai. She also heads IVF center. I want to understand from ma'am, AI has the power to either close the care gap or deepen them. How do you move from equal access to a truly personalized and equitable care for women?
So, hello Dr. Rahul. Thank you for giving me this opportunity, this wonderful panel. Thanks to Dr. Rakesh. It's nice meeting Dr. Simar Sethi, Dr. Avanish and Dr. Harsh and Dr. Abhi Chatterjee as well. And I would say I'm extremely honored and privileged to be sharing the stage with Dr. Sadhan Sundaramurthy, who is my very own mentor. He is a very important person and policy making in education, and it's so exciting to see you implementing AI in medical education as well. So people are talking about IPR. I would so proudly say he was commemorated on the Republic Day for the highest filed IPR in India, if I'm right. So privileged to be sharing the stage with you. So coming to your question, Dr. Rahul, to differentiate between what equity and equitable precision is. So what equality means in reproductive medicine in any clinician is, a particular door being available for each patient, a particular process, a system being available for each patient. An equitable precision is something that is built for that patient. As clinicians, we would see the same treatment doesn't work for everyone. We would see a patient with no complications end up with mortality, and with patients whom we think high risk would walk out of the door very easily. Even as an anesthetist, I think Dr. Avnish will see a lot of patients. Let it be a wonder to see patients like this. So how do we bring equitable precision to treat our patients is what, the augmented intelligence of AI should help us. So, for example, I would say, I had a patient who had 3 IVF failures, and when she comes to me and all her embryos are normal and I still transfer an embryo and she still becomes negative, I don't know what to do next. So we try reproductive immunology, we try AI to decide her embryos. So this is an affordable patient with her husband working in an NFBC, so she can afford whatever I ask her to. But when a similar case comes from a remote village in Kanchipuram or somewhere in Tamil Nadu, I cannot offer these treatments to these patients. How will she afford this? And if you're going to give me a tool that's going to be very expensive, which I can only give to a patient in a corporate setting, definitely this is going to increase the gap. It's going to widen the gap. And now that I don't know, even if AI can choose an embryo for me that has the highest implantation potential, and still the patient becomes negative, IVF negative, it's on me, it's my responsibility to explain to the patient why it became negative. I cannot just simply say on her face, no, AI asked me to choose the embryo, and she would ask why. It's the clinician's responsibility to tell her why it was negative, why I chose AI to choose the embryo. So as clinicians, it's our responsibility to, rightly use AI. The right clinician will know when to choose AI and when to put AI down. It's not as easy for the clinician as the technocrats is. So I think all our panelists will agree on that. So when it comes to equality and equitable precision, we want the technocrats to build systems for us that will help women across our country, our demographics. Now we have tools that are built, data models that are built on Western population. How can I use that data that's been built on Western women, women in New York and London? How can I use that data? How can I imply that models in women in our own demographics? We see, patients vary across demographics. Patients in Chennai are different, patients in Delhi are different. Our culture is different, food, BMI, all contexts are different. How can I use Western models to our patients in villages? So it's not easy. So we want AI that will diversify data, which will give us specific models which we can imply the outcome as well.
Again, it comes to the trust part of it, right?
Yes, sir.
Thank you. Trust is very, very important, and then if at all we think the AI as the bus, the driver is the doctor. So that is where again I come down. The first panel was it has to be doctor driven. The second panel is it has to be doctor driven, and the upcoming panel at 1 to 2 will again be it has to be a doctor driven healthcare system when we use AI, because paracetamol cannot be different for my father and for your father, right? It has to be a paracetamol, right? That's very, very important. In the respect of time, we'll again go down the Mr. Sarvana. You have been seeing the ecosystem right from, IT Madras, entire research park grew, where you have also contributed in making up the research park. How do you see the deployment in the clinical setting as a challenge?
First and foremost, thank you, Dr. Rakesh, Dr. for the wonderful opportunity and the visionary steps that you are taking. Even yesterday in my official note, I have mentioned about this and shared it with rest of the colleagues in the industry as well. Right? This is very, very transformational, and it is going to be a key role that you are playing that can transform how AI is utilized, as Dr. Rakesh said, how it is augmented in a much more beautiful format. If I answer a question, aligning it to the utilities, like you also quoted, it is like electricity, it is like water, but the utilization has been in a much faster pace. The way electricity took maybe 100 years, right? Other things like even usage, waiting the pipelines of water, everything took hundreds of years. Whereas even internet as an utility took even 3 to 4 decades. But when you look at AI, it's less than a decade. It is less than 4 to 5 years what we are today. Though the research started, the adoption I'm talking about, right? So how do we structure that around? So electricity is the same for everybody, whether you are a doctor, whether you are an engineer, you are a manufacturing unit, it is the same. You may need to only amplify it with the transformers and so. But AI is going to be unique for clinicians, it is going to be unique for a lawyer, it is going to be unique for different professions. And the most important thing is, how do we the most
water board, something from the government. Every state government and institutions like you to be part of it and regulate like what the other fellow panelists were saying. It is not the duty of the practitioners to be bothered about the ethics. That should be regulated. Nothing that the power and be worried about position of the panelists will not be able to talk about what we can do. So there has to be a responsibility that has to happen. So that's how we have to build the environment. AI is in place. It is everywhere. How much of that we are going to adopt it, how much of that we are going to be consciously doing it, is going to define the success and going to be a collective success and the progress of not just the profession, like the clinician or the patient, but as the industry as a whole. So that would be my 2 cents on that.
Thank you so much, sir. We go down to the last part of the session. Abhik Chatterjee. Abhik Chatterjee is Director BFI Innovation Hub, IIT Dhanbad. Abhik, from you, I want to understand how can innovation ecosystem encourage more clinician-led AI development instead of purely tech-driven solutions? So we see more of techies making AI solutions for doctors. What method, processes would it require where we see doctors making these technologies, contributing to technologies?
Yeah. So good afternoon, and thank you BFI, GIMS, and Center for Medical Innovation for allowing me to speak here. So even before I answer your question, I would take a minute to there were a number of people who were telling that among the panelists itself that it is AI who is going to be driving around. It is actually the other way around. It is AI is in that current phase where it is learning from you. Like let's say what I have heard is Dr. Sumir Sethi, that is you have been a mentor to a number of doctors. Now at some point of time the day arises when you become the patient and you happen to be treated by one of your patients, one of your students directly. So AI happened to be something like this. So AI is data driven, which the data that has been collected upon your teachings itself. So AI is not away from us. AI is our day-to-day activities collected in a data form and then predicting for us. So just like someone was telling that at one point of time should we let our aircraft be controlled by AI. So as far as 5th generation aircrafts were concerned, it was about stealth. When 6th generation aircrafts came into being, it is pilotless. So we are ultimately allowing $1 million aircraft to be flown by AI. So we are trusting. So, but then now, I'll not divert away from my question. I will just get back to my question over here directly. We need to be trusting the. Am I audible? This mic is working fine. I feel somehow I am hearing myself anyway. So that's fine. But what I feel is, can you just since I had to mention all of this, I somehow got diverted from what your exactly question was.
Sir, you come from BFI Innovation.
Right.
I want to understand now. People are making technology, AI-driven technology, training with our doctors and coming down and selling to us.
Right. I could not connect it because I got diverted. I got your question right. So this is a problem which is not. This is. I do not have. So neither. Okay, fine. So.
बहुत दे रहा है उनको दे रहा है नहीं आवाज नहीं मार नहीं सर टेक्नोलॉजी इज इम्पोर्टेंट
Technology is important. No, don't bring another one close by. Yeah, so Yeah, that was good. That was good. So the thing is, what I have done for my center is, instead of like developing technologies right from the scratch, what I have mentioned in my particular website, that these are the industry problems. Develop technologies that can directly address those. So what you just mentioned is, without the doctors, I cannot dream of a technology that has been like generated through AI, where the doctor's skin is not in the game. So it has to be like a doctor is definitely a stakeholder when it comes to AI solutions developed for it.
Okay. Thank you, Avik, so much. And going toward the very last part of the session, I'll go down to my own director to understand. Should every hospital establish a formal AI ethics and validation committees? Because access to ethical committee, access to research committee is so tough in the country. When we see our own startups, when they want access, the reason why we created India's first AI clinic in a government hospital was, you do not know whom to talk to. Who would be my PI? Will the institute allow me to get into the research committee? Will I be present? Will they allow me access to the ethical committee? Do you think that should we prioritize this for keeping AI startups in the core of it?
See, this medical incubator and AI clinic, we all should make it, but not the ethical. As Dr. Bharsa said, ethical committee is a break. And I remember when I established my ethical committee, we appointed an professor from UCMS, and all faculty, they came to me कि सर आपने इनको क्यों बना दिया है, हमारे कोई प्रोजेक्ट नहीं पास होने देंगे. And sure enough, उनका I used to personally attend it, and before going to the ethical, he used to go into the scientific, and then ethical, and not one go, probably it takes 2 to 3 sittings when the project is cleared. But at the end of it, the foundation he laid down in our institute for the ethical committee, I think we still remember, because those projects are, has been published in high impact journals. Those projects we are worth, doing it. So I think ethical committee, we should very deliberately, the person actually heading the ethical committee has to be a very, very, reputed person, not that everyone, makes a ethical committee. So I think we need to keep it in mind. Quality is important, quantity is not. So in the interest of patient, ethical committee should be made by the reputed institution, by the reputed, chairpersons, so that actually good scientific as well as ethical outcome should be much, much better.
Perfectly put together everything that yes, AI is important, regulations are important, and we as public institutes will have to create access window for startups. GIMS as the medical incubation center in Uttar Pradesh is already doing it. We have a single window system. You come to the incubation center, we give you the access to everything. And very recently we have added a AI expert to the ethical committee. So everything that as a startup you need in the country, we are not less than France, we are not less than anybody else. We're right here, India has arrived. So that's the statement, that India has arrived, and we arrived together along with the President of France. To the closing part of it, AI must be doctor validated and work integrated. Governance and IP frameworks must evolve alongside innovation. Equity must remain the center, not an option. India has scale. France and US brings regulatory and research depth. Public hospitals bring real world complex, and we have the largest network of public hospitals here in the country. If we can co-design responsibly, India will not just do AI adoption, India will export patient-centric AI to the world, and that was the theme of the day, the AI for the world right from India. Thank you so much. Thank you all the dignitaries for again making the theme very popular. One theme which GIMS believe, AI has to be ethical, patient-centric, safe, and very important, doctor-driven. We say it very loudly. Thank you so much. Toward the last part of the session, as token of love, we invite Dr. Sumer Sethi sir. Gaurav sir, can you please join us? So Dr. Gaurav is again a big shot clinician. We celebrate him as a clinician first. He's also the CEO for BFI India. यार एक मिनट आप चाहे बीच में आ जाओ पिछली फोटो में भी ये गड़बड़ हुआ है बहुत टेक्नोलॉजी यूज़ नहीं करनी है सब एक ही जगह देख पाए हम लोग वरना 4 जगह देख रहे होते हैं तो टेक्नोलॉजी शुड नॉट बी डिस्ट्रैक्टिव प्लीज केशव यू कैन गो अहेड यस फोकस ऑन Next we have Dr. Avnish Khare sir. Next we have Dr. Harsh Bayana sir. यार डॉक्टर ड्रिवन ही बताया तो पहले डॉक्टर को मना कर रहे हो सर आप यहाँ बैठे नहीं वी कैन नॉट कॉम्प्रोमाइज ऑन दिस हैज टू बी हाँ नेक्स्ट वी हैव अनंता लक्ष्मी मैम can you all come close? Next we have Dr. Mr. Sarvana. And we have Mr. Abhik Chatterjee. Thank you. So we'll have a group picture together. Dr. Rajesh sir, can you please join us? Sir, please join us for a group picture. Thank you so much.
Well done.
We again meet from 1 to 2 where we discuss what we do at the GIMS AI Startup Clinic, which is country's first AI clinic for AI startups in the country. We'll be talking about the regulatory challenges and specific to the software as medical device. See you at 1 o'clock right here. Thank you.
Hello, check. Hello, everyone. We have a panel here. If you could all please settle down. People in the back, please, if you could join us. Please take a seat.
Hi everyone. We are starting the panel now, an exciting one. Request everyone to please take a seat.
I will start. We can start.
I think we should.
Right. Hello everyone. So today we have here with us women leaders who are building impactful and inclusive AI. Our today's session is called Women Advancing AI. Now, our panelist is Dr. Geeta Manjunath. She is the founder, CEO, CTO of Niramai Health Analytics, developing thermoanalytic and AI-based non-invasive radiation-free breast cancer screening solution, accessible for early detection in low-resource setting. Next, we have with us Ms. Veena Muktali. She is the co-founder and CEO of Periwinkle Technologies, focusing on AI-powered medtech solutions like the Smart Scope for real-time cervical cancer screening and remote diagnostics in resource-constrained areas. Next, we have with us Dr. Kritika Rangarajan. She is the Associate Professor at AIIMS Delhi, specializing in as an oncoradiologist and data scientist with a PhD in deep learning in medicine from IIT Delhi. Her work centers on AI applications in healthcare, including extending care to underserved areas and enhancing doctor-patient interactions. Next, we have with us Anusha Purushottam, my bad. Anusha Purushottam serves as the head of health systems and policy at Remedio, a health tech firm pioneering AI-driven health innovations in primary care and population-based service delivery models for eye care and systemic health screening. Next, Dr. Renu Ithirajan. She is a hemato-oncopathologist with over 20 years of experience and serves as the chief medical evangelist at Sikh-Tirtham, where she promotes AI-powered digital pathology solutions for diagnostics. Now, the moderator for today's session, Dr. Shweta Jinjal. She's a dedicated pediatrician and public health leader with over 15 years of experience, advancing women and child in low and middle community countries. Currently, she is the chief of party for Johns Hopkins UP Health System, strengthening project and program direction at BFI for the MedTech Incubations program. She drives strategy, interventions, capacity building, and evidence-based research in Uttar Pradesh. Over to you, ma'am.
Thank you, Priyal, and for setting the tone of this panel. And good afternoon, everyone. Welcome to this conversation. Thank you for taking out the time for it. And I'm very pleased and excited to have all these wonderful powerhouses, women, all under one roof. Well, technically not a roof, but surrounded by these walls. So big hand to all of them. I'm personally invested in women's leadership in healthcare a lot. So this means a lot to me for you all to be here today. So thanks again. And I know everybody wants to see and feel the AI Summit as much as possible, and you all are busy as well. So without further ado, I'll dive right into the conversation. This kind of panels, usually I'm not sure whether I should be feeling happy or disappointed in saying that. It's not common, let's say, to see panels exclusively with women leaders, and therefore, I want to take a moment for all of this to sink in, and I hope that this can continue to be a practice rather than the exception in our space. So I'll start the conversation with you, Dr. Geeta. Farthest from me. Dr. Geeta, as Priyal introduced, is the CEO and founder of Niramay Health Analytics, which focuses on non-invasive screening of breast cancer in low-resource settings. So, Dr. Geeta, firstly, I want to understand from you, and why don't you share with our audience here as well, what prompted you to take up this journey as an entrepreneur, and what has been your biggest lesson, throughout your journey as an entrepreneur here in the health tech space?
Hello, can you? Thank you very much for the invitation on this wonderful panel. My journey into AI per se started off long ago, maybe 30 years, 25 plus years for sure, where I did my master's from the University of Science. Then I started working in Hewlett Packard Lab as a scientist, a principal scientist, working both for India and the US. 17 years there, and then I was head of AI to Xerox Research Center. The wonderful team of 100 plus young, smart engineers, and my role was to obviously mentor them. Of course, I did my PhD from IISc as well, and the specialization in AI. And then, so it was a wonderful journey of innovating for the future as a part of the Xerox research, leading AI at that time, as we were discussing, probably AI was definitely not as well known as it is today, right? It was very good. We were looking at use cases of AI, not just in healthcare, definitely healthcare, but customer care, transportation, and so on. Everything was going well, and suddenly I just heard from that one of my very close cousin sister, Bharti, got detected with breast cancer. She was 42 years at the time, and it was late stage, and within 6 months after the surgery, it triggered and she passed away within the year. She had done mammogram, and she had difficulty in detecting it because, there are limitations that mammogram can only be effectively used about 45 years and so on. So this was a trigger to start the research in my lab itself. And then when I was doing this as part of 30 other projects, obviously I was not able to give. Then after some time, within 3-4 months, I lost one more family member on my husband's side. She was 38 and she died on her son's birthday. And this again was a dangerous issue on young lady. And so that's when I decided I can't be just sort of, being part of this whole corporate and do this as a side activity, and it requires more attention. And I quit my job and started Niramay. Again, of course, I knew about breast cancer only as a patient, and of course I started discussing with radiologists and so on. But then last 9 years has been only radiology, oncology, conferences, books, friends, and understanding, I went to a course to do mammogram interpretation, MRI interpretation, and so on and so forth as well, because unless you delve into it, like you don't understand the plus and minus and how to sort of position it, etc. Having said that, I'm very glad to let you know that over the last 9 years, Niramay has now become a top 20 technology pioneers in the world as per World Economic Forum, and that's how we got this BFI. Several other awards. More importantly, while I was a technologist and looking at it as a research, the entrepreneurship actually, as a journey, right, made me take this, how do we sort of take this idea to the ground and make it really be used in real life conditions, in hospitals for sure, but really where we can take it to the underserved areas and then make it used in the real field. This is something that, it's a major learning, and it's not just about tech, it's not just about fun, it's figuring out what are the gaps, fixing, and so on and so forth. Second big thing I had to learn coming into an entrepreneurship in healthcare is, of course, as researchers, we do a lot of evaluation, experimentation. As scientists, we know what should be the objective, how do we do it. But clinical evaluation is also so beautifully well established, the processes for it, safety protocol, etc. So understanding that and figuring out how important clinical evaluation is before you take AI algorithm and really call it a medical device. There is a whole journey there, retrospective studies, etc. So that has also been a great journey. Of course, raising funds and, starting to do it when you just quit your job is fun in a different way. But the best moment really, Shwetaji, is many places I get on from the stage after talking, and I have people waiting, and I've had like 2-3 occasions. She comes in and says, I came here not to ask a question, but just to thank you that my mother detected cancer because of this test, and she's had all the treatment, and now she's well. And I get the call on and off, and it's really, really fulfilling. It's already worth it. And if any of you are thinking of doing it, reach out to me. I'll tell you some tips. Thank you.
Thank you so much, Dr. Geeta, for taking us through this journey. And what I've realized is that behind every such momentous journey, there's always a personal story. And that was the story for you. And the world benefits when women like us, we respond to the stories that are going on in our lives with empathy and intentional action. I think that's a message for all of us to take home from what you just shared. So moving on to Veena. Veena, you're the founder and CEO of Periwinkle, and very pleased to have you here with us today. Similar approach, and I would like to ask you about, how through Periwinkle, and I know we spoke about your journey into entrepreneurship and what brought you into Periwinkle. So why don't you tell our audience today a little bit about how Periwinkle as a product is aiming to bring equity in healthcare. We spoke about it, but I want this story to be broadcast for the audience.
Sure. Thank you so much, Dr. Shweta, and I'm really happy to be here. Thank you for giving an opportunity to tell my story as well. So the story of Periwinkle began when 12 years ago, when I was doing research with Tata Cancer Hospital in Mumbai. I met a woman who had traveled from Manipur to Mumbai to get her cancer treated. And as I spoke to the doctor, the gynecologist, she said that cervical cancer is one of the few cancers that can be detected at a pre-cancerous stage. And it can also be treated with methods that are not really very invasive or very expensive. So if it is detected at an early stage, that would be really a big boon, because almost 50% of the women who reach healthcare facilities with cervical cancer don't have a chance to survive. The prognosis is very poor. And India sees one death every 8 minutes because of cervical cancer. So worldwide also there are lots of deaths, especially in low and middle income countries, because testing methods like the pap smear or the HPV DNA are not really built for public healthcare. They are not built for population screening, that's one. They're also subjective. Sometimes they are also not applicable to the particular women's age group, and we know in India the age of marriage is pretty low. However much we try, still women continue to be at risk for many years before they even get tested, and the testing is even less than 2%, right? So in order to make this a scalable, and we are talking about equity here, that means geographical areas in countries like India where there is very poor outreach or poor access to healthcare facilities, can women really find something in their neighborhood? Can women really avoid going to tertiary care centers like the Tata, just to get themselves tested? And can this happen at a regular and early stage, rather than when the symptoms start showing, which is much later? In fact, women start seeing symptoms of cervical cancer when it is already at stage 2 or stage 3, which is really a sad thing, because there are mechanisms to do that earlier, such as the smart scope. So that's why we decided to focus on making an AI, building an AI into the device, right? So there's a handheld device which even a nurse midwife can use very easily. And we have built it on the principles of colposcopy, which is already an accepted technique in the medical practice. So a nurse midwife can perform colposcopy using a handheld device which does not require any infrastructure. Plus, there is an AI built into it which gives her the guidance like a colposcopist. So that is something that helps transform a 30-day multi-visit protocol into a single visit where within 30 seconds she gets a report, right? And even if it is, not really cancer, but she's at risk, she still gets to know that from the AI. So that's the value of that AI that we wanted to bring out.
Thank you so much for taking us through that, Veena. And just to give a very brief overview about what Veena spoke about, cervical cancer is one of the biggest killers for women in India. And as you rightly said, diagnostics for cervical cancer are not really made in a way that can be easily accessible for women, especially in low resource settings. So we are really looking onwards to diagnostics, which make lives easier for patients as well as care providers. Thank you. Moving on to Kritika. Dr. Kritika, you sit at AIIMS Delhi, which is one of the busiest public health facilities in the country. And I want to know your experience, having worked as a radiologist and in the AI space now for a while. What is your experience regarding and insights on the readiness of healthcare? We are looking at the AI summit here. It's a huge event. It's putting India on the map, as many of us are saying. But really, from a first-hand perspective, what is the readiness of Indian healthcare system at that scale when we see to adopt AI and also to roll it out like from one end to the other?
So thank you first of all, Shweta, for having me here. And I think I'm the odd woman out over here because everyone else is like a founder of a startup, and I'm somebody who comes from academia, so I haven't done, I haven't taken quite the leap that all of you have. So hats off to you for that. I'm also the odd woman out in the sense that I've taken the opposite approach. Began with MBBS, MD, DNB, FRCR, senior residency, and then decided that look, I think one of the triggers there was we see patients every day. So these are everyday stories for us, and there is a social component to every story. There are kids that people leave behind. There are people who travel really long distances. Nobody in AIIMS Delhi really comes from Delhi. People are leaving their own children, losing a day's work, traveling all the way and coming. And we're also very fortunate that we work with a lot of institutes, we work with a lot of industry, we work with a lot of startups. And when you look at the sort of medtech ventures that came to us, you'd suddenly start realizing that, by and large, medtech is built because you can build medtech. That is, you look at, okay, here is a data set. What can I do with this data set? It's much too often that we're not beginning with the problem. It's 2 years, 3 years down the lane that we'll say, I have this product, let me go and sell this to a hospital. But does that hospital need it? I think we haven't asked those questions at the beginning. So my idea of really jumping into medtech was we need to change this thinking. We need to approach it from the opposite side. We need to begin with a problem and not with AI. AI is only a solution and a means to tackle the problem. So that's when I actually sort of left practice for a while. I went to IIT Delhi, I did a postdoc, and then did a PhD. And I couldn't stay away from patients. I think that's where the real impact is. And I came back as a faculty over here. And then we lead several initiatives in AI. But to your question on is the health sector ready? I think it's as ready as the products are ready for the health sector. I think we really need to, if we are thinking that we'd build out a product and create a change in the healthcare system, I think that's not going to happen. You have to make things which are very, very easy to adopt. Why do all of us use DigiYatra? It's because it's easy for us. It makes our life easier. But if we today build an EMR and you go to a hospital like AIIMS and say, I know you're seeing 200 patients in 2 hours. I want you to spend 5 minutes more per patient and make this entry. This is not going to happen. We need to make it stupidly simple for people We need to make the lives of everybody involved much easier, and we need to introduce the stakeholders who are the final beneficiaries in the process of actually designing. And that's been our primary focus. We sort of work together with tech teams right from the very beginning, and we've been fairly, I would say, successful in implementation of. We have several vision-based models which are in implementation in workflows in AIMS, although we are looking at mostly in clinical trial phase. We have several sort of language solutions which are being built out to ease the processes in OPDs. And we have a lot of new discovery sort of systems which are something that we're doing with the kind of very unique sort of system that we are placed in to really understand Indian disease processes. So that's where we are.
Thank you so much, Kritika. So what I hear you say is, one is that the human centricity of the design really has to be at the foremost. So whether it's patients or healthcare providers that the products are being designed for, to take them into to take their buy-in is really critical. And also the journey of being an academician and then turning into that's really impressive. Thank you so much for sharing. Now moving on to Anusha. Anusha, you are leading the health systems at Remedio, and we heard from Anand yesterday at another event, Anand, the founder of Remedio, at another event about how Remedio is transforming the access to ophthalmic care. And I want you to talk about that aspect a little more as to how your product specifically aims to integrate that into healthcare delivery, and give us an example if you can.
Firstly, thanks to the BFI team for even conceptualizing a panel like this. I echo with all the others on the panel as the audience as well. Very often, women are underrepresented in many decision-making tables. So I think this is, firstly, kudos to everyone here. Now, back to your question, Shweta. So at Remedio, we build both hardware as well as AI technologies that help detect blinding conditions, specifically conditions of the disease early. We arrived at this problem statement firstly because traditional ophthalmology requires extremely expensive as well as bulky devices that are electricity dependent and require a specialist or a trained ophthalmologist to operate. And what this means is most people, especially in remote and rural areas, do not get access to eye care, apart from, of course, cataracts as well as refractive errors. So the burden of blindness from retinal conditions is fairly high. So 1 in 6 people with diabetes get diabetic retinopathy. And once diagnosed with diabetic retinopathy, you have a 1 in 3 chance of blindness. So this is also a disease of the working age population. So hence, we're talking about economic costs to healthcare systems, individuals, of course, and then the communities that they're part of. We approached the solution in 2 parts. Initially, we began with developing hardware, so design engineering and building point-of-care devices, miniaturizing existing technologies. Over the past 5 to 6 years, we realized that while optometrists or vision technicians at the last mile or even nurses are able to image patients, they had to depend on teleophthalmology or other modalities to also understand whether they could refer patients to secondary, tertiary centers. And there was a delay there. And many a times we realized patients were coming to primary care centers or vision centers, but then it stops there, right? And the care stops because you don't have enough information, and optometrists are limited by this. So that is when the solution, the AI solution, came as a layer on top of the hardware, where the AI is completely offline, built on the core ML processor of the device in itself, and is able to provide a binary classification. Either the patient has diabetic retinopathy, glaucoma, or age-related macular degeneration, 3 chronic eye disease conditions that are that affect that have a high prevalence rate. And now the optometrist can, or the vision technician or the nurse can then make an instant decision to refer the patient upwards. And then data is also available at the base hospital. So what we've done is sort of enabled an easy, efficient workflow. The design is intuitive, easy to use, not dependent on electricity. So that's the first layer of the AI solution. Now further, we're pushing the boundary a little further. So the retina in itself has the image of the blood vessels, and this is the only access that you have non-invasively to look at changes in the morphology of the blood vessels, which can also correlate with other systemic conditions. So there is literature to state that changes in the retina correlate with cardiovascular risk, chronic kidney disease, neurodegenerative disorders, and others. So in the pipeline are models that we're building for cardiovascular risk, preeclampsia, anemia, as well as chronic kidney disease. So that's early research, and several models have moved along the pipeline. But we're also very proud to say that going back to what Dr. Kritika was also mentioning, we didn't build a product and start going to the community, but we listened to the community, realized that this is what is required, and then built it. The AI didn't come first. It didn't precede the problem. It came as a response to a problem. Thank you.
Thank you so much, Anusha. I think we would all, love to, play a little bit on the product if it's possible sometime.
We are here, so we're at the Meti Pavilion and the Government of Odisha and Andhra Pradesh Pavilion. So please come along and you can look at the product and play along with it. Yeah.
Yes, thank you so much. I think the ophthalmologists and the medicine specialists in the crowd would really be happy to hear that, screening for hypertensive retinopathy, diabetic retinopathy, anemia even is now possible through, looking at the fundus, it's always possible, but to make it more accessible and faster is what we're doing through AI here. Right. Thank you. So, yeah, Dr. Renu, medical evangelist you are, as you say. So I want you to talk about Sigtuple a little, how that's using the end-to-end healthcare workflows at present in making blood smear analysis easier. And also, if you see that, how this can make seeking care easier for people. We've been hearing a lot about the public sector from your co-speakers. So,
right.
Over to you.
Yeah. So, first of all, thank you for having me here. It's indeed a privilege and an honor. And the energy in the BFI Pavilion is definitely very infectious, as I was telling her before the talk started. Hello everybody, I'm Dr. Renu. I'm basically a hemato-oncopathologist by profession, and somewhere I think I was a seeker to go beyond what I was doing behind the conventional manual microscopy. So the 20th century brought in a lot of automation, unparalleled advancements in automation, and that's where laboratory, the face of the lab, changed. But there was still this white elephant in the room, and that is the manual microscope. We all still went back to that. And somewhere I think the first point that I wanted to address is accessibility. And in 20 years of my experience of being an oncopathologist, it was so mandatory for me to be in the lab next to the microscope. So there's no way that you could actually give a diagnosis without physically being in the lab looking at those smears. And trust me, that's a great challenge. There have been days when I have traveled 30 kilometers to look at just one smear, for example, in APML, where patients can actually bleed overnight, and you have to give that diagnosis ASAP to the oncologist. So there are multiple such stories of challenges that we do get to see in the lab. Little things like hemoglobin, little things like platelet enumeration, all of these pose as regular challenges, especially when you're working with chemotherapy patients. Forget about all that, just your basic anemias. When you look at the public sector, even till today, women's health and children's health, nutritional anemia still play a major role. And how do we even diagnose that in real life today, especially where there is resource limited areas and remote settings, right? There's no reach for expertise. There is no reach to get those slides across to an urban center where you can actually give those diagnoses. There are many times when I have got second opinions coming from various parts of the country, incorrectly diagnosed as anemia, and there was frank leukemia just staring at you in the eye, and it's already invaded the marrow and the lymph nodes and all of that. And even that time I was seeking, right? And that time AI wasn't still really around. It was just still so far away into the horizon. And I was thinking that how could we actually get that reach out over there? How could we actually, these questions were always there. And I definitely thought I'm not going to retire from behind this manual microscope, that was for sure. And then came SIGTUPL, one fine day. Just, I think I probably, I sometimes joke and I say that I probably even manifested it, you know. What would it be to actually do something on the other side of the fence instead of giving these amazing diagnoses of leukemia and lymphoma, gray zones and all of that, right? So when that happened, obviously it was a major decision that I needed to take in my life, because I had this comfort zone of looking at, you know, I was a chief of Hemat Onc, I was a chief of molecular, the blood bank and everything. Such a zone that anybody would have loved to have been in. And then I thought, okay, there is no harm in actually looking what the other side gives you, right, and offers, and probably can you make a difference in a little way, in a small way, with whatever knowledge that you have. And I think that's something I really learned quite early, is to accept change and plunge into that. I mean, not have the fear of seeing what would come out of it, but just take the plunge. Finally, if it doesn't work out, you can always go back to practice, right? I mean, you have nothing to lose. But that's a change I never regretted till today. And I think that's been an amazing journey. I unlearned so many things and learned how to work in a different ecosystem of engineers. You know, I was completely surrounded by engineers one fine day, data scientists, and I had to mold myself into see how I could work in an atmosphere like that. But the current thing still was there in my mind. How could you create a change, transform the current area in laboratory practice? And that's where digital comes into place, right? And I'm saying all of this, you know, as we're working, and I was actually telling Anusha as well that we are like horses with blinders. You know, we're doing validations, we're doing product, and then you know, finally when the change actually happens, it actually gives you goosebumps. You know, what you set out as an intention to go out into the first place, and you see that practically happening, and I'll tell you how that happened. So here we are creating classifications for RBCs, WBCs, and platelet enumerations all on an AI-based platform, which is all great, and that's nothing, right? Like that was like ABC. You just put in data and machine learning happens, you're doing annotations day after day, you're doing your first set of validations, you get some good results, not so good results, you're working on targeted results and all of that. But one thing was definitely there, image-based evidence is the confidence that gives a pathologist to work, especially in remote areas, to obviate the necessity to be physically available next to your microscope. That's game changing. Especially today, if you see, you know, I could look at lots of cases from across the world sitting right here with just an internet-enabled device, and I think that's transformed the life for a pathologist too. So what digital actually brought after automation came into the lab was equity in diagnostic excellence. So when we talk about equity, we're looking at different areas. One is definitely accessibility. Until today, I put that right on the top, because the pathologist needs to be accessible to the smears, the digital images, and then the confidence that you get by looking at that, coupled with the AI's results, which, you know, brings about, brings your turnaround time definitely much more lower. The mundane activities, I don't know if there's a pathologist in the audience, there's so many mundane activities that happen in the lab. Let the AI take over that and use your cognitive intelligence for the critical cases where you really are required. So we talked about accessibility, we're talking about process equity. You know, when you're looking at processes in the lab, there is pre-analytical, there's analytical, there is post-analytical. And trust me, a lot of errors can happen across these. So although we are all accredited today, there's CAP accreditation, there's NABL, NABH and all of that, there is still a lot of gaps here, and these gaps are multiple. There are things like unconscious biasness that can set in, the ambiguity of the human mind, the fatigue of the human mind. You know, there was this dialogue in the lab, especially I would say this, you know, evening would come like 8 in the night and I'm like, the slides aren't talking to me. Yeah. They're just not talking to me. Come back the next morning and voila, you know, you just have the diagnosis. So yes, even if you have the expertise, you're human, you undergo fatigue. But what if you could just standardize certain processes, make something consistent? How can you change complexity into some kind of confident decision-making capacity? And that's what digital and AI brings about, right? And then when you see that practically happening, and I'll tell you when that really happened and where I felt that, yes, until today it is my dearest diagnosis till today, where we had done an installation in the Nilgiris for about 50 hamlets of Adivasis out over there. And I was just asked in the initial phases, today there are doctors who are looking at those reports, but in the initial phases I was helping them. And I was traveling somewhere and I got a call from the superintendent, hey, can you have a look at these two cases? They're pediatric cases and we don't know why the child is crying. I said, okay, let's look at the peripheral smear first. And I didn't find anything remarkable there. And then I thought, what about urine analysis? So, basic things like a CBC, a peripheral smear interpretation, a urine examination, till today throws a lot of clues to what you're dealing about before you can even go and think of something like immunophenotyping, flow cytometry, molecular, and all of that. These are your baseline tests. And screening, early detection and screening is what makes that difference, right? So when I told them, why not try the urine analysis of these two patients? Let's just put the urine cartridge and see what that throws up. Trust me, one child had a UTI, there were pus cells, the other child had hematuria. So we had it, and this is real time, happening. And till today, it's my most precious diagnosis that I've ever made in my life.
How
And I hold it
wonderful
very
is
close
that?
to my
Yeah,
heart.
yeah.
So, that's the kind of change and transformation that we are making. And the final equity is in the outcome. And that's the outcome that comes with that. You get accuracy, you get accessibility, and you get accountability because of digital and data, which is, so transparent, which gives you accountability and confidence to make it. And that's how we're changing the scene of healthcare today.
Delivery. Yeah. So wonderful. You packaged it all in one. So we're talking about making healthcare accessible here, diagnostics. We are making it affordable. We are making it easier. We are making it standardized, and we're also bringing in transparency and accountability on the part of the providers. So yeah, it's all summarized for all of us here. I know there was a lot of technical stuff but I think we can talk about that over a lunch, right? Sure. Thank you, Renu. So I'm going to shift the tone of the dialogue a little bit. We've heard about such wonderful products and initiatives that you all are working on so far. I'm going to address the elephant in the room, which is not an elephant now, given that the constitution of this panel. I'm going to talk about, how your journey, and I'm moving on to Dr. Geeta now, back to you. There is a mic, there should be a mic. How, your journey as a woman, and whether for you it has had any impact in your journey as an entrepreneur, leading your organization, being in spaces where you were probably the only woman, and speaking to a space, technology and AI more so perhaps. Most spaces, I would say, which are new in our country and maybe even globally, they tend to be male dominated. So how did it feel for you, and how does that journey, any lessons or any insights that you can share with the audience here, and for the younger women who would love to delve on a similar path?
Yeah, I guess really the elephant in the room, as you said. And it's not something that I'm sure all of us want to keep talking about it, but if we don't talk about it, right, it's like we can't learn from each other, right? So that's one aspect. So typically what I say is, are there biases? Yes. Are there differences? Yes. But I'll start with my mantra. I will say, okay, let them be, let it be, right? But you know who you are. You are a person. So I said, forget the gender and go delve in it. Think about your goal. Think about what you're doing, and that's it. Don't worry. They may be still thinking, but let it not get into your head. So that's in us. We can't control what they're thinking, right? We can't control what their bias is. Automatically it will go through. Once you are yourself, right, remaining goes. So some stories, just to sort of crib a bit, I guess it helps to know what I... When I was at HP, right, full room of leaders and only lady department head and researchers. You really see a computer science researcher, how many? Or maybe I should go even further down. When I was doing my master's, right, in IISc, of course it's a top institute. I love the institute. I feel Saraswati is there in every leaf there. I mean, it's amazing. It's hard to make it. It's the whole room of 110 people. You know where I'm going. I'm the only girl. It's crazy. It's crazy. And I'm not like an outgoing person. In my bachelor's, it was better. I was not talking to my classmate. Like, it's crazy. It was like only girl, girl, girl. And suddenly you go to a class of 120 people and you're one, and you want to ask, you want to learn, you want to ask that doubt, but you have that, what will this person think? How can I stand up and ask? Then I just said, forget it. I've come here to learn. Let them think. And that's when I sort of, said, okay, there's nothing wrong in learning, right? We have the right to learn. So stand up and ask. It used to be very difficult, and I had to sort of remove that sort of fear in my head. So that's when it started. Then after that, of course, in HP, as I was going to say, right, you're a researcher, and you say you want to give an idea. Idea always starts with an I, like it is from a person, like unfortunately. But if that person is lady, there's a lot of pushback, and usually you try to sort of, set the stage for the idea, ye hoga, wo hoga. That's why I came up with it. But as soon as you start saying ye hua, that's why somebody said, he would say the answer. I said, like, what the hell? Like, I'm setting the context to tell the answer. It's just sort of natural that they don't want the sort of the idea to come from a lady. And so then, of course, when you're talking about an idea in a group, it's not fully worked out. You won't know all the answers. You'll know a few of it, few you don't know. And then there are a lot of questions. But if I was putting a question, there are a lot more questions of why it won't work as to why it will work. So this used to happen. Then I said, okay. It used to sort of, put me down and said, okay, let me get all the answers before I share the idea. So I used to work midnight. Crazy I was, right? As some people say, you have to work twice hard to be accepted at the same level. And that's definitely something I've seen during my corporate days, for sure. Same with entrepreneurship also, right? It's a medical device. We have 56 clinical publications. We have a Nature publication. I don't know how many Indian Nature publications of a founder is a lady, but it's okay. Yeah, there should be a start somewhere. Let's do it, and many more people will feel that accepted. But everything is here. Everything is in our mind.
Yeah.
That's all. Like if you want to do it, your focus is the work. Forget the gender.
Right. Thank you so much. Yeah, I think that's the power message that we really wanted to get out of this panel, because when I said lessons on breaking the glass ceiling, I think the glass ceiling will only be broken when we really, as you said, just go for it. Or as the Gen Z here says, you do you. It doesn't matter who's in front of you. So thank you so much for sharing those insights, Dr. Geeta. And so I'm going to now jump, again. And working twice as hard is something that a lot of us women relate with, and being the only woman in the room and ideas getting shot down, you perhaps not being perceived as much of a leader as your peers. So I want to move on to you, Anusha. I know you work in a heavy space, which you transition from a public health career to a space, which is it's a for-profit entity, and you have to deal with a lot of stakeholders. And do share with us, a couple of insights that have come to you through this journey, and that you would want to be able to share with this room. Not just the women, I would say, but also the men folk here, and how we can collaborate together to make this. I mean, we are bringing together this huge event. If we can't work together as two sets of population, I think any amount of collaboration is not going to work. So over to you, Anusha.
Way to put me on the spot, huh?
Yes, literally.
Okay, so I think just maybe like a bit of a backstory. So my training is in molecular biology. I also did a minor in computer science. So similar to Dr. Geeta, I was like there were like 6 female students to 100 male students in my computer science classes, right? So, and that also goes to indicate that STEM majors in general, attract, I'm talking about like 10 years ago, so things have definitely progressed. So setting the context there to say that, being in male dominant spaces is started very early on. And I've kind of had career transitions over the past. So I was working in bench research in labs, and then kind of pivoted into public health, and then moved into health technology. So breaking the norms and being like an outsider is also something that I'm sort of comfortable with now after experience. And so gender is not the only sort of identity people carry. Like there's, like age and language and race and ethnicity and all of these
Intersectionality
layers.
as
Yeah,
well.
a lot of
Yeah.
layers, right? So I used to volunteer in a county hospital in Dallas to, aspirational districts in Assam. So being an outsider, you've got to get comfortable with that. So I think being comfortable with your own skin is something that I think really empowers you. That's one. Second is you've got to have conviction in what you're working on, and also have the ability to handle people who have different and diverse opinions, and understand that people come from various experiences, life experiences that they have. And when you frame it that way, you don't respond to it from an emotional standpoint, but rather you're looking at it very objectively and saying that, okay, how do I then get this person on the same wavelength, and what I'm communicating, how do I help that message land correctly, right? So I think sort of framing all of this in that perspective helps, because I also tend to be like, in government meetings, I tend to be like, young and also like no gray hair and like, a woman. So it gets harder for people to take you seriously. So this helps really like to communicate in a language that people understand, and just really like at the end of the day, we are all human beings. We can connect on that emotional level, like science apart, technology apart. Just barriers tend to exist if we focus on our differences, but just communicating that message has helped.
So thank you. So hearing the same language, we are speaking the same language, sorry, as your stakeholders, whether they are your colleagues or, people in the government who you're working with. So I think that is something that, we'll really have to keep in our mind, and also like both of you are saying, standing tall by your conviction, that really needs to be there. Okay, so now I'm going to bring in the perspective of, the people who we work with and for. And I want to talk to you, Kritika, next, because again, the kind of setup that you work in, I can completely relate with that, having trained in a government medical college myself and worked in busy tertiary care centers. I know it's tough. As a healthcare provider, when we offer any service, whether it's AI or any product, one, I want to really know from you, what is the perspective of, the new age solutions, and how are they integrating the perspectives of the healthcare providers? Most of them are women, as we know. And can we make this a little more equitable in the way it's designed, and secondly, the way it's delivered? Most of the solutions here, right from Dr. Geeta's Niramai to Veena's Periwinkle, they're focused around women, and we really also need to look at that angle of service delivery. But any thoughts on that?
So I'll begin with an area which is totally non-tech, right?
Yeah.
And if you look at, how, for example, breastfeeding is explained.
Yes.
Simple breastfeeding that every woman literally
Has
goes
to do,
through
yeah.
in textbooks. What they'll capture is that it's just very easy. You put the baby on top of the tummy of the woman, and the baby finds its way. And anyone over here who's had a child, how often does that happen? And honestly, I think to me, when I had my children and I had to feed them, I think that was a shock.
Yeah.
And that just goes to say that when textbooks are written by people who don't typically
Don't know, yeah.
experience it, how different your perspective could be of doing the same thing. Having said that, I'll actually, I think Anusha has beautifully sort of put across where some of these come from. And I think they're not deliberate biases. A lot of times it's just statistics. We tend to kind of, absorb what we see around us. And that's possibly just about it. We have, preconceived notions about literally everything, and that's how we navigate through life. and therefore to bring in a more female perspective to things, to acceptability. I think we all as women need to be there in the system, and I think that's the most important thing. And I think they've, beautifully, Geeta and Anusha, both of them, I think, described a lot of the challenges very beautifully. I'll just sort of say one thing additional, which is, I think, as women, biologically, you're just set to face certain challenges in your working age group much more than men do. And I think, effectively as a society, I think shout out to the men who are here in the audience, because I think you play a very important role in actually creating these systems. Unless you participate in creating these systems, there's absolutely no way we can actually keep the women where we are. I've been extremely fortunate, and I would thank my stars for having these systems in place. Medicine, I think, is a lot less gendered in comparison to technology. So I first sort of went into medicine, which is a lot more balanced. But yeah, I faced all of that with technology, and I completely relate to how you must have felt when you step out into technology. And I think the difference starts very early. It's not about what you do in the computer science lab of an institute like an IISc or an IIT. It is when you're on the road and driving, how is it that people perceive you? It is when you give your mobile phone to your son versus your daughter. How much do you appreciate your son for figuring something out? And I think change has to start at that level. We have to start technology equitability at that level. Appreciation of how women can do things very early on at that level. And when women go through these, biological sort of responsibilities, which we do all have to, if we choose to, but I think creating communities and systems which would support them through that makes a huge difference to how the society evolves in general for future generations.
Yeah. Thank you so much. So I mean that translates for all levels of we are looking at students, we are looking at the staff, we are looking at product designers and all. And I really want to emphasize and again bring into the room the importance of women designing these solutions, and which is why we have 5 of you sitting here today. And to understand from you, Veena, how do you feel about solutions that is designed for women by women, and how does that compare to anything else? For example, what Kritika spoke about. And lastly, just briefly throw light on how this can be scaled across systems.
Sure. I think all 3 of them have really put across very important and very core points which relate to equity for not just women's healthcare, but also the empowerment of women in general. So it doesn't start from data. It starts actually from the way you bring up women, right? So if women are empowered to think of themselves as an important part of the family, that's where they build that confidence, and they also eventually find a place in the society as important members of the society, right? And that is one part. Second part is, as Dr. Kritika rightly said, you also need to have data that supports innovation for women. So right now we know that medical industry has a lot of data that is biased towards male biology, and also clinical studies have been designed for ages for the male biology.
Body.
Yeah, for the male body. So I think it's about time, since we have access to technology such as AI, which can also analyze data at a much larger scale and also from different perspectives. We need to also understand how good data related to women's biology can be fed to it. So one is source of good data, second is design of these kinds of studies. So that's a very important part which will help us create innovations that are designed for women. And of course by women is another aspect where women leadership is something that comes because of there has to be like an internal voice which says, I need to do this. And finding that internal voice is something that's completely personal. It's not just a woman or a man, because there are men as well who lead, entire lives. They work as an employee of a company. They are brilliant brains, but somehow they don't
would
have
not
that
want to lead,
inside.
yeah.
Yeah, they don't want to lead. So I think it's up to us as a society to build that confidence in the girls, right? To enable them to think freely, make their own choices, and that's how I think tomorrow's leaders are built.
Yes.
Now in the creche.
Yes.
So I think that's. I mean, I have a girl.
Yeah.
Growing up, I was the younger child. I had an older brother, but my parents never treated me as a girl. They never treated me differently. Always I saw the same kind of opportunities being given to him and
Both of
me.
you, right.
And that's the same thing. I have a single girl child, and I have always treated her as the apple of my eyes. And of course, she's grown up to be a beautiful. She's a neuroscientist, and she's
Wow.
like very confident and making her own choices. So we also need to trust our kids in making their choices when they are growing up, right? Of course, I mean there's a part about bringing them up, giving them boundaries, etc. But then, as they are teenagers, as they grow older into adults, especially because they're women, we sometimes tend to be overprotective. That's another part I think we need to be a bit careful about. Be their friends, but at the same time also be their confidants.
Confidants.
Listen to them, and of course give them that confidence that whatever choices you make, we are there with you. We won't be hindrances, but even if something fails, that's fine. We are there for you, right? So that's the kind of support system that we can build for these women. And I think being women leaders and designing for women are two different concepts, but overall with these two pillars, I think we can achieve that in future.
Thank you so much, Reena. And lastly, back to you, Renu. In your experience, building Sigtuple and, being a doctor, being a hemato-oncologist, if there's one thing that, you can wish for to be added in the whole ecosystem and all the entire wish list that we have with us, equitable solutions, human-centric design, leadership to be driven in people. If there's one thing that is still missing from the conversation, and just one of it, just what would you like it to be?
As we were again talking earlier, I think it's collaboration.
Okay.
That's a very important thing. While we are all, trying to do something in our own spaces, I think it's a high time that we all came together and made something beautiful together. That's very important. We may be masters in our own field, but it's time to come out with that and exchange informations and ideas to find that end solution, because there'll always be something missing. See, digital pathology, because I contribute to that and I'm talking about that. It's an enabler. It's just a tool. It's a foundation. But finally, you need conscious decisions. You need operational decisions. You need aligned protocols and policies that, to implement these and take these forward. And how can that happen? That can only happen when there are both ways, where we create a solution, we create a product, for instance, but there has to be acceptance of that. There has to be something on the other side as well, which can come halfway through and collaborate with you to make it, practically possible and to utilize this in the best possible way. So I think collaboration is something that we still have to achieve, and I'm very hopeful about it. And thank you for organizing sessions like this, which actually brings out that focus onto that, right? And build it further to wherever we could take it to a much better place. So
Yeah.
collaboration it is.
Thank you
yes.
so much, Renu. Thank you all for a wonderful dialogue. And what you just said is music to my ears, because I'm working on gender transformative leadership, and we are here. We are in the age of AI. We have so many of us in the room, and really to have these networks. I mean, speaking of collaboration, I want to take it to networking, and something that I want to see soon is for women to have work taken out of networking. We can have another whole session on that. But we really want to make it equitable and accessible, and here's to more such dialogues where we can come together and talk about what we can do better together. And do we have any questions from the audience? Yeah.
I have several.
Okay.
Thank you. So a lot of what you all said resonated, obviously, but I think at the core of it was also this theme that at the end of the day, women do have to ignore a lot of things and adjust in a way. How do we change that? Because whenever we get together in sessions like these, everything looks positive, and then we go back to our regular days and the same biases, the same things, the same patterns repeat. So like what you said, Dr. Shweta, like to bring up that mindset and ecosystem change, I don't think we can drop the ball any day. So but then it's also exhausting, right? You can't fight every day. How do you maintain that balance? How do you pick your fights? I guess that's the primary question.
Do any of you want to take that? Okay, well, I mean, I can just share very briefly, and this is, what I want to set the stage for here. One of the hashtags also I use on my social media is women supporting women. And like, so many of them also said, the world is not going to change in a day, and neither should we try to. What I find really helpful is for solidarity to exist, for each of us to support each other, like Renu said, collaborate, support each other, be each other's cheerleaders. And I think when you stand together cohesively, that is when the world starts to notice your power, and that's when sort of things start to shift a little. And any of you want to add to this?
Yeah, I'll just add one point is I think when women start to realize that the power is really within them, that's when they can uh, take that decision to keep fighting every day. Let it be, even if it is every day. We have to also realize that there are men as well, as I was saying earlier, men as well who face the same situation. They may be facing the same kind of competition at their work, in their education, wherever it is. So the one who gives up and thinks that I can't find this is the one who's lost, right? So women have to remember the same thing. If you really want to go somewhere, you have to keep pushing no matter what. There are always going to be like 1.4 billion women, people in India and 8 billion people in the world. So there's always one against so many for some of the things. So you have to find, as she said, perhaps collaborators, people who think like you, find inspiration from some of those, find mentors, and keep fighting.
And let's have more people doing it, right? Let's be the front runners, and people will get used to it, right? That's where we should take, and then I think nobody will see the difference. There's no difference, right? But yes, as I also mentioned and Meena mentioned, yes, let's not make that get into our head. That's all. Then everything will be clean, and world will see it even as we move forward.
Just stay, because a lot of it is about statistics. So don't give up and just stay there, and it'll all sort out.
While I agree with all of them, I think it's okay sometimes to also hold people accountable. And you can do it very tactfully and respectfully, but also hold people accountable if you see that there's overt like biases that are creeping in whatever context that you're facing. And many a times, if you're able to put it across in the right manner, and you're also able to be part of the solution, right? Like you're calling out a problem, but also be part of the solution. And then you might not have to face that particular bias in a recurrent manner. So, like be part of the solution, but also call it out.
Thank you, Anusha, and thank you everybody for a wonderful dialogue again. I know we would all love to continue this conversation, but we are being pushed out again for the next session. I know you all have places to be. I'll give it back to Priyal.
Thank you all for your presence. And I would like to invite Dr. Pooja to felicitate our guests. Thank you.
lovely, yeah, and lovely to hear your views also. Yeah, really appreciate everything you said. Oh, totally agree with everything you said. Yeah, let's take this. There's so much that yeah, yeah. Are you there tomorrow? I'm there tomorrow. I will say I think for the inauguration. I said this will happen on Monday. I think we have to get to the phone 7:30. 7:30 Check.
For the next session.
Hi. How are you? Good to see you. Good to see you.
कल अच्छा हो गया बहुत.
That was good yesterday.
I couldn't make it. I had to go back.
Oh, really? You came
Yeah,
there
yeah.
and then tried? It was crazy.
See you around.
We are getting all the three startups.
और लगाना पड़ेगा तो
बीच में हो सकता है, ज़्यादा बेहतर है. वो चेयर वो सोफा मिल जाएगा. हाँ, एक सोफा और चाहिए. बहुत बड़ा पैनल है. मुझे भी लगता है ना, एक्चुअली और मीटर के लिए. Looks fine. So ये पूरा पैनल ऐसे नहीं. The first was the panel. है ना, राउंड टेबल बना हुआ है. ये मिल जाएगा. ये भाई.
Only two of the mics have this audio.
Okay.
Otherwise, the audio will not go into.
Perfect. किसी को वो लगा. So we have how much of time? 1 hour? ये सब पेन देना हमको. So welcome back to the one more panel hosted by BFI and Government School of Medical Sciences, Greater Noida. This panel is really special because what we see, AI is not just that what we see. AI is beyond what we don't see. So let me take the context right from here. The panel is not just what you see from that side. The panel is right here, all the front rows. Can we have you on the second row, please? So we have, in the scarcity of space, we thought of getting the maximum voices. We have Dr. Ravi, who's a senior scientist at GIMS. We have Vivek sir. Hi, please. So Vivek sir is a compliance expert. He's also one of the mentors. We have Avnish Khare sir. He's an anesthesiologist and he's an AI expert from Government of India who teaches AI to doctors. We have Jaideep sir. Jaideep sir is a clinician, has been into this ecosystem for a long time. Along with Avnish sir, they are also faculty member for the executive course at Geo University, which is the Institute of Eminence at Maharashtra. Along with me, I'm also joined by Amir. Amir represents a fund that they invest into startups across the healthcare domain, from pharma, biotechnology, devices. So it is very, very thank you for joining us at the very last moment. We are joined by Dr. P.K. Jha sir. P.K. Jha sir is a MCH neurosurgeon from AIIMS. He practices in Patna, Bihar. And very unique of him that he has developed a hospital information management system using AI. So normally when we see that, are doctors only absorber of technology or they also create it? So that's a very unique example. We are also joined by Dr. Vamsi from AIIMS, which is in Andhra Pradesh, right? Dr. Raju sir, he's a professor of radiology at TMU. We are joined by our Mukesh sir. Mukesh sir is the clinical trial officer at Government School of Medical Sciences. So the single window system that we talked about for a startup that we have made at GIMS. So all the clinical access that you need, that goes to the incubation center, and we have a dedicated office where we handle all the startup related activity. So we have simplified a lot of hurdle for AI startups in the government public hospital. Then we have Mr. Kabir with us. Kabir Mahajan is a popular name. He heads as the CEO for Mahajan Imaging. For people who do not know, let me tell you, Mahajan Imaging happens to be one of the very prestigious names in the country. His father, Mr. Mahajan, was the first one who brought MRI to India when AIIMS did not have MRI. And now they are one of the finest imaging chains in the country. And he looks after the entire operation. So we'll be learning from him what it takes to integrate AI into a mechanism where you have MRIs, right? MRIs are the very high-end things. But then how important it is to integrate technology to stay in this ecosystem. That is what will go to him. Next three are my special ones. Why? Because GIMS has established the incubation center in a government hospital. Very new model. Government of UP has established a state government company to run it. I am the CEO for the incubation center. And startups are the one who make the incubation center special. We'll be listening to all the three startups. We have Ragadeep. He has traveled all the way from IIT Guwahati. They are working on a very, very specific niche area, cochlear implant. Very few startups who are working in that space. Because it is very, very important that are you making for India? This answer has to be very, very clear. Do you know that what India needs? We do not manufacture cochlear implant in India. Probably they will be the first one in the country doing so. We have Mr. Vamsi with us. Vamsi is CEO for DFACTS. He has a wearable for patient monitoring. We have Sadanand. Sadanand has an AI-based image analysis software for leprosy. We need this here in India to solve tuberculosis, to solve leprosy, to solve asthma. Can we use tools and technologies and empower our doctors to do it? This is the long introduction. Going into the depth of it, I would go to everyone, but with one simple question. To all doctors in the panel, my question would be, how do you perceive a startup when somebody is approaching to you, sir, I want to do a validation? What is your perspective? We want the audience to understand it from a clinical perspective. Because people have this notion, I have had, we listen to too many pitches every day. We are also a Stanford center. And now we are a BIRAC center. So we listen to a lot of pitches. The very basic problem that startups tell me is we do not know whom to talk to in the medical college. We do not know what is PI. We do not know what is research committee, what is ethical committee. They know one thing, I went to this doctor, this doctor said this app is very good. Your product is very good. And then I go to investors and tell them, few doctors said that our clinical trial is done. I would go to Mukesh sir to tell you understand what is clinical trial for a medical college like ours. Clinical trials and opinions are different. Clinical trials is an institutional process. For example, you may be engineer and you got to know an art of injecting IV medicine. For example, आपने नर्सिंग स्टाफ से कहीं सीख लिया, आपको दवा देना आ गया, लेकिन वो वैलिडेशन नहीं है, वो आपका ये हो सकता है कि मुझे आता है लेकिन लाइसेंस नहीं है ना आपके पास. A nursing professional is licensed to it. A medical professional is licensed for it. That is what very important part. But yeah, opening up, let me go to startups first and then we go to doctors. Is that okay? Yes. Keep it very sweet, simple, 1.5 minutes.
Sir, rightly said. Also in the afternoon, I heard Dr. Hirsch saying that doctors would never come and doctors would never ask particularly that are you authorized, do you have the licenses. Doctor would only ask that do you have things that would make my workflow better, that would make my work more efficient, that would save more time of mine, right? On that part, I would like to say it is primary responsibility of the startups themselves to get them registered, to get them authorized for what they are doing, to get them patented with their technology, to get the clinical trials done. And that's where I believe GIMS and BFI are putting a step forward in an area which has never been explored and give medtech startups an opportunity to do the clinical trials.
Vamsi, you are making a product which you say that will use technology for patient monitoring. I want you to tell me the hurdles that you face because you have crossed those hurdles, right? Can you talk about your actual experience and then what should have been an ideal thing that you listen that this happens in this country, right?
Yeah, it's going to be something like this. We started this in 2020, yeah, with zero knowledge on the medical background, but we have a good doctors who are on board supporting us on how to take it forward towards the medical device, clinical validations and all that. But the important here is, so every day is a challenge to us. So it's not straightforward like any other industrial IoT devices or the other devices, commercial devices what we are previously making. Here important is we need to have a proper principal investigator. That's one challenge. And the second challenge comes with the ethics committee. Yeah. So once we have these two, the third comes is the documentation that need to be submitted to the CTRI and the other bodies to get the approvals, and then the trials will start. But most of the cases what the startups do is we start the trials, then we go for an ethics committee, then we'll try to find an investigator, then we publish. These are the challenge in the day one we faced. Yeah, I'm also in the part of that itself. We started with trials, doing the validation study, going back again. Again, we started the trials with the proper the steps to follow, and we have completed the trials in that model. Most of the startups we first try to do the validation, and we think that we need to keep everything in the market immediately, but it's not so easy to do that. We need to have a proper steps. We don't find the steps anywhere. We need to identify ourselves. We need to learn from the failures itself.
rightly put out together. The my startup Ragadeep. Ragadeep, why did you choose to make a cochlear implant? Because we see people making something like Ola, Uber, sending medicine, sending ambulance. Too many things happening which are very simple. Or maybe too many software companies coming in, helping in doctors the decision making using the image analysis. So if we have to categorize the AI startups in the country, I will categorize that there are software medical devices almost 50% of them. But when you thought of making a cochlear implant, and that's how I reached out to meet you at Guwahati, before that many people had said that they're making it. But I was looking for who is the guy who's actually making it. I heard a different story in Madras, I heard a different story in Delhi, Noida. So then I actually got to know that you are making it. Why did you think of that in an era of AI? You chose to make a hardware which is not AI, which is required for human being. Your take on it.
Thank you, Dr. Rahul, for the intro and everything. The thing is, when we started to look into the problem, we did not know how deep it was, how difficult it was. And we were not exposed to the larger market of cochlear implant. We worked from a very remote place, which people still think is remote from northeastern part of India. So maybe somewhere not being exposed to the bigger sharks made it very clear to us that, okay, we can also do it. So that creates a difference in perception that whether you can do it or not. If you're not scared of, you don't know the shark in the ocean, you're not scared. So we started it. And as we went into the journey further and further, we started to understand, okay, these are the problems when you are developing a class C, class D devices. So because we were taking one step at a time and we were not limited to reach the end point. If we are taking just one step at a time, so we are not scared of the end point. So that is where it's segregated. The entire process is segregated into steps. So with those steps coming in, that removes the scare. I think that is what you wanted to know, like why did we go into such a thing which has such a large gestation period? This is one question I always get from the investors, or I always get whenever I am coming to somebody to meet. Why did you choose to develop a cochlear implant and not something as simple as a hearing aid? So my answer would be, why not? India needs it. Why not? Why cannot we do it? Why cannot even we try to do it? If we are limited by the thought that, okay, let us try something simpler, our answer is, why not try something difficult and fail early? That will result in something simpler in time to come. That might be a possibility. But trying to make something difficult is the biggest challenge.
Very rightly put together. Thank you. Thank you so much, Ragadeep. You are actually doing something which the country actually requires. A low cost, good efficiency cochlear implant is what India requires. Let me go down to Mr. Kabir Mahajan. Very simplest वाली बात होती है जैसे ना कि अगर आपके घर में गाड़ी हो तो मैं बोलूँगा संडे को गाड़ी दे दो कि let me drive your car. आपके पास you have the data set. You are one of the finest imaging centers in the country. Do startup approach में data दे दीजिए और अगर करते हैं है ना क्या हम उनको कहते हैं इनिशियली क्योंकि ना from a medical college perspective when I was talking to few startups I tell them these are the guidelines. कोई शॉर्टकट नहीं रेगुलेटरी में there is no shortcut आपका if you understand that what you are making आप कैटेगराइज करते हैं but then it is very sad that startups normally go down to the shortcut first in the name of कि हम वैलिडेट कर रहे थे सिंथेटिक डेटा पे क्या आपके पास जो डेटा के लिए आते हैं यू एज अ लीडिंग चेन आपको लगता है कि हाँ ये तो आराम से दे सकते हैं बट फिर क्या एथिकल चैलेंजेस हैं जो आपको अलाउ नहीं करता एंड आई वांट टू लिसन फ्रॉम यू अ लीडिंग ऑर्गेनाइजेशन जिसमें इतना डेटा है तुम क्यों नहीं देते और डेटा तो किनको देते हैं
So thank you for having me, and that's a great question, and also thank you for the kind words. So yes, sir, definitely a lot of startups do approach us, and the good part is even a lot of the established players like the Philips and the G's, etc. Renowned players, they also approach us. So one thing is we try to subsidize, that we charge the bigger organizations more, and startups we try to do whatever we can. So this is how we try to subsidize. But as far as startups, yes, numerous startups of all different parts of their journey. They do approach us. Some don't have a solution in place. Some are just thinking about it. Some are incorporated companies who are looking at validation. So it's a mix of companies that approach us. Our primary goal is that to whosoever we can, we try to support them as much as possible. We first try to also get interested in the overall product journey, because for us, sharing just data is a one small part. So typically we would not share only the data. We want to be involved in the overall product development and validation, and eventually we'll want to deploy the solution. Of course, there might be commercials involved, but when someone just asks us for data, that typically does not excite us. That is one. Secondly, we try to understand what the company is trying to do, what problem is it trying to solve, and whether they like it or not, we try to give our feedback, at least initially, to them. And this is how we typically go about it. In some cases, if it's a university, we work closely with various IITs, especially IIT Delhi is just opposite to us. So a lot of students would approach us, and we, as a policy, we try ki at least if they were asking for 1,000 brain MRIs, we will at least give them 50 that we already have, just so that they can start. And then we don't want to be a hurdle also in their journey. So we try to do that, but eventually it is also not easy for us to always share whatever someone has asked. It involves resources, it involves cost, and even some might have very specific disease areas that they're focusing on. Our attempt is whatever little we can, we try to do it, and then we want to be part of the overall product development journey. And to that, our biggest learning was from a project we did for GE Healthcare, where we helped them develop the world's first on-device AI application for chest X-rays, which was a solution for pneumothorax. So from the concept to FDA approval, everything happened in about 12 months, which was extremely surprising for GE Healthcare. But then we were the part doing all the radiology reads, the labeling, annotation, and validation. And of course, there were other international institutes involved. So again, if we just had to share 5,000 chest X-rays with them, it would be fine. We would have got some money, but that's about it. Now we have a video with GE Healthcare showcasing us as their partner. We have the inventor status for this product. So that might not have got us any monetary benefit, but then in terms of stature, repute, it gives us a lot of pride and joy. So that's where I think this is how we typically
co-creating together.
Correct. Co-creating without any equity. We understand for startups it's difficult to give equity, but at the same time, startups also have to understand that there is significant effort involved in retrieving data. So it's not as simple ki click here, you get the data and you just share it. It's not as easy as that.
And one very interesting question which I have for you is, लोगों को लगता है कि MRI तो हर जगह MRI है. What is that makes महाजन so special? क्योंकि अभी हम लोग डिस्कस कर रहे थे, लोग कहते हैं ना महाजन से करा के लेके आओ. ये जो फेज डेवलप हुआ है in a era of AI, how इसको कितना प्रेशर आप पे बिल्डअप करता है? And then for any startup who's building up, everybody wants to be a trusted name, right? Yes. Business comes by default. कितना प्रोसेस इनोवेशन किया है आप लोगों ने? What is the AI that you have absorbed? और क्या ये आप जैसे जाइंट के लिए कितना profitable है in terms of money and trust?
Sure. Thanks. And again, thank you for the words. And these are, the first question is for my father, not for me. I don't know how he did it, but nice. On a serious note, trust, as you said, is the most important in healthcare. Without that, there is no two ways. So yes, you might have the most amount of validations. All companies will, especially growing companies. I've been part of a AI startup in oncology, radiology. Even though we had very minimal true installations, we would claim we are in 100 hospitals because कहीं पे pilot चल रहा है, कहीं पे एक analysis हुआ है तो वो भी हम दिखा देते हैं. But trust is very, very important. And for us as an organization, I think trust has been built over years. It's not overnight that it has been built. It's because of the quality of equipment, quality of manpower, quality of training, and overall quality of work we do, which attracts good manpower. eventually radiology, as much as we would like it, and no full respect to our radiology friends over here, we will want that it moves in the direction of lab medicine, where a lot of it is automated and only the complicated work is seen by a pathologist. Similarly, we would hope that this level of quality control validation comes in radiology as well, which, as we all know, there is huge shortage of radiologists. So trust is built over time, trust is built over day in and night of good quality reporting, speaking to the doctors, referring doctors, realizing where you've gone wrong, trying to work on it. And as far as AI for us goes, again, it's a big responsibility for us to also adopt the right kind of technology solutions. So if we adopt something, patients and doctors naturally will perceive it that ye to theek hi hoga. So it is a big responsibility on us, and what we've done in AI, very real AI, for which we've also paid some money to a company, is we upgraded 5 of our MRI machines with AI-based reconstructions. These are machines by GE Healthcare, and they have a solution where for enhancing productivity of MRI scans. So now we are able to do more number of scans in the same or shorter amount of time with actually better image quality. So that is how we are trying to use AI, and eventually the solution has to add value to the organization. It has to solve problems, and these are the two basic basic needs that any company, be it GE, be it a startup, they have to go by these rules, that it has to solve a problem. You might have the most fancy solution, but if it's not solving my problem or it's not being integrated into the workflows, then it has limited use.
Oh, perfectly said. Thank you so much, and very happy to announce that Dr. Nidhi Podirma is with us. She is the CSR head, the international vice president for SCL Foundation. Has been doing a lot of philanthropic work, a lot of deployment happens through what SCL Foundation does. A lot of contribution has been done to our hospital in terms of setting up facilities. Very close partnership. Welcome, ma'am. I'll be coming on to you with a question as well, because everybody wants deployment. When we are making solutions of world class, everybody says that the government is investing so much of money to make you world class, but when it is to be absorbed in the system, are we all going for the old branded big companies only and not trusting our own startups? So I'm going to ask you that. But before that, I have got two regulatory questions. I'll go down to Mukesh sir. Mukesh sir heads our clinical trial facility at him. What does the structural clinical validation in the public hospital truly look like? क्योंकि बहुत बार जब हम ये बातें कर रहे होते हैं, मैं और आप बहुत बार साथ में ही when we listen to startup pitches, I've had that 80% of the time startup हमसे तो उसका validation हो चुका है. But then we also sit on the evaluation committee of few government agencies, including government of Uttar Pradesh, where we check for the viability of the idea. We have seen that this understanding is missing. बहुत बार वो किसी कमेटी में जाके कुछ लोगों से बात करके एक ओपिनियन फ्रेम करते हैं और फिर आप उसको ये लगता है कि मेरा ट्राई हो गया. इस प्लेटफॉर्म के तहत वी वांट टू एम्पावर यू एंड टेल यू कि जो आपको लगता है वो पूरी तरह सही नहीं है. सही क्या है अगर मुकेश सर क्विकली बताएंगे आपको.
Thank you, Dr. Rahul, to invite me here.
उसके बाद I'll come down to Vivek sir to understand कि जो सॉफ्टवेयर एज मेडिकल टेक्नोलॉजी की बात होती है, सॉफ्टवेयर एज मेडिकल डिवाइस होता क्या है?
Yeah, thank you, Dr. Rahul. If we talk about the regulatory and clinical trial, first of all, I just want to go back for more than 10 years back, right? So if we talk about 2013-14, the discussion was going on in the regulatory to frame the it was happened like this कि if you have any idea or any product or subsequent product of medical device or drug, vaccine, whatever, just discuss to the doctors and we have this, so can we do the project or execute the clinical trial. So because the rule was not streamlined that time, so they just made that a protocol and discuss with the investigator and do the investigator initially study that time, get the approval from ethics committee, because that time ethics committees was not registered to the regulatory agencies that time. So the number of lacunas over there that time. But if you talk about the NDCT rule 2019 and MDR 2017 rule, now the all things are streamlined and we can execute the trial as per the regulatory. See, first, if we talk about any kind of startups come to us and we have this idea and we want to execute clinical trial in facility, can we do it? So, because they have done some proof of concept study that time, and just say, ki, yeah, we have done this is, and can we move it for the uh, commercial purpose like that. But regulatory not like this. Regulatory says that first of all you have to do the proof of concept study, and you can use the raw data on that if you have developed prototype. So just like Kabir Mahajan said, ki we have a number of images and that. So in that case, they can use some part of images to develop or to prove the concept they have, right? But not like that ki they can claim, no, we have done the study. That note is a study. So after that, they can go for the performance evaluation study. Now the regulatory rules start. So first of all, you have to go to the MDR 2017 medical device portal of CDSCO. There is a set checklist over there. You can check everything over there, and accordingly you can do that. So regulatory point of view, if we talk about the medicine, vaccine, or medical device or software, SAMD you can say. So you have to apply on MDR 2017 in regulatory. There's a set of panelists over there, 11 committees over there in regulatory. They will check out your idea and just decide and tell you in which category your ideas fall, A, B, C or D. If you have already that idea, no, I'm developing the C category medical device or D category medical device. So first of all, we need to check out this, what is the C category, what is the B category, what is the D category or A category. A category is there is no need of the particularly clinical validation study, because you are just developing the in vitro kind of study, and you are just saying like that we are just helping the system as a primarily, not secondary or not confirmatory test. No, this is the diagnosis, and you can take or you can take the decision to start the line of treatment based on that. Not like that. In B category, there is a moderate risk over there and mild risk over there, and C is a severe and D is a very severe or risk assisted of you can say medical device over there. So in that case, you have to submit over there. That is a central licensing authority of CDSCO, right? CDSCO will see your files and suggest you, and if it is feasible to, you have to do the clinical trial or performance evaluation study. So you need to take the test license of that, and in that test license, they will tell you how many number of medicine or batch of the medical device developed to use in clinical trial. So this is the way of central licensing authority, and if you got the test license, so based on that you have to prepare the protocol and select the different sites or single centric or multi-centric as per the query raised by the regulator. If there is a single centric study, so you have to develop the protocol accordingly and submit again in regulatory with the document of the principal investigator you have selected for that, and ethics committee documents of the institutions, then laboratory accreditations, or all documents as per the dossier you need to submit over there. Then they will give the permission. Now you can execute your trial. And after that, getting the permission, go to the ethics committee. Get the permission from the ethics committee. Then go for the CTR registration. Now you can start your study. So this is the proper regulatory studies.
तो सर ये इतना डिटेल था मुझे लोग डर गए होंगे. So let me tell you very simple thing. Regulation बहुत सिंपल होते हैं. Regulations are bylaws. आपका ऑप्शन नहीं कि आप उसको टेस्ट करो. You have to follow it. At the institute where we come from, Government of Medical Sciences, we have established, the state government has established a state government company to run innovation center, where we help you through a single window system. आपको जो चाहिए पहले हम ये बताएंगे. पहली मेल पर आप बताते हैं कि आपको चाहिए क्या. Do you know that what regulatory things you need? क्या आप किस कैटेगरी में हो, A में हो, B में हो, C में हो. So there is a complete hand holding that we do. इस पूरे प्रोसेस को बहुत टफ ना समझें, keep it very simple. We are there to help you out, but we are not there to get you through a shortcut.
Sorry to Rahul, actually regulatory is here to help out, not creating the hurdles. Because you have done the study over there, now the regulatory stop. No, this is not regulatory study. Then you will be in panic situation. Ki I have invested so much money and I am not able to market my product because you have not done that like this. So regulatory is here to assist you.
I will. In the interest of time, I will quickly take up the questions. I'll go to Raju. You are a professor of radiology at a very prominent TMU university. You have trained so many MD students under you. When it comes to you to use AI in radiology, what are the things that you think that these are the challenges? Because why I'm asking is, if a startup who is building up a model on AI using the diagram images of CT and MRI, at the end you are going to be the user. Or probably you will be the one who will be deciding that what is to be bought. How do you see it when an Indian startup is doing it? What are things give you a lot of confidence that this looks good? क्या वो investment का criteria होता है कि good investors have invested into it, that means it's a reliable thing, or just knowing that they have a test license, that means they are validated, or how do you take this up as a clinician? My question to you is a clinician using AI in a hospital setting, sitting at a top position, where you're deciding the deployment of technology.
Thank you, Dr. Rahul and James and BFI for having me here. So your question is very relevant. Lot of companies approach me because we have got so many modalities with us to use it and ask the authorities to actually deploy it. But I always start with what are the licenses and regulatory certificates they already have, whether it is cleared by FDA, CE or our Indian own CDS code. Second thing is the data which they have used to train, whether it was an Indian population or it was the Western population, because we all know that any software that is made on a Western population may not fit us. And the third important thing is we need certain cases where we will internally validate the results. So we already have a data, we will try to find out whether it is producing the same results as a clinician is thinking over it. So if it does not fit in any of the three, it is not useful for us. If it fits in all the three, then we will talk about the cost. Until and unless it is trained on the Indian data, it is already certified, then only we start an internal validation. And if it internally gets validated, then only we talk of the cost. Otherwise, we don't talk of the cost.
Okay, thank you so much. One very important question. When people talk about trial, validation, hurdles, we as an institute, we talk about, this is the process. This was a long route to Greater Noida, so this is a short route to Greater Noida. In Greater Noida, we have a incubation center that talks about you as a startup. I want to understand from Dr. Nidhi Pundi, she is the Vice President, Global CSR and Director, HCL Foundation. If a startup, they don't have money, can they actually get CSR to get the clinical trial done? A very question that everyone wants to understand. Is CSR only for what they want to do, they will do, or can we actually get CSR to do a trial? For those we are not funded. For example, at biomedical school, there are faculty members, they want to develop something, but for them the policy does not allow them to make a company. Government doctors cannot make a company, but if at all they want to develop something, can CSR help them out in pursuing that idea? So very relevant question that I got.
That's where the thing like what CSR resources can do is we can give you problem statements. For example, we are using AI assisted, we are using the X-ray machine AI assisted to screen tuberculosis, and we are using it quite widely. One of the mics can go off. We can switch it off. So for example, we have to do wide screening of tuberculosis, and we have to ensure that the DOTS treatment is given on time. And that is where we are using the AI-assisted X-ray, as you would know, quite widely in the communities, and our DOTS treatment profiling and how the patients are coming out of it is becoming successful. There are a lot of such other unmet need areas. For example, if I look at the immunization of children in the slums, urban slums, still the coverage is less than 50%. I mean, that's a burning problem. Now, can AI come forward and give us a solution? Now, clinical trial is something which we have to also go by the ethics. We cannot just, give communities and surrender them for, I think there are a lot of regulations that we have in India. But what we can do is, if you've already pilot tested something, we can definitely make it reach those communities which are in the need of it. For example, northeast communities, far-flung communities. I mean, even basic preventive programs are failing, including continuum of care, for example, in the maternity and the child care. We are looking at NCDs in a big way across. Screening of your simple diabetes, for example, I think. So the reach is where I think CSR funds can be utilized. Coming to clinical trials, maybe outside of public health. I know we are speaking under the banner of gyms and but for example, water conservation is a very big area. I mean, we would love for you to come forward and give us certain AI solutions which can help us measure exactly, because it's crores and crores of funding which is going into, and then it is connected with waterborne diseases, it is connected with the entire public health spectrum. So the moment we start talking about One Health, the entire climate action causes which are linked with health issues, CSR funds are available for that, and we very much invest a lot. For example, giving you examples from outside of health. I think if we switched off one of them, it will. So for example, we have this kosha device which can actually tell you whether what you are wearing is handmade or not. You just screen, you just put it on the fabric, and then exactly it is the artisan which is getting the benefit of it. And it is consumer behavior is changing towards utilizing their money towards handmade. There are krishi, there are agriculture solutions where we are able to tell the farmers about the weather conditions right ahead in time. Similarly, we have a whole lot of aids for people living with disabilities which are AI assisted. So an answer to your question, Dr. Rahul, is that while CSR funds are available for innovation, they are surely available for you to know where the problems are, because most of the times people who are incubating, they are not even aware of what exactly the problem is, where exactly the resources should go. So there is a whole list of problems that we have with us. Then there is a gender lens which needs to be applied, because the AI solutions, I know in India we are not as much right now making a distinction between use of technology, use of AI. I think everything is getting a little mixed up. But then those also need to be segregated and seen differently. There's a whole lot of telemedicine that we are doing all over. But then, are we really applying the gender lens? I mean, I am one person sitting here on this panel, but then
is it women friendly? Is it something that they'll be able to understand? So I think those are the spaces we can work together, and of course we are already partnering with gyms on many of these AI assisted plus technology driven technology devices. Yeah.
Panel ke baad question. So one very important rule regulation change which has happened in the last 4-5 years. There's a grant called HDFC Parivartan. Now this HDFC have started using their CSR grants to give it to the incubation centers to run specific programs. Do we also have something like this where we pick up an area? For example, there was a Netherlands embassy, though legacy remained. They came down to us that they want to run a program with the CSR fund. They wanted us to develop devices for the leprosy.
Yes, absolutely. I think it's see, as medical, or rather, let's say as public health experts, one thing that we have to make sure that we never cross the boundaries of ethics. The same ethical guidelines will apply on human population, irrespective of AI or irrespective. So we can never offer human population for a clinical trial, so as to say. And I think that's something which I would also like to warn a bit the experts in the whole enthusiasm of bringing something, that we should not offer our populations in a blind trial, so as to say. However, we are quite open to something which at least has a result somewhere, which is which is published. The other thing is, the population, it would need to be tailor-made. Because our genome is very different, the way populations respond to any kind of medication is very different. So I think that part we have to be very clear. Once those things are, gateways are clear, we are there, I think.
Perfectly put down together. Just to do a follow-up question of what you said, I'll go down to Dr. Jaideep Raya, sir. Sir, you are a faculty at the executive course at Geo University. And when you teach your courses, the ethics, what you last we had the conversation, right? When you're teaching ethics in the era of technology, the technology has gone to a different level of penetration. Is there a modification in teaching the ethics? Or do we practice it? Or is it the old method that we say कि नहीं, दरवाजा नहीं खोलना है 8 बजे के बाद तो नहीं खोलना ये ethics है. लेकिन AI में तो कैमरा भी आ गया है. क्या हम ये कहते हैं कि अब ethics ये भी कहते हैं कि देख लो, recognize करो फिर खोलो. So I just want to understand. Ethics is one. My personal ethics are they come from my roots, my training, my upbringing. But then one ethics is which technology is infringing, teaching. How do you take when you teach students the ethics part of it?
Thank you, Rahul. And ethics is a tricky subject, and a lot of people think, like you rightly said, ethics is something which we learn at home and dil se aata hai and hamara culture and all that. But ethics is also very technical, and we went through an entire phase. If you're following the MCI and those parts, so when it came to the ATCOM part, ethics became something very important which MCI started to stress upon, and then there is the whole bioethics and all that, right? So that is one part. So already ethics is being stressed upon in the medical field, first level. Second level comes is when you talk about the ethics of AI. So there also I would probably put it into 2 or 3. One is the ethics of actually the data collection, and there's a huge field of ethics, bias, black people are ignored, white people data is there, gender bias is there, all that is there, right? Then there is the ethics of actually building the model, right? So if I am a corporate hospital and I build a model which will make more and more money for me, right? So हल्का सा सिर दर्द हो गया तो उसको कैसा बनाएंगे कि MRI हो जाए, right? With contrast, and possibly for the whole body, even if there's a headache. So that is a different kind of ethics. The other ethics, and this is sort of coming in, is in terms of should we even use AI or not? Or should we even use टेक्नोलॉजी और नॉट, राइट? सो हर चीज़ में AI का तड़का जैसे कहते हैं, not, I mean, why do we need to use something? So there is a deployment level ethics also which is there, and we really need to be considering, because there is a cost. There's a cost to the patient, there's a cost to the system, there's a cost, environment, ecology, गर्मी बढ़ रहा है, पानी कम हो रहा है, all that is also there. So ethics is a very wide topic, but it has to start with you. So it has to first start with you, and you as an individual, you as an institution, and then we follow all the other rules like DPDP and whatever, and then it becomes, as a nation, as a community, we follow this.
I will talk about very important two clinicians, right? I'll be going to Dr. Piket Hassan. Piket Hassan is a neurosurgeon from AIMS Delhi, studied experience there. He practices neurosurgery at Bhagalpur. We have been in touch for a year or more. When we started the first AI clinic at HIMSS, I was looking for clinicians across country who practice, teach, learn, solve, create AI. So in that direction only we got in touch, and he was one of the few clinicians in the country developed the AI model for hospitals for the HIMS. And that's very surprising for anybody to know. इसका मतलब AI is simplifying things, but जब हम बनाते हैं, तो जब हम उसको डिप्लॉय करना चाहते हैं, तो फिर ये कितने एक्सेप्टेंस आती है? सर, अगर आप इसी बात को एक्सप्लेन करें।
Yes, thank you, Rahul. The biggest pain anywhere in medical world is that wrong diagnosis, wrong treatment, wrong investigation, heightened cost. And as a neurosurgeon, people come to me in last stage when they have exhausted all the money and time before. Because people do not know what is the right kind of advice that I should follow, and they do not have any idea. They go by the name. यहाँ पर एक महीने की waiting list है, वो डॉक्टर अच्छा होगा. I'm pained by people, neurologists treating spinal disc and patient is paralyzed. नहीं surgery मत कराओ ये. So these are the kinds of things that pains us. Why information is not reaching to the public. And so I made this software myself. I've been learning software for the last 30 years and making in PHP SQL program. And I can see that when I can solve the patient's problem, it gives me that really, if it is applied at the basic level, at doorstep, one can go with the mobile, and mobile will ask so many questions that even doctors do not ask. We have to filter out the dangerous cause. As a doctor, we have two things: whether your life is at risk, second, your limb is at risk. If it is not, then you should not heighten your fear. So all this thing is going on in medical practice. We must stop this, and AI can do that. By taking the data from the system will feed us a system. We can learn from the system itself, which we are treating. So this is a two-way pathway. And this software can reach to the village practitioner who can use this and give right diagnosis and right treatment, supervised by the team of doctors, and monitor the treatment itself. Everything is possible. So I have made everything now. And I just wish some investments and investing so that we can apply it at larger scale, so that people can go to the doorstep and get the right advice at the right time. That is the crux. If we are not able to solve this problem, then all thing is waste. We have to serve the poor. We have to serve the last person on the list who needs right kind of service at right time. And as he said that MRI, 90% of all headache is caused by migraine. And 50% of all headaches are getting MRI done. So a lot of burden to the investigation, this thing, and the pocket of the poor is being siphoned. So this MRI, this AI application can prevent it. We must go ahead and spreading this across all over the country to start with a pilot project. And second thing that I have made is finger-based, your pulse-based derivation of this digital stress index that I have made. Any person can go to the mobile and we can do research and we can do pilot testing also. It gives you digital stress index, and you can do online meditation, breathing work, affirmation, and your stress will go down. Your headache improves. That I'm using in my patients, and it is really giving beautiful result. So the problem and solution is both inside. Once you have to be aware of it, and psychological evaluation, counseling, everything can be done. So let us come forward and use this application for the public, and that is what my inspiration was. People are suffering. Our engineers will not understand what is the problem is. So they can't make the software. They cannot have the insight that where to use, what to ask, what to implement, how much to implement, what to monitor, how to get the feedback and how to improve. All this is only doctors can understand. So I met this and I want all of us to come together and start at a simple level. That's so that we can give it to the population. AI in India, people are listening us, people are seeing us. They must be expecting something to come out of it. If you are going to give them this solution, they will be happy that something is being done to take care of themselves. Thank you.
Yeah, thank you so much. You touched every part of it, but you said थोड़ा investment मुझे तो अच्छा लगेगा. Let me go down to the man. He is Amir Khan from Ana Capital. Amir, thank you for joining us. You are the fund manager for this capital and your area of interest is healthcare. I want to understand from somebody who sits on a fund. My startup ecosystem, when I also got my startup funded, आपको ना सारे के सारे इन्वेस्टमेंट वाले लोग सारे साथ दिखते हैं. ये आदमी तो इन्वेस्ट कर देगा मेरे को, राइट? और हर स्टार्टअप हर बार they pitch to every investor with the same conviction कि क्या पता अगले 5 मिनट में you start like my idea. आपको बताने के लिए we bring too many examples, stories to tell you कि मेरा ये validation हो गया, मेरे ये डॉक्टर ने ये बोल दिया. When you invest, what is that you think in healthcare startups?
Right.
You are Dubai fund, right?
No, an Indian fund.
Indian fund?
Indian fund.
Okay.
Completely purely made for India. But different investors have different things that they look for in startups and startup founders. It is mostly gut feel at times. It is the simplicity with which you've defined your problem. It is the simplicity with which you've identified that this is the solution for it. Because a lot of time what happens is investments are missed out not because people are not ready. It's mostly because the investor has not understood what you're trying to do. Awareness leads to confusion, awareness leads to fear. And a majority of the funds that we've invested are in startups or founders or teams that have been able to accurately communicate what they're trying to do. A lot of information is missed in jargon. I mean, in this summit as well, when I was walking, there were a lot of things that I wished to understand to be able to use in the ecosystem that we're trying to build. Dr. Nidhi talked a lot about One Health. The name of the fund is actually Alinar One Health Fund. So building towards that, we're investing in pharma engineering sectors, in pharma, biotech, healthcare, which also includes medtech. And we have developed an ecosystem to help them grow in ways that a financial investor would not. We've invested in about 12 companies, built 3 companies from the ground up, a total ecosystem of about 15, invested in 6 more, so 21 companies who deliberate with each other, who exchange ideas with each other, even inquiries and orders with each other, to build their own value and for them to move towards a mindset where they're looking at it from a scaling perspective rather than, okay, this is what I've built, please give me funding. It's your ability to communicate to people what you've actually built. Because otherwise, there's so many good founders, technical founders, doctors mostly. And I need to say that I'm the least qualified on this panel. It's a very beautiful panel. But it's mostly technical people who we bridge gaps for, where the idea that needs to be set out in the world needs to be set out in a way that is easily understood. If you go to any website of the big end consumers or clients or even like take for example Apple, they have a very simple website. You can identify what they're able to do as opposed to somebody who's explaining from the ground up. So we look for a good founder, a good issue that they're trying to solve, and most importantly how they're able to communicate that with us. And obviously you have scalability, you have financials, you have all of that, but that's mostly secondary. It's mostly your gut feel.
The problem statement and how they communicate.
Yeah.
So that's the key. How
Yeah.
are you able to tell that what exactly you're building up?
Right, because we investors are mostly, we sit and analyze a company like a dumb person.
Right. So if you're able to explain it to me, then I'm very, very sure you'll be able to explain it to a population of 1 billion people.
Yes, and we'll be more than happy, we at GIMS also want the program to start. Where we want the investors to come down and teach the startups that if they become evaluators, so what is that they're looking at? So a mentoring, not just for fun, but a mentoring how to pitch to the investors from the investors. So that is next on my list. Probably for that we will be inviting you as well.
Definitely.
So in the interest of time, I'll directly go down to Vivek sir. Vivek sir, Vivek Kumar Singh is a regulatory expert. I want to understand from you as a layman. We as doctors, we fail to understand कि मेडिकल डिवाइस समझ में आता है कि एक हार्डवेयर है मेडिकल डिवाइस फिर एक नया टर्म आ गया कि सॉफ्टवेयर मेडिकल डिवाइस इसका मतलब इसके अंदर एक सॉफ्टवेयर है वो सॉफ्टवेयर मेडिकल डिवाइस है फिर एक नया टर्म आ गया कि बिना हार्डवेयर का भी एक सॉफ्टवेयर है जो एक मेडिकल डिवाइस simplify this for all of us we have people across country simple one question कि सॉफ्टवेयर मेडिकल डिवाइस होता क्या है
Right. Thank you, Dr. Rahul. So you asked the term software as medical device. So there is a software which acts as a medical device. Let's first understand what is a medical device. So technically medical device, it's a huge definition. I'll simplify it. Any kind of product which treats a disease, monitor a disease, prevent a disease, that product is a medical device. Okay. Now, if I make a software product and if it is treating a disease, if it is monitoring a disease, if it diagnosing a disease, then that software product is a medical device, and entire regulation which is applicable for any hardware medical device. Like he's making a cochlear implant. So whatever the regulation applies to this, his product, all regulation will become applicable for that software product. So any product which is having any medical use, that product will have to follow complete medical device regulation to commercially launch the product to the market. That's a simple way to define it.
Very, very beautifully defined. इसको अभी तक हम लोग ये समझाते आए हैं कि any device that generates data helps the doctor to take clinical decision that will plan his intervention in the patient before medical device. मैं अपने यहाँ मतलब this is how you think. So very, very beautifully said, sir. We will just go to two more individuals. I want to go down to Dr. Ravi. Dr. Ravi, can you just quickly tell us the capacity which we have in genomics, diagnostics? How you are trained in US, right? And now you're working with our government of medical sciences. The genomics that we see for the US-based companies and now the startups that we see together. What are the 2, 3, 4 points that you see? Is use of AI too much happening in genomics, or should genomics be very simple? Let it be all genome sequencing based, the actual results, simple software, or we just using too much of hype of AI using everywhere?
No, actually, in the field of genomics, AI is helping a lot. For example, my background is there. I'm a medical biotechnologist. And if you heard the term, that's called multiomics. Multiomics like genomics, proteomics, transcriptomics, and all these things. So there is a huge volume of data, and it's not possible to analyze that data without the help of AI, artificial intelligence. For example, because few startups approached me to analyze their data. One of the startup was there who they just wanted to study the human gut microbiome. It's a very complex thing, and now, as you know, that gut microbiome said it is the second brain of the body. So now it's a very important aspect in clinical aspect. If we understand that what is the actual status of your gut microbiome, then you can clinically correlate it with the patient. I mean, what's the behavior is there? I mean, so few of the patients, they are suffering from, you say, IBD, inflammatory bowel syndrome, that is there. So the data of gut microbiome is very huge because it's not possible. So yes, definitely they want us to help them to develop an algorithm that can analyze their gut microbiome data. So definitely developing an algorithm is a very fantastic part of artificial intelligence. And like when we say gut microbiome, that do 16S profiling, that we do the predictive modeling. So that predictive modeling is very much helpful with the help of artificial intelligence.
So in short, AI is bringing revolution in genomics.
Yes, it's playing a very important role in that.
Perfect, thank you. I'll just go down to AIMS Andhra Pradesh. I want to come down to you intentionally at last, so that we can have opinion of our institute of national importance, When you're a part of this program, you were a part of the program yesterday as well. How do you see the integration of AI and INI?
Yeah. So how do you see integration of AI with INIs? INIs. So basically, whatever is of clinical value to our clinicians, if AI is making their job easy, and if it helps or aids them in early expedition of their of disposing the clinical material at the which they are seeing every day, so definitely it is welcome. And only thing is, till date, what we are able to see is, though there are a lot of startups coming, no one is able to prove that yes, this will help clinician in real time, so that the administration or the management will definitely take requisite approvals in the standing finance committees of their respective institutes, and deploy it for the ready use, so that there is no bar at it as such.
Are we using some AI at your center for now?
As such, no. Only thing what we are doing is every institute is connected by data centers at Noida, CDAC Noida. So we are using the HMIs of them. So they are trying to do some real case scenarios where they are trying to put clinicians and trying to develop their own AI tools, but not any AI tool from outside.
The second last question we go now to Abhijit Karizar. Abhijit Karizar, you teach AI in medicine to the entire doctors. That was the first ever course which Government of India launched. National Board of Examination launched a program, 6-month program on AI and doctors, and you are the national expert. I want to understand from you, when you have to teach the doctors the use of AI, do you also face these sort of questions कि क्यों पढ़ना चाहिए? ये तो टेक्नोलॉजी वालों का काम है, हमें तो सरकार रेगुलेट करके देगी. Can you just quickly address this part of?
So definitely any intelligent person will have this question of why. Means that is why I always start my lectures with the by addressing the question why should you learn this, and then what is it, and then how you can apply it, or what is the proper way, as we discussed the regulation part. So all this comes as a triad. By why I always tell them, see, if you want to use AI, you can have 3 roles. Either you can be an informed end user of technology, or on the other side of spectrum, you can develop technology, or you can be somewhere in between, which is a translator. Abhi usme everyone fits, including me, who will be a translator of technology. Abhi तीनों का why अलग-अलग होगा. My why as an end user is how I can use it better to serve my patients. Developer का why होगा how I can learn it to build something, and then they might have to go deeper. Or translator, how much I should know so that I will be able to explain it in a simple language. So it's a very nuanced thing. This is what I want to say. सबका why एक नहीं होगा. Why important है, and it has to be addressed when you are trying to teach. Otherwise, it will not be adopted, even AI literacy. So this is definitely, it holds true.
So capacity building is must be required.
Should start with why.
Perfect. So again, the second last question to get out to Dr. Anta Lakshmi. Now you practice IVF at Chennai. You have been to both practicing your gynecology practice. Into a space like IVF, when people go down to a specialist, a lot of money involved into it, a lot of pain they have been on to, so there's a lot of hope that they see in the doctor, right? How do you see that when the doctor uses AI, do you check for the AI that you use, is it validated, not validated? Or it is more of a moral responsibility because the outcome defines your trust. The patient comes to your setting, seeing you, your credentials. In an era of AI, because if whatever goes wrong, the clinician is to be held accountable. How do you manage very personal space of IVF when people do not want too many other technology? They want the doctor to guide them what क्या बढ़िया क्या है, क्या आप करेंगी. How do you see this space from your perspective?
Nice that you address this issue.
In reproductive medicine, we have deep learning tools like IDA-Score and LifeSphere tools which we've been using already. This tool called IDA-Score actually can, assess the embryo quality 10 times faster than one of a senior embryologist can. But the clinical pregnancy rates are not higher than what a human embryologist can do. So what does this imply? Should I use this machine, this tool, and incur higher cost to the clinic and to the patient? That IVF is cash. It's not insurance covered in India for our patients. So you think of the result. That's why we were talking about how it widens the gap, not equity in the morning. So we do need AI tools that are specific for our demographic data, more for our rural women. We want models to be built in our rural setup because they who cannot afford IVF need the AI precision more than the metropolitan women. It's when AI can say this embryo has a higher implantation potential and she can become positive in the very first IVF cycle. She is the one who wants it first. So we want people to come forward and build tools that starts with our rural women first. So I think we have a lot of more potential in this field, and we invite investors and more clinicians to work on this. Yeah.
Towards the last part of the session, we have a clinician. He took sabbatical from his practice, trying to make his own startup. That normally doesn't happen in India, but this is happening in this India. Siddharth works with Nanavati, Mumbai, one of the very prestigious hospitals. One fine day he decides, I want to create an impact. मैं ब्रेक लेकर के स्टार्टअप बिल्डअप करूंगा, 6 महीने का ब्रेक लेके, कुछ बन गया तो ठीक है, वरना वापस प्रैक्टिस में आ जाऊंगा. When he's building something like this, I want to hear it from him कि what influences a clinician at such a young age, जब आप रेसिडेंट हो, एकदम ब्रेक ले, क्योंकि ये रिस्क लोग लेते नहीं है. Just from
Thank you so much. I mean, I would just thank Jims for this opportunity, all the inspiration for this, I guess. Because I've been associated with Jims for the last couple of years. I've mentored a few startups, helped them screen it. And through all those exposure, I guess I got to know that, yeah, the space is really nice. Since we are in the hospital 16 to 18 hours a day, we can identify a lot of gaps, a lot of problems are there. I've worked in a lot, different kinds of setup. I'm from Bihar, I've worked there after my MBBS for a couple of years. I went to UK, got my license over there. I worked in NHS for a while. I came back, I've worked in Delhi in GB Panch, then in Nanavati. So all sorts of government and private corporate experiences. So I could identify a lot of gaps. Dr. Rahul is here who also guided me through all of that, and I think if you have the commitment, if you are ready to take that step, that leap of faith, nobody knows if it's gonna be built or not, but if you are willing to take that leap of faith, I think the resources are there. All the help is currently available, be it technical, be it financial, whatever is my limitation, I just go to the window, that single window of Jims, and they come out with some solution in some form, and that really empowers us. It's not just us, there's Dr. Sanjana, Dr. Nishchita, they all are clinicians, they all are specialists, and they all are trying to just come out and solve that gap. Because it's not just about, so we are technically in the urban healthcare setup, but since Jims is a government setup, it's mostly rural, and the accessibility point of view, that's mostly in the limelight. But healthcare is for everyone, and sometimes we have to go from the top to the bottom, and that's where we are trying to just fill in the gap. And I'm really grateful to Jims for this opportunity. Thank you so much.
Thank you. So last question will be with Nidhi ma'am, and again, these similar questions I had in last two panels. The way AI came and interrupted, disrupted, or so many other words that we use for AI. 10 years back, nobody thought of that AI will do something like this. The last line I want to hear from you is, what would be that future skill that people should be prepared for? probably next 5 years of time. Will there be some other revolution like AI that will let people forget about AI and that new technology will rule everything? From somebody who understands ground deployment, understands CSR, understands empathy, how do you think that one should be prepared for it? And what, if at all there is a technology that will come, what will that be?
Tricky question, and I have no one to. I'm not a prediction expert. But I think, as a person who's worked grounds up, and the way we deal with communities, people, poverty, diseases, and all of us here, I think that's the fundamental that we are in this field, that we wanted to be healers, or we wanted to be, people who can fill the gap. And I think, thank God, AI is here, which can help us with scalability. It can help us take solutions to people who really need it. It may help us minimize the cost in many, many ways and make the world a little more equitable. I think we're all also heading towards the 2030 agenda of sustainable development goals. We are sitting already in 26, and everything, if it can be structured towards how do we really achieve the 2030 agenda by using each piece of technology, each piece of AI, and cover as many people as possible. And not forget that amidst all this, there is planet Earth to be saved. There is environment which is calling for action. There is air pollution to be dealt with, and so on and so forth. But I still believe that nothing will replace emotional intelligence. So from AI to EI and the bridge, which will be important and super important as the time, and as you rightly said, the leap of faith, which I think, how do we really make AI available for people who are suffering in loneliness, for geriatric people? Those are the big challenges which are right sitting right here. India, in fact, is going to, or already has, the biggest demographic dividend in the form of young people like of yours, but we also have a huge demographic, or rather say youth burden, in the form of people who are above 60 years of age. So I think the biggest disruption that we need is there, and it is going to be the balance of EI and AI likes, which is the future. So I would strongly appeal that we stay connected in these times. So convergence and connectedness is going to be and would remain the disruptor. Thank you.
Thank you. So with this, we come to the end part of the session, and let's build AI together, not more intelligent than human beings, because I see, I have a different definition of AI that's called, awareness of intelligence. I said in the last panel as well, let this be awareness of intelligence, let the machine be more intelligent, but then you should be knowing that the machine is intelligent. If the machine is less intelligent, you should be knowing that the machine is less intelligent. Human intelligence should dominate it, right? With this feel that we will, someday this is going to replace doctors. ये सब myth है. Doctor होना ना मैं कह रहा था कि you study medical science as a science, but once you practice it is an art, and nobody take that, कोई नहीं ले सकता. That makes you a little better. With that, we end the important note. Again, with this, we are Government Institute of Medical Sciences, did this event with BFI, who has been supporting us. We are a Government Institute of Medical Sciences. Government has made a Section 8 company, UP State Government Section 8 company, to run innovation centers at Greater Noida. If at all you are a startup, you need any help right from your idea to the validation of your product, one place, one startup at a time at UP Government. Thank you so much, everyone. Vamsi. Mr. Vamsi.
Glad you're doing the certificates.
यही नाम है पूरा आपका?
Yes.
I just came for the round.
सर का तुरंत फोन आया।
हमारा तो कार्डियो we had a client. It early in the morning.
सदानंद पैनल के बाद क्वेश्चन पूछ लेना, उस वक्त मैंने अलाउ नहीं किया। खींच रहे हैं सबको लाइन वगैरह खींचना चाहिए, फोटोग्राफर एकदम बेवकूफ़ है। रागदीप सर इस तरफ भी आ जाएंगे, सब लोग आ जाएंगे प्लीज। कैन एवरीवन ज्वाइन फॉर द फोटोग्राफ, वरना रह ही जा रहे हैं सब लोग। पीके झा सर, पीके झा सर। आमिर, ये सेशन स्टार्ट कर रहे हैं हम लोग ट्रेनिंग वाला। स्टार्ट दैट सेशन, इन्वेस्टर्स ट्रेनिंग। Thank you so much. Thank you so much. Dr. Vamshi, he's from AIMS, Andhra Pradesh. Yes, sir. You. The panelists whom we could not get the certificates will write your name and will send it to your address 100%. You know, so thank you for making so special. Thank you, Gaurav sir. So it was a wonderful show. We hosted 3 panels. Again, the theme was very common: keeping trust at the top. Let the AI rule. Not, it should not damage trust. That's very, very important. A doctor-led ecosystem has to be made. BFI is already doing it. We are doing it with the UP government, and any support you require from government of UP, Government Institute of Medical Sciences, we are just a call away. Thank you so much.
sorry. Can I request you to just move the slide a bit? Yeah. No, I mean, one second. Can I? So our technology has been clinically validated in 2 trials with over 300 patients, and we have received our international ISO accreditations. We have the permissions to manufacture and sell in India, and we are currently looking at, we have the readiness for EN ISO, looking forward to move ahead. The market need is great. We have spoken to multiple clinicians. We know we have an addressable market size of more than $4 billion, and since early intervention remains critical and is underutilized because of late diagnosis. So this is how the test looks like. Can you just put it in display mode? See, I'll tell you what. I need to see the entire table in one. Okay. Thank you. Our current competitors are the doctor's diagnosis, which is the ACOG gold standard, which takes a lot of time, is expensive, and is inaccurate. We have global competitors like Roche and Perkin-Elmer, but again, we fare better in terms of result, in terms of our performance, and in terms of price per test. Currently, we are working at building our India market, and we are, through our manufacturing distribution partner, we are selling to the governments, and we are trying to make partnerships with other maternal health bodies. But we are also looking at strategic alliances to SEA and MENA right now, and hope to move to Europe soon. To achieve this, we need CE certification, which is the need of the hour right now for us. So why do we want to be a part of this cohort is because we need pilots in hospitals, we need clinical champions, and system readiness with global credibility. So this is our team. That's me. You will see our CSO and our clinical trials manager here in the arena as well if you have any questions for them. And thank you so much.
Thank you very much for your pitch. Could you explain your pricing strategy? I've seen that it's $15 per test versus $40 from Roche.
Yes.
Why this important difference?
The first part is our platform. It's a disposable test. Although we use a lot of antibodies and we have imported antibodies as of now, so the price point is at $14. But with the Gates Foundation's help, we are a part of the Gates cohort as well, we are reducing the price point to ideally, see, the Roche test is costing $40 for one time. Results are viable for 8 days. So we are looking at doing the entire entire pregnancy in less than $40 with our test. 4 time points of testing throughout. Yeah. Thank you.
Questions.
Yes.
Answers,
Yes.
Have you identified the relation of your test with drugs that are being developed for the same indication? And well, you can answer this, please.
No, we haven't. Yeah.
No?
So I'm speaking purely in terms of science.
Yeah.
The biomarker that we use and the drug interventions that are now, we have not done a head-to-head comparison. No.
Okay. And have you aware of, because you are comparing yourself with established tests, but can you tell us a couple of examples of other companies developing things like you?
Yeah.
Who?
So I have an entire slide
Yeah.
of my competitors.
Yes.
So I will speak about the differentiators more than
Yes.
anything else. First is the biomarker, which enables me to do early diagnosis. Second is the test format. And the point of time during preeclampsia development when we are able to do the diagnosis. So that's where we fare better than even the startups coming in the same space.
Thank you.
Thank you so much. If there are any questions, I'm just right here. Thanks.
Thank you, Vaishnavi, and thank you everyone for maintaining the time. Also joining us at the front here is Dr. Gaurav Singh, the CEO of BFI. And all the people who are interested in BFI, he's the man to go to. Okay, the next startup joining us here is Polyorbit, that is being represented by their co-founder, Dr. Mamoni Dash. Over to you.
PowerPoints. Can I give it to you?
It's fine, we'll manage.
All right.
Very good afternoon to you. So, as introduced, I am the co-founder of Polyorbit Private Limited, and we are working in the space of exosome-based bone graft solutions for critical size bone defects. So, bone defects and non-critical unions are still a global burden, driven mostly by osteoporosis, accidents, trauma cases, congenital diseases, and this solutions often go around the allografts or stem cell based variables, and that's where Polyorbit is coming in. What we are pitching is something that is derived from stem cells of the donor cells. So these are acellular in nature, but they contain all the biological activities coming from the parent cells. And that is the differentiation point. So what Polyorbit is developing is the next generation bone graft solution that is overcoming traditional cell therapies. So we do not have handling issues, rejection, and high costs. The signaling molecules are the exosomes itself that are encapsulated into polymer matrices, which further give the enhancement of the extracellular matrix. Although there are global players already as bone graft substitute developers, Polyorbit stands high in the sense that it's acellular yet biological activity. So we are trying to bridge and overcome the limitations of something that is more inert and synthetic in nature, but yet it also overcomes the challenges of cell-based therapies. We will be trying to aim diversified revenue streams and value captures. We'll be directly interacting with hospitals and dental chains because these are the two pipelines that we are currently developing. One is a dental bone graft and the other one is an orthopedic model for veterinary uses. We will also aim at indirect channels where the medical distributors and procurement networks will be our partners. But we will closely work with clinical collaborations and surgeon trainings as well. So can you just go down a little bit? So in terms of revenue, the product sales from B2B will be the major revenue stream, while we are also planning and launching out more R&D related services based on exosomes as well as stem cell therapies. So that these two will be our more the focused revenue streams. Why are we aiming for an European collaboration at this point of time is because first of all, I have a training from Europe for over a decade. This will give us an early de-risking of the clinical translation of utilizing exosome-based therapies, a validation in a different clinical environment with clinicians in the European setup, and strategic partner identification, which will allow us an early introduction to the team. So the team in India is very well equipped to take up the studies that we are currently ongoing. So we are on to GLP related studies using these exosomes. But we are also open to European team expansion as well. So thank you very much, and we hope we can partner with you to take orthopedics to the next level. Thank you.
Okay, one question. Yeah. Congratulations on the presentation. Why do you think that you need 3 different business models to commercialize your technology instead of just focusing on the top one? Why you
The
are opening
focus,
that?
so yeah, we are opening up because we are looking at alternate revenue streams as well to keep our plans ongoing. So there are other R&D pipelines, and we are currently looking at commercializing and valorizing those kind of the technology platforms as well.
Because the first one is not enough?
No, it is enough, but this allows us to get a revenue stream quicker because the other one is more of an EU MDR regulation. In India, it is a CDCSCO regulation. So we are now kind of dependent on the investments that we are raising and the fundings from the government sources, but we do not have a revenue source as of now.
And my second question will be associated with your comment. Are you raising funds right now? Because
Yes.
you mentioned that in private. So can you explain a bit about how much and to achieve which point?
Yes. So far the major funders have been BIRAC, so government funding agencies. We also have support from BFI, and with the support from BFI, we are now doing some toxicological studies under the GLP conditions. So we are undertaking some, it's not a pharmacokinetics kind of a study because that's not needed, but we are on taking up some toxicological and efficacy studies under the GLP conditions utilizing the funds from BFI.
Have you approached the industry?
Not yet.
Not yet.
Not yet. We haven't approached industry, but we have started talking to investors in India.
So your idea is validating several business models in India and trying to go to the European market in the short term.
So the business model is going to be B2B. We are not going to validate any other business model. The R&D factor is only a revenue stream to be trying to see if that can be commercialized earlier. Like standardizing the exosome isolation purification, because we hold the patent on some of the technologies of isolating these exosomes in a high quantity as well as quality. So these are some aspects to get the revenue, while the model will be B2B in both in India and in Europe.
Great presentation. So I just wanted to understand, so yes, this is great for revenue stream also, but you're doing the first model, you're doing dental first. Has there been an interest received, and is it because it probably is minimally invasive?
Yes.
So you've talked to doctors and seen an interest in the dental.
Yes. So the team actually has prosthodontists as well as clinicians that surgeons, dental surgeons onboarded. And the source of the exosome is also the pulp cells. So the dental pulp cells, because the dental pulp cells are something that are thrown away. So they would anyways get wasted. So that is our source, and we also have them onboarded who are giving us like one-to-one discussions on what they would like to see and what is currently being used by them. So Yelish is something they are using now. So they have BioOS, that's a xenograft model. So it has a lot of rejection issues with certain patients. So they are the ones actually giving us very first-hand feedback on what they would like to see and what patients need for overcoming.
Quick answer I would need. At the current stage, what is your expected time to market, looking at the regulatory scenario in India?
2 years.
Thank you, Dr. Mamani. Quickly, we'll move on to the next startup, that is CLRNA Therapeutics, represented by their founder, Dr. Rajkumar Kunaparaju.
It's a PDF. Oh no, PPT. Good afternoon, everyone. I'm Rajkumar, and at CLRNA Therapeutics, we're trying to develop the next generation CAR-T therapy. The next generation CAR-T therapy. So we'd like to revolutionize CAR-T therapy for non-Hodgkin's lymphoma using our capless mRNA technology and in vivo target delivery. Non-Hodgkin's lymphoma is a rapidly growing global cancer with more than 500,000 new cases being reported every year. And as of now, there is good treatment, line 1, line 2 for non-Hodgkin's lymphoma, but still there are a number of cases which are not being cured because of not responding to this treatment. That is where CAR-T cell comes in. However, current CAR-T cell therapy have got a lot of limitations. Only less than 10% of patients are being accessible to CAR-T therapy. The current market for non-Hodgkin's lymphoma is 4 billion, and it is expected to grow to almost 15 to 30 billion by 2030. So as of now, the existing therapy, CAR-T therapy is ex vivo based. It involves drawing blood from patients. They then be shipped to centralized laboratories, GMP facilities, and then they get engineered and then infused back into the patient. It's a very complex process taking 3 to 6 weeks time. Sometimes people die even before getting their CAR-T being infused back. And it's a very costly process. Worldwide, it's costing $300,000 per patient, whereas in India, with the new entrants like Immunac, it was brought down to $30,000-$40,000. And in most cases, the manufacturing fails because it's a complex process. So this is the limitation on which we would like to generate a new generation CAR-T therapy. Right? So our solution is in vivo CAR-T. So in vivo CAR-T, you actually inject targeted antibodies coated mRNA LNPs into the patient. They then engineer T cells to become CAR-T cells. They then help in tumor regression or cure. So if you compare existing CAR-T with that of in vivo CAR-T, they are injectable formulations. Treatment can be commenced on the same day with much more economical costing, which is we can bring down the cost to less than $10,000. And it's a standard oncology laboratory practice as compared to ICU and simple cold chain logistics. So the key advantages in here are no cell to be taken out of the patient and no viral vectors being used. And mRNA is always proven to be safer with respect to no genetic modifications. So our revenue models start with two approaches. One is short. Yeah. Okay, our revenue model starts with short-term and long-term, which is co-development and partnership and royalties. Long-term, we look at drug-based revenues and licensing. So BFI Connect, we think it will help in bringing in good connections with UK-based universities and VCs and soft landing. Basically, I think UK is very well established with respect to CAR-T therapy and mRNA. So we believe that this gives a very good opportunity for us. So our core team consists of myself and Bharat Verma. We have an advisor committee which with more than 20 years of experience in animal studies, immunology, and business development. So these are our core strengths: mRNA design, development, formulation, and capabilities in vivo, in vitro. So we believe that in vivo CAR-T is the future of immune therapy. Right? Thank you.
Thank you very much. From the slide you were showing the short term and long term,
yep.
Are you planning to sell the therapy yourself?
Basically, we have two patented platforms. One is mRNA, capless mRNA, which is innovative, and we are second in the world in capless mRNA technology. And the other thing is our antibody target delivery. So we have gone through a very intensive search on patents, and we have identified a target which is not being patented yet. So being able to have those patented IPs, I think our initial revenues, once we have the data, we can have collaborations with big pharma companies on co-development of cancer drugs using our platform. So that will be our first line of revenue. And the second line of revenue is developing drugs right from scratch till the market on our own, which will be the long-term objective of our revenue.
Thank you. Congratulations. Please, short answers, okay? In your case, in vivo CAR-T is a strong competitive landscape right now.
Yep.
I'd like if you can comment a bit more on the patents that you filed. Okay, have you been performing freedom to operate analysis
yep.
in the US and in Europe?
Yep.
Thank you.
In fact, our mRNA technology, the what you call PCT, prior art search, is already been out. It was not published, but we received the response. It is innovative and it is industrial applicable. There are few comments on the what you call inventive steps, which we can always address them, because sometimes they might comment this particular result needs to be projected in another way. So there is a very positive feedback on the IP with respect to mRNA card. But whereas with the targeted delivery, we are in the process of filing, so very soon we'll be filing that. We have 8 lead molecules which were very specific for T cells.
Thank you.
Thank you.
Thank you. Next, we have Deval Karia from OpenMed Labs. And again, request to the presenters to keep to the time and also keep their answers concise.
Hello. A typical 25-year-old could end up spending roughly half the salary just to keep their diabetes in check. And because advanced diabetes management tools like insulin pumps and continuous glucose monitors remain unaffordable, less than 1% of them receive the kind of care that can add up to 27 healthy years. This creates a massive care gap and a massive opportunity. Right now in India, there are roughly 2.5 million people who should reasonably be on insulin pumps today. Globally, that number is more than 15 million, representing a 9.5 billion euro opportunity that remains largely untapped. And at our price point, we could potentially tap roughly 6 billion euros of that. Now, I've spoken a lot about the numbers, but let me also put the problem into perspective. Using an insulin pump in India is like buying a small car, carrying it around in your pocket, and then spending the equivalent of a scooter annually for consumables. Hello everyone. I am Deval Karia, co-founder and CEO of OpenMed Labs, and we are incubated at the Indian Institute of Science in Bangalore. Our mission is simple: to make advanced diabetes care accessible and unlock a multi-billion-dollar opportunity in the process. And that is why we've developed InsuFlow, which is an affordable insulin pump for people with diabetes based on our patented pump engine. And the numbers speak for themselves. Right now, we are priced at roughly 950 euros versus 5,500 euros for a flagship competitor device. And more importantly, we offer open communication, allowing any open source control algorithm or continuous glucose monitors to interact with our pump. This basically offers patients choice and not lock-in. Insulin is only the starting point for us. Our pump engine can be extended to pulmonary hypertension, Parkinson's disease, as well as palliative care, combined representing more than 3 billion euros of a market. Our expectations from this program are very clear. We want to gain clarity on the regulatory pathway for these devices into the European market. Second, we want to ensure a soft landing for the GTM strategy for Eastern European markets. But most importantly, we are now in advanced discussions with a large Indian pharmaceutical company, which is publicly listed, to take our device and then the engine for one of their drugs into the European and US markets. And that is where we need mentorship from this program to help us navigate the complex negotiations. Professor Manish Arora and I are the co-founders of the firm, and our team has experience across industry as well as academia. We are privileged to have Neha Bhatia from IIM Ahmedabad, Dr. V. Mohan from the Madras Diabetes Research Foundation, and Ms. Jaz Sethi, who is a diabetic herself, on our advisory board. We've received funding and support from multiple organizations that has allowed us to come this far. And thank you for your time.
Yeah, I found really interesting what you mentioned about the potential collaboration with this company without disclosing anything confidential. Can you elaborate a bit more on that, please?
Yeah, so the idea of our collaboration right now, and it's in advanced stages of discussion, is that our pump engine will be repurposed by developing a completely new interface as well as the drug dosing calculations, and will be as a new device that we will apply to the US and European markets. and we will be the exclusive suppliers to this pharmaceutical company. And at the end of the day, the ownership of the IP still remains with us.
So the pharmaceutical company is an Indian company?
Yes, it's an Indian.
But the drug belongs to the company?
No, so it's a generic version of a drug which they are planning to launch in the US and European markets.
And it's not the GLP-1?
No.
Nothing like that. Okay.
It's actually one of these drugs that I just spoke about.
Okay. Thank you.
Can you explain the difference between your pump and the current pumps that are already in the market,
Right.
please?
So most pumps work on a syringe pump principle, which is basically you take a syringe, you move it in a controlled fashion, you deliver the drug in a controlled fashion, right? Now, it's how you achieve that motion is what is different in different pumps. The way we are doing it, we make our output agnostic to the actuator that pushes this, right? So essentially, I could take a $5 motor from a toy or a $30,000 motor from a Swiss manufacturer and still achieve the same level of accuracy. This allows us to bring down the price point of all our input components.
One final question on a bit controversial. How do you think Medtronic is going to react to your product?
So the typical reaction is always to acquire that said startup or company and sort of shut it down or
increase the price.
Or archive that. I mean, why even increase the price, right? They can archive our stuff once they acquire it, right? But the way to counteract that is to work with another larger player, right? I mean, Goliath and David only fight in stories, but if you want to fight a Goliath with a gun, you need another Goliath backing you. That's what we are trying to do.
Thank you, Deval. Next, we have Dr. Swati Shukla joining us from CRISPR Bits. Joining us from Serigen Medi Products. All the names are mixing up in my head at this point. Dr. Swati, please. The stage is yours. In opening up PDFs. So I'll request the next group to please come up. CRISPR Bits. Dr. Kritika is joining us from CRISPR Bits.
Good afternoon, everyone. Thanks to BFI VK Connect for this opportunity. I'm Dr. Kritika from CRISPR Bits. I'm here to introduce our CRISPR-based diagnostic platform, PathCrisp. So, there's at least 47% of the global population that do not have access to basic diagnostics. Even if we can bring this down by like 50%, we'll be able to save at least 1 million deaths in LMICs alone. The case is not very different with infectious diseases and AMR. There are more than 1 million deaths directly through antimicrobial resistance, and at least that is the European Union is not anywhere away from it. It's at least 35,000 deaths that are seen every year, which is why the EU 2030 AMR reduction targets says that diagnostics must become faster, more affordable, infrastructure light, and widely deployable across regional and mid-tier hospitals, which is where we position PathCrisp, a CRISPR-based diagnostic platform with its unprecedented accuracy in target recognition. Also, no major dedicated instruments required. This is how our platform works. We call it PathCrisp AMR Detect. It's a point-of-care molecular diagnostics for AMR gene detection. So the first step is sample detection. Sample can be blood culture, colony isolates, anything. A crude DNA extraction followed by addition to a lyophilized conventional PCR master mix. The PCR product goes into a lyophilized CRISPR-based detection mix. Lyophilization is a key USP for us because it completely avoids cold chain transportation as well as storage of the reagents. Finally, the readout from a very simple portable qPCR machine or any fluorescent reader goes into our cloud-based platform, which does analysis automatically and gives a report. So it's not that there are no diagnoses available for AMR right now, but the culture-based methods for antimicrobial susceptibility testing as well as qPCR platforms are very high on accuracy. They're very high on accuracy, but they take at least 3 to 4 days for the reports to come out. There are other rapid assays like the immunoassays, which give results instantly, but they're not very accurate. Our test is accurate as well as rapid, and our only competitors are BioFire panels and Gene Expert. How are we different from them is that they are highly costly, very expensive tests, and they require separate centralized instruments on which the assay is run. Whereas PathCrisp AMR Detect is high speed, broad detection, cost effective, point of care, and customizable. So this is our proposed business plan. We propose to strategically enter the European market based on the AMR burden. We are open to regional and mid-tier hospitals through national laboratories as well. We are ready to do region-specific panel customization as well. And our proposed revenue models include kit sales or validation kits along with training, and also panel expansion strategies with customizable options up to 10 genes. Our go-to-market roadmap is phased, expert validation to generate real-world evidence, potential LDT launch, followed by regulatory pathway and CE-IVD, finally towards scaling up and deployment into developed markets. Through this mentorship program, we seek market access, help with regulatory support, and commercial mentorship. This is our team along with our advisory board. Thank you.
Thank you for the presentation. Have you identified which antimicrobial resistance focus we like to start to validate that?
Yes, so we have a CABA panel with 5 carbapenemase genes, and we also have an ESBL panels with 3 ESBL genes. So this is widely spread even in India as well as in the European Union as well. These are the most important ones.
You can answer short. How you design this panel? Who did that? You or you with the collaboration with other hospitals?
So we, along with our clinical partners, guidance from our advisory board, who are also clinicians, infectious disease treatment, who look at infectious disease on a daily basis, as well as the statistics that is available depending on the prevalence of each of these markers across India as well as in the other globally in general.
And associated to this question, but not only about this, your IP strategy is based on the mix of the CRISPR mixture together with these panels? Or
Yes. Yes.
And for Cas9, or is agnostic of how?
So we are free to operate in India as of now.
Okay.
We have our term sheets from Tolo for operating worldwide. We are in the process of licensing Castrol for the same.
Or to be able
Yes.
to
Yes.
Okay. Thank you.
Who would be joining the sessions if you were selected from your team?
So it would mostly be me along with our business operations head. She's Miss Manoti. She takes care of business operations. Thank you.
You done? Thank you very much. Next, we have IoT devices coming up, represented by their founder, Nishant Khatpal.
Good afternoon, everyone. Good afternoon, everyone. I am Nishant Katwal, CEO and co-founder of IoT Devices. We are a medtech startup with major focus on diabetic foot and its associated complications. Just a minute, the slides are. You can go to next. So our major focus is on diabetic foot and its associated complication. Every 30 seconds there is one amputation happening, and more than 500 million diabetic patients are prone to this problem. So in short, diabetes leads to sensory nerve damage, which we call neuropathy. Because of that, patient feel no pain even if the foot is injured. Those injuries leads to ulcers, gangrene, and eventually amputation ranging from toe to the entire leg. Mind it, 85% of these amputations can be saved if foot screening happens at an early stage and accurately. So depending on the patient stages, we have 4 products in our portfolio. The first one is VibraSense. So according to ADA guidelines, a patient who just got diagnosed with diabetes, they need to undergo for this screening every year. And if the glucose levels are unmanaged, then this screening needs to be done in every 3 months and 6 months. So VibraSense is most portable battery-powered handheld device, which is validated against gold standard test that's called nerve conduction velocity. More than 7,000 such devices are already deployed across 30 plus countries. We have got all the approvals. The second stage is when the patient doctor needs to analyze whether the nerve damage is in large nerve fibers or small nerve fibers. That's where VibraSense Plus T comes into picture. With just single probe, it can quantify 3 parameters, and based on that, doctor can analyze which part of the nerves are damaged. This device is launched just this year in Q2, and that is also having all the approvals right from CDSCO till US FDA. The third stage comes when there is an injury. So that injury will heal or not, that depends on macro circulation blood flow data as well as micro circulation blood flow data. So for macro circulation, this is VasoSense, basically quantifying ABI, ankle to brachial index. We have 4 such units placed at all the 4 limbs, 2 upper limbs and 2 lower limbs. Within just single minute, the doctor will get all the readings, and doctor can see whether the patient is required surgeries or not. The last device that is in clinical trial right now in AIMS Delhi, which is AngioCam. This is India's first and globally 4th or 5th product in this segment. From 35 centimeter of distance, this device can analyze how much is the blood flow across the skin. All these 4 devices are not only limited to diabetes segment, basically having multiple other use cases like VibraSense and T. They are utilized in andrology, chemotherapy, induced neuropathy. In AngioCam, it can be utilized in plastic surgery, burn surgery, when whether the skin will become normal or not post the surgeries or not. So we are supplying to 30 plus countries already with classical model like distributor and going direct. Our revenue is growing 2x and we are EBITDA positive. Till now we have raised almost 9.5 CR and we are currently closing our pre-series A round also. So basically with VK Connect, what we want is going from classical program to cover the nationwide coverage instantly. How we are planning our activities is by doing the health economic study where we need most of the support. This economic study will help us understand how this device will be helping us in the patient for the long term, how it will reduce the healthcare expenditure, and also how much is the revenue that is generated by the hospital, and the cost and the taxes part in the European market. So I am an engineer by background. I have 8+ years of work experience in product design and development. Along with me, we have Pankaj Inshulkar, who is into sales, and Dr. Bajish, who is taking care of the clinical part. We are a total team of 23 professionals. Thank you. I'm looking forward.
Thank you. Your project is very advanced, right? And you have raised funds, non-dilutive and dilutive funds. Why do you think that you need this project to get what you have explained? I understand what you have explained, and it makes sense to me what you plan to achieve. I think the best way is through this program rather than connecting directly with distributors or with consultancy firms that can respond to your questions.
So we are at pre-series stage. So if we go via consultancy route, definitely that will be incur more costs. That is what we want is the local connects, which we think that this program can provide us. And I want to work on ground there, which will require more time to better understand the market. That's where I am looking forward to this.
From your revenues, it says that 10% are from the US.
No, it's 25% is the international market revenue, which we want to increase to 60%.
Okay, but you are not selling in Europe yet.
No, we are selling mostly in the Europe. US is just
Sorry?
We are mostly selling in the European Union rather than selling in the US. US it's very limited as of now.
Okay, so you are already have customers in Europe.
Yes.
And how do you engage that customers?
So we generally participate in the exhibition like Medica in Germany, Arab Health in Dubai. So we used to connect the distributors which we are going
And you
with.
sell that through distributors?
Through distributors.
Okay, thank you.
Thank you, Nishan. Next, we have Doto Health coming up, represented by their co-founder, Dr. Shantanu Pathak.
Hi, good afternoon. I'm Dr. Shantanu Pathak. We represent Doto Health. We are in business of medtech and digital health solutions for maternal care. We believe in offering next generation fetal and labor monitoring system for healthier next generation. So, in context of Europe and UK, fundamentally, the problem is less about maternal and newborn deaths, but it is more about the load on the front line or the midwives, as well as the maternal negligence issues which happens during labor and birthing period or in a pre-labor period. This also is costing huge, like UK spent around 3.5 billion pounds or 4 billion last year just in addressing maternal negligence. Also, this is a gateway or opportunity for healthcare providers to engage women for larger women health issues and not just leave them at maternal level. So we see this as an important opportunity to engage by addressing issues which conventionally existing devices which are designed for bigger or larger facilities stick mother to the bed during labor and birthing period or even earlier period for longer time. When a labor is given for like induction or augmentation of labor, mother needs to walk. However, current solution limits them, or they have to come to facility if they have to monitor, which is also an extra cost for individuals and hospitals, and occupancy of bed increases. Also, the paper graph that you can see doesn't actually give interpretation correctly, and doctors has to basically observe, spend 5 to 7 minutes for 20 minutes of graph, and there is a huge inter-observer variability when they are monitoring the patient, which leads to missed clinical events. what we have done is made this device completely portable, so you can use it at home or hospital. There are 2 different versions. Also given the AI-powered clinical decision support tool, which gives now gold standard interpretation, which is accurate compared to subjective interpretation, and it helps doctor in making decision. What we have also added is digitization of the story by making central monitoring system saving the nurse's time, as well as real-time remote monitoring system enabling this monitoring at home also in a pre-labor condition. So company has already got necessary regulatory approvals, clinical studies, both in India as well as beyond India. Where if we compare just UK or Europe-based players like Huntley or Nemocare, or Chinese and Korean player like Edan Bionet, we do offer complete connected care system. So we are not just a smart device, but right from mother when she is pregnant, from that point till the labor and delivery and postpartum, we offer the care. The additional advantage is the AI model. We have generated India's largest data set of around 1.8 million tests, and in UK around 20% of the Indian population is part of NHS patient group. So you need a neutral AI models which also represent Indian data group. That's where our association with Oxford is helping us. What we need from this BFI Connect program is basically our target is to do around 3 million euro revenue by 2030. Reaching that stage will require a systematic entry into the market. For that, we have already understood 2 potential models. One is the labor monitoring system where we offer device and software as a SaaS, and also home monitoring model where the devices are given at home for mother. Now this revenue model will be more B2B2C or through insurance. What we already received interest from UK ecosystem, from King's College and Oxford, as well as Organon and Summit Pharma, which is the pharma company of Sumitomo, has given the leads. So the expectation is we understand the regulatory pathway, understand the customer interaction, and achieve the distributor network through this program.
Thank you very much. In terms of financial plan, what do you need to achieve that?
Are you asking business model or the entry into the market?
Investment.
So basically, we are currently raising the capital also.
You are raising capital?
Yes, to ensure we have global expertise in entering, and also regulatory approvals if additional any approvals needed.
Okay. And as a team, because it seems that you are facing a quite commercial path of your company, how are you planning to grow as a team?
So as a team, we do have. So this is not. But as a team, we do have department-wise specific. But for the global team, we need to hire new people, and that's what our focus would be, to understand the global market, have expertise to expand globally. So those team members needs to be hired from here.
Thank you.
So when you're saying that you would like to, or do you have the ability to scale up your production for the thing? How are you planning that?
Yeah, so considering the requirement in medical space, end of the day for OEMs or the contract manufacturers, it is electronics manufacturing. But the requirement of medical devices is usually in thousands, and these people have capacity of manufacturing thousands in a month. So it's like their capacity is way higher to manufacture, and as well as for us, it's more about financial management on placing orders or inventory rather than the quantity. Yeah, we are not doing complete manufacturing by ourselves.
If I understood correctly, you still are not CE marked, right?
We are CE marked.
You are CE
Yes.
marked. Okay.
Yeah, there was.
You are already perfect. And here I see USA. Are you clear as well? FDA clearance?
No, so with the current fundraise, we have planned to start a process of US FDA this year for remote patient monitoring, and enter US market in 2028, not 27. 27 is a Europe plan. Yeah, thank you.
Thank you, Shantanu. We'll have the next one. This time I'll say it correctly. Folks, we're just figuring out some technical thingies over here. If anybody needs to take a couple of minutes break, please feel free to do that, and the jury can discuss.
Again, it has gone. Yeah. Yeah. Is this, am I clear now? Yeah. It it is not in the presentation mode.
ये वाला नहीं चाहिए भैया, दूसरा वाला नहीं चाहिए। नहीं, मैं वही कह रही हूँ, ये वाला चाहिए। पीपीटी पे लगा बस, या फिर ऐसे ही प्रेजेंटेशन स्लाइड्स
Finally. So people get claps after they complete their presentation. I'm getting from the beginning. Thank you. So we are Serigen Medi products, and we can go to the next slide. This was just a placeholder slide. So in spite of development for various wound care products as well as bone marrow filler products, which are basically fall under the umbrella of tissue regeneration product, there is still a limb that is lost to diabetic foot every 30 seconds, and an osteoporotic fracture happens every 3 seconds, though we have many solutions. So why is this happening? Because there are certain limitations to the solution. And what we are doing here is we are trying to address the limitations that are there in the current world. That's the last. So at Serigen Medi Products, we have a patented platform of using silk and converting it into kind of matrices which are suitable for various tissue types. And that's what we call our technology, which is Seritech. We address the growing European market's need for safe and effective tissue regeneration in orthopedic reconstructive procedures in treatment and as well as in treatment of chronic wounds. We have 2 products currently. Ceridum basically treats chronic wounds, and how it is different from the currently available options is currently all the advanced wound care products, they do it so by moisture management and non-adherence. However, we address the key problem, that is management of the inflammation at the wound bed, and that is how we accelerate the healing, improve the outcome, and also reduce the chances of losing the limb by amputation. We have already launched this in India. We are also talking to US FDA about its 510(k) clearance. We got very good clinical outcomes in Indian market. The other product is Serios, which is unlike Ceridum, it is an implantable device, high-risk device which goes inside the bone and allows, it behaves as a matrix for the new bone formation. The options that are available currently, they are not exactly biomimetic of the cancellous bone, whereas we are, which means that the surrounding cells will see it as a matrix where they can form new bone, and it stays there till the new bone is formed, unlike the currently available options. Thus reducing the...
request that you speed up. You have less than a minute.
Yeah, this request. So the enhanced surgical outcomes are there, and the milestone that we have achieved is that we have completed clinical investigations for this in India, expecting the permissions in India now. What we want from BFI is initially we would like to have some regulatory support whereby we can get the CE approval and also identify the reimbursement strategies, with which followed by that we'll build the key opinion leaders who can take up the clinical trials and have 5 to 10 key leaders who can use it actively, and then focus on commercial penetration with country partners over the 5 to 7 years. So that's the ask, and thank you.
Hi, thank you for the presentation. I have one question only. It's about the competition. So
the company?
Competition.
Competition, yeah.
So I am aware that there are some projects in Europe similar than yours. Have you identified them? Do you know what they are doing? how you want to compete with them if you go for this regulatory path? Thank you.
Yeah. So there are two aspects. One is using some other material but working in this space, and using the same material but developing some other solution. Both are there, right? Both are there. So I first address the same indication. So they are trying to do so by mixing the ceramics together so that you change the dissolution rate and address the current issue that it either resolves too fast or too slow, thus creating issues. That is what is the approach currently is being taken with the same indication. But the other ones, the silk-based other startups, they are addressing either the knee tissue repair or something else, which is not exactly a bone body filler. We are the first one to do a bone body filler, silk-based bone body filler testing in the world globally, clinically validated.
Have you approached the army industry?
We are.
Have you approached them?
The
war industry.
Military or army, like defense.
How do we approach them?
Have you already approached?
We have. We already. So the one which is in the market is being sold to military also. Defense is one of our buyers. Okay. They buy.
Thank you. Okay, thank you. Thank you very much.
Thank you.
Next, we have Ignosis, which is being represented by both the co-founders, Divyansh Mangal and Rakshit Jain.
Do we have to? Hello. Hi. Hi, we are Agnosis. Right. So, the problem we are trying to solve. So, for European market, every 10 minutes there is one autistic child being born in India, in Europe, and there's a critical gap. The early signs of autism come at 6 to 16 months, but in Europe, the average age is 4.5 years around. And there's a critical gap that the neuroplasticity of a child goes down as he ages. So those symptoms lock in. So it's very important to detect autism early. Now, why doesn't it happen right now? Because at a small scale, because it requires experts. It costs around 200 euros in Europe because it takes like an hour of assessment to do. It has subjectivity built in because it's questionnaire based and to consume a lot of time. So this cannot be done on scale. And the autism has been on severe rise. It has tripled since the last decade across the world. It's not audible? Oh, okay. Better now? Okay. So there are 3.88 million kids born in Europe each year, and the prevalence is 1 in 68. So you can calculate how big this problem is, and the detection is absolutely important. Now, what we've done is try to solve this using AI. We show the child a stimulus. On the basis of the stimulus, we track the eye tracking of the child. We use eye tracking as a biomarker if there is an aberration in it, and track it, and then using our AI, get the reports out. We've got the CDSCO license for this. We did the research at AIIMS Jodhpur with a big cohort of 700 kids, and comparing it to some US competitors, their hardware is actually really costly. So we have 1/10 the cost of the hardware. We have 1/10 the cost of the test itself because the compute itself is really low. And importantly, we can scale across the network because we don't require any specialized hardware.
Yeah, so coming to how we can scale it well in Europe, we have already received the licenses in India. The prices are as high as 400 to 500 euros, which we can bring down to less than 10 euros. We are looking at European market as a way to GTM. The idea is to connect with healthcare workers there, get this regulatory approvals done there, and to also do more and more research on how therapeutic interventions can help us scale faster. Um, we both come from very strong background of AI, and both our parents are pediatric hospital owners. We have presented the solution in Shark Tank India. We have recently raised more than $500,000. We have team of HODs from AIMS Delhi. We have more than 7+ engineers who have left their jobs. We have more than 7+ psychologists who are also from UK-based companies. We have big purchase orders from pharma company in India who is taking us to more than 30,000 pediatricians just in India. Alongside, if we talk about competition and market access in Europe, internationally there are only 2 players which are doing it at a cost of 700 USD, while we can bring it down to less than $30. In UK, there's one company who is still using the traditional based tools. So they still require 30 to 40 minutes and is very expensive, and that's something which can bring it down. And yeah, thank you. We are also working with the Rajasthan government and looking at pilot projects there.
Hi, congratulations on this and the raising the funds. I have a question for you. You are both co-founders.
Yes.
What are you doing? The same thing?
No, so I predominantly take care of sales marketing, and Divyansh predominantly take care of product tech research.
Okay, and neurodiversity is a quite hot topic right now.
Right.
Okay, and there are many companies around,
Right.
the one that you selected
Right.
as well. So I like to understand a bit more about what happens with an early diagnosis. What happens if we do an early diagnosis?
Right,
I
correct.
know that it's better for the
Correct,
but
correct.
what we can do.
Right.
with
So
this.
so let's imagine a child who is screened as early as 16 months. He gets therapies for less than 6 months, and he is going to the normal school. 71% of children who get early intervention go to normal school instead of special school. There's 31% increase in their cognitive abilities in less than 6 months. And when we are looking at later diagnosis, let's say at 5 years, we are rehabilitating the child, while at an early stage, we are just giving some inputs and doing corrective measures to get the child back on the right path.
And the system is ready
Yes.
to make this happen.
Yes, correct. We have the licenses. Yeah, yeah.
No, I don't think he was asking whether you are ready.
Okay.
Whether the system is ready to adopt it. Right? That's
So,
the,
correct.
And how do you think the market in India versus in the Europe?
Because now let's say that we say, okay, 20% of the kids, they need to go to a specialist school. Do we have enough specialist schools?
Right, for sure that would need to scale better because we are basically solving the top of the funnel, and then the ecosystem will evolve, and we are actively trying to help in making that ecosystem by making guidance and referral systems after the child is screened when it's flagged.
But if we look at it from the point of is US ready or Europe ready, the idea there is if we are doing early detection, we don't need a lot of intervention. We just need 3 to 6 months of online rehabilitation programs which are already on the platform, so that the child can already integrate in the systems which exist in Europe. Thank you.
We've hit technical snags yet again, so just give us a couple of minutes to figure it out. And next is Centella. Just be prepared, and I'll call you, hopefully in a couple of minutes.
Does it have an HDMI cable?
Yes.
I'm going to चला लूँगी तो best होगा. I actually don't want to make my laptop. Yeah, if you can get it, because then you guys say the next person. Maybe.
All right, a lot of exciting things happening in the front row here, folks. So, right, Dr. Riaz, please go ahead.
Hi, good afternoon. I'm Dr. Riaz. I'm the founder and CEO at Centella AI. In the interest of time, I'll divide my talk into two parts. Part one about the intro, technology, traction we build, and the part two about the specific, support we are looking from, VK Connect. So I'm Dr. Riaz. I come with close to 15 years of experience in drug discovery, medicine chemistry. I founded Centella AI with my co-founder, cancer biologist Dr. Poorna. We have been funded by ISB and Mighty and also few angels. Raised so far close to 350K and raising the next 1.25 million round as well. And we have around 500K soft commitments. And this is what specifically what we try to build with our generative AI platform called Cascade, which is now being converting into an agentic platform with Microsoft Discovery partnership. So the specific problem statement we are trying to address is to design and develop new therapeutics using our AI and human intervention platform. So we built our agentic AI Centella Cascade, and we would like to build a selective CDK to specific small molecule therapeutics with CCNE1 application, and which is overexpressed in endometrial cancers and counts for approximately 10 to 20% of European Union, and close to 130K cases annually. And there is a huge therapeutic gap in terms of failure of chemotherapeutics and resistance to CDK4 and 6, which eventually contributing to the upregulation of CDK2 as well. And there is a systematic gap innovation we are trying to address with our platform. So what the proposed solution, we used our agentic AI platform with our Medchem intuition to design CDK2 selective molecules. In a traditional settings, you ideally synthesize around 3,000 to 5,000 molecules to take a molecule to the clinical level, and around 20 to 30 iterations. Now we would like to cut down to 300 the number of molecules you synthesize and screen, and iterations less than 10. So in that context, our platform with human intervention, generated, gave ideas, and eventually out of 40 molecules, one top active molecule with 7.3 nanomolecular activity, and the further selectivity studies and admin studies are in progress. Platform is entirely disease agnostic and can be applied for any disease as long as you have data. We divide disease modalities as well, whether it is autoimmune other as well. And this is our business model with partnerships platform, and we build our platform to build our internal pipeline. We have 4 co-developed programs and 2 wholly owned programs, and we want to help other partner with small mid biotech and large pharma and also research institutions to build their pipeline as well as with a co-development. Mass General and working with Albert Einstein College of Medicine as well and Harvard Medical School. And yeah. On co-development models, work in their areas on their specific therapeutic modalities or like the disease segments, and also draw insights from citizen science, BFI, on the disease indications and the specific targets as well, and which are interest for the both the European Union and India, and joint collaborative projects with and support for equity-based investment and non-dilutive grants. And this is our team. I'm a medicinal chemist with around 15 years of experience. Poorna, cancer biologist, and other team members as well. We are a 20-member team, which is truly interdisciplinary. Yeah. Thanks.
Hi, thank you. Regarding the business model that you first showed, the partnership model, have you started conversations with these potential partners?
Yes, we already worked with University of Toledo, Kentucky, and other institutions on a paid transaction basis. Yes, we are working with them. Ideally, the engagement starts with a paid pilot, and then once build the confidence, then we move on to a co-development model. We work with University of Catanzaro, Italy, on one of the metabolic disorder target as well.
Congratulations.
Thank you.
I have 2 questions. The first one is,
I don't understand why you are pitching directly to a CDK2 inhibitor. Okay, fantastic. Instead of pitching first your platform, because at the end you are an in silico drug discovery company, and your plan is not to develop a CDK2 to phase 3, So why you are pitching that? And then I have a second question.
Yeah, the CDQ is just one application of our platform. As I mentioned, the platform is disease agnostic.
Yes.
As long as you data for and then we can use it that. But in specific case, like we would like to pitch this because it is scientifically validated. See, the tech bio has to transform into biotech. Now we are in the transition. So we built the technology platform and now we are scientifically validating it and validated. So hence is the pitch. When the technology is built, it has to be validated in science. So hence is the reason why we are pitching science. And tech we already built, we are enabled, it's a TRL 9, we are there. And we are enterprise ready as well. And these are at a TRL 3. So that's where we feel like, rather than technology, because we already built the technology over the last 4 years, now we need your support to put us in the next orbit for the science acceleration.
And my second question, let's imagine 1 second, I am a European biotech.
Yep.
I have been invested by VCs in Europe and
Yep.
in US.
Yep.
So, and there are companies like you in US and Europe.
Yep.
Why we are going to engage with you
Okay.
instead? Why?
Right, that's a very good question. We see drug discovery through the lens of AI, not AI through the lens of drug discovery. Right? So people, if you see 98% of the AI first companies are founded by techies. They build a nice technology platform, have challenge in validating in science. I'm a medicinal chemist by training, Dr. Poona is a biologist by training, right? So the entire platform is built through the lens of medicinal chemistry, biology and bioinformatics. Then we know where to integrate, how to integrate, how to accelerate AI. So that's the, pitch and differentiation. That's how we have been coming out as a signal out of the noise. Yeah. Right. Thank you. Thanks.
Thank you. Next, we have Dr. Sunny Singh from Bioscan. They're just going to be placing their product in the front for everyone to look at. Dr. Sunny, you can leave it on the table and start the pitch.
Good afternoon, everyone. My name is Dr. Sunny. I am a medical affairs manager in Bioscan Research. Today is the topic we are discussing about the cell row. This is a classic example is there about a patient named Palbo. He had made an accident in the Sunday and he was a bad one accident. On Monday, after 18 hours, he had an accident, a normal patient. Had a normal day. After Tuesday, he was changed. He was asking why the bed is spinning. When he was going to the hospital, the hospital staff say take rest and take ibuprofen. Neurological examination was normal, and there was no diagnostics test was done, and was planned to change discharge. Clinical advice was symptoms, just wait and walk. Along with the 2022, Palbo plus 69 millions of people are just waited and it out. Because in the mild cases, why the directed diagnosed TBI in absence of symptoms inaccurate. Basically, out of 100%, 25% are moderate to severe TBI. For that, their severe mandatory is recommended. Early detection and early treatment is possible. But what about the 75%? There's mild to severe patients, which are complex factors, and delayed CT scan is there, and delayed treatment. With our device, we have early CT referral, early detection, and early treatment possible. From 30% to recovery, it goes 90%. Yes. No more wait out. Why Servo? Servo is a portable device, non-invasive, used NIR systems. Basically, we have patent technologies and designs patents granted in India and USA. Clinical validation, successful multiple sites, clinical trial involving multiple lobes, demonstrating high performance, published world-class journals. Basically, our clinical partners in Ahmedabad civil hospitals, Himans's Bangalore, Bhopal, and etc.
You have 1 minute.
You have a minute.
This is a portable device we have. This is a portable device. We can use anywhere in the trauma cases. We can add the patient. In 2 minutes, we can scan the whole lobes in 4 parts. Basically, it compares left lobe to right lobes. Basically, in 2 minutes, we can scan the tumors. Basically, it's used for the mild patients because for the severe patients, there is a CT scan already is protocol. But for the mild patient, there is no tools such as we use the glass coma scale test, which is not accurate as such. Basically, we use our as an objective tool.
Thank you. Can you tell us a bit about your IP strategy? You have patented this solution in your innovation in India and the USA. I didn't see Europe. What is your plan?
We are exploring that right now. In Europe, we are exploring right now. Yeah.
So, obviously, your device could change a clinical protocol.
Yes.
How sure you are that the medical community will take the decision on changing the protocol based on your
Basically, we have done multiple trials in basically in NIMHANS, Bangalore, AIMS, Bhopal, AIM Delhi. We have done multiple trials on that basis. Basically, it's a screening tool. It's not a diagnostic tool. We are not. Yes. We have done a multiple trial. On that basis, we have a 97% sensitivity, 94% of accuracy, and 94.1% is sensitivity. Yes.
Thank you.
I want to follow up with Mark's question. Using this device will change the behavior of the clinicians or of the users, right? How can you know that you can change behavior? What kind of validation do you have so far?
Right now, we have done a multiple trial. On that basis, we have the patient who don't have the sign and symptoms, basically. For that patient, this device is useful because right now the patient which are going under to the glass coma scale test. So, right now the patient which are going to the mild TBI cases, they are not detected by the glass coma scale test because this is not accurate right now. It's 56% on a data basis we can say. But our device is objective based. It can give the device self the patient for automatically notice.
Thank you.
Yes.
Behavioral acceptability of the clinicians for the device, based on the clinical trials that you have done amongst the clinicians.
We have done a survey also.
I have a question. If you are selected for this program, who's likely to be part of it? And what is your role in the team and what is Shilpa's role in the team?
Shilpa ma'am is a founder of the company and I am the medical affairs manager of the company.
So would you both be essentially participating?
Yes.
Okay, thank you.
Thank you.
Thank you. Next, we have Biology, which is being represented by their co-founder, Dr. Anchal Chandra. Can we have the presentation for Biology, please? Okay.
So imagine a disease that is almost entirely preventable.
Jury, we are online. Please.
Okay, so imagine a disease that is almost entirely preventable, but still it kills 350,000 women every year. This is cervical cancer, and the issue is not with the complexity of the disease, but the screening, which is still heavily reliant on doing clinical visit, access, which is not merely millions of women do not have access to such kind of screening, and the infrastructure, which is heavily reliant on only urban centers. Now, yeah. Oh, wait. Wait. It has, I think I clicked few many times. How do I? Okay.
Can you point to the laptop? I think that
Yeah? Okay. Okay. Anything else? Okay, so EU is heavily committed to eliminating cervical cancer through its various programs, which is EU eliminating cancer as well as the WHO targets. But most of these programs and the current screening is limited due to multiple pelvic examination, which is usually done in the clinic, and most elaborate lab-based diagnostics, which takes multiple days, as well as the limited resources and hospital staff, which is not usually available. Now, this requires a solution that can be easily decentralized and can be provided to women at an easily accessible rate. And for this issue, to solve this issue, we have developed self-service. Okay. Okay. So self-service is a integrated self-sampling and self-testing solution which can detect up to 8 high-risk HPV subtypes in a single test. It offers easy to access and a very representative method for women to collect their own sample and do the self-testing at the convenience of either their home, it could be at a public or private hospital, or in a community-based setting. Okay, so there are few HPV-based rapid detection tests which are in the market, but they usually target HPV 16 and 18, and they are very limited in their detection capability as well as qualitative. Self-service ensure that you can detect multiple HPV subtypes which are quite heavily prevalent globally in a single test without the requirement of any additional instrument for detection and operation cost. Okay, so for us, EU is not just a market. This is where we want to, it's a regulatory as well as validation anchor for global scalability for our solution. We are looking to, with the help of VK Connect program, to actually access 3 main areas where we want to clinically validate our tests developed in the EU markets by forming clinical partnerships. Secondly, to understand the more IVDR regulatory network of EU and regulatory bodies, and thirdly, to basically deploy the situation and form strategic partnership with the for the deployment of the solution. So talking of my team, we are basically comprised of a combination of engineers and scientists. We come from a background of nanobody-based discovery, AI-based enable nanobody discovery platform and biodata discovery, which is the sorry for the
Hello, thank you. Can you tell me about the business model? Because I understand that one plan is for women to test at home, right? Which is great. Is this a B2C? Do you see this as a B2C?
So if I talk so when we develop this test, so of course for the Indian market, our main approach or the main main target or customer will be the government bodies, because we want this implemented in the screening programs, national screening programs. And of course the second tier is when we want to introduce this more on the pharmacy off the shelf test, because this is something, it comes in a screening range. This is not a test that women will immediately go and buy from a pharmacy to get tested. So to implement it in a regular screening regime, it has to be implemented through the either through the clinician partners or recommended by them. So that is where we want to approach more clinical partners and go for B2C and B2G implementation in the first round. Secondly, second tier will be going directly to pharmacy and diagnostic partners, where this test can be made available for women for at-home testing.
Here I see a big challenge, making women aware of the importance of testing themselves.
Yes, so there is a strong need of creating this awareness that this particular screening can be done at home, and how necessary it is to get screened at a regular interval. So I think this is, of course, comes co-ed with the regular awareness programs that to educate women that you can easily take an at-home test for screening yourself for HPV infections.
I don't know if you mentioned this already, but what's the stability or like the shelf life of?
Yeah, so far we have generated up to 9 to 10 months of stability data, and we have very stable tests because the nanobodies that we use, they are very highly stable at room temperature. We are still continuing this study, so we want to push this to even at least 18 months. But so far the data generated that we have is for around 9 to 10 months stability.
This is before and after collection of the sample?
No, this is, I'm talking about the IVD, the assembled IVD test stability.
Okay.
Yeah.
Right. So, I mean, once the test is taken, once sample is collected, does it still remain stable at room temperature?
No, sorry, I think you didn't get. So this device, basically you can collect the sample with the integrated device, and then you can immediately do the testing. You don't have to send the sample anywhere. You can do the testing, so it's almost immediate, and within 5 to 7 minutes you will get your results. Yeah.
Okay, so by doing that, let's do that, okay, and we will increase the diagnosis, okay. So then what happens? So basically, pharmaceutical industry. So how is the access to the treatment?
Yes, so this test is basically designed for screening purposes, and this basically covers the area where, so normally for HPV screening, what is recommended when women take a test in lab or in clinic, if they come positive, they're asked to repeat the test 2 to 3 times at an interval of 2 to 3 months. This is basically to check whether they have a persistent HPV infection, and will these be the candidate who are at high risk of developing cervical cancer, right? So this kind of screening is what we have decentralized. So immediately you have to repeat the test a couple of times to get any intervention. If you keep coming positive for all the 3 times, then is when the clinician comes and intervenes, and they will then triage you whether to determine which stage you are in. Basically, you are in SIN 1, SIN 2, or the
Drug A or intervention B.
Yeah, so then
And these 3 women are the ones that they are telling you that if you do so, this is going to be great for them in order to progress, no, with the treatment, etc. No?
Yeah, so I mean, so after the screening test, if the women comes positive, then they have to implement a triaging test, which is usually, still we don't have a point of care solution for that. That is usually still done in a lab or a cytology based testing, where they will determine which stage you are, and if you have already progressed to a later stage, then of course, then it will go through a standard treatment, cancer treatment. There is no bullet therapeutics for cervical cancer still, so it will go through standard cancer treatment, which will be chemotherapy and yeah.
Thank you, Dr. Anchal. And now we have the last live pitch of today, that will be by Abhishek Gaikar representing Force Medex. Last but certainly not the least, I hope the jury is still attentive enough. And just to brief the jury, after the final pitch, we have 2 video recorded pitches by startups who could not be here in person. And with that, Abhishek, over to you.
Hello. Breathing should be effortless, right? But in case of
I will request you to take some. Thank you.
breathing should be effortless, right? But in case of mechanically ventilated patient, the clearing of an secretion is itself a huge task. I will just brief about what mechanical ventilation means. Mechanical ventilation is nothing but when lungs are not responding properly, they have been put on the ventilator with the help of an endotracheal tube, or you can say as artificial airways. This airway is now have to keep the patient alive by providing the breathing. In normal case where the normal lungs are there, where we can cough out the secretion whichever is giving an uneasy feeling in the trachea. But in case of mechanically ventilated patient, it is requires manual intervention to take these secretions out, and that's where caregivers come in. Caregivers spend millions of hours in order to do this suctioning over the ear for the mechanically ventilated patient, and surprisingly, 70% of them do not follow the suctioning guideline provided by national and international bodies. And as a result of that, there is kind of mucosal injuries, there is a high risk of getting infection, and the biggest culprit is ventilator associated pneumonia, which requires at least 3,000 euros to treat one episode of an VAP, and it is a recurrent one. So we ask a simple question to ourselves, why this suctioning have to be manual at all? Why it can't be automated, safe, discreet to the patient? So that's where our product Truckies comes in. Truckies, Truckies won India's Best Design Project Award in 2025, and this is a multi-component system altogether. We have modified the airway itself so that suctioning and ventilation can happen at the same time without having any intervention for the mechanically ventilated patient. We have something known as obstruction detector, which will tell you what's the lung health, what's the tube health, and based on the feedback, our suction system will precisely decide the suction pressure and take the secretions out without touching the patient. Essentially, with this system, there will be no guesswork, no oversuction, and no waiting for any kind of an alarm. It can work entirely without any human intervention. So why we are better than existing? In order to provide a comprehensive care for mechanically ventilated patient, oral, subglottic and tracheal secretion has to be sucked. Trachea being the most aerodynamically complex area to suck the secretion, because force of suctioning is 16 times higher than that of force of inhalation. So that's why it is very much complex. In this particular case, we are on the automation side, where a bigger player like Medtronic, Smith Medical are on the manual side. So we are able to do suctioning of oral, subglottic and tracheal secretion automatically. In case of business case, we have two different revenue streams. First is recurring sales of consumables, which is around 50 euros, and one-time sale for suction system unit, which is around 5,000 euros. Our TAM is about $3.4 billion, and our SOM is about 29 million, considering 10% of the whole market. Why our product is completely based on the ventilator itself. So that's why our best strategy is to get acquainted or get partnership with the strategy with Jet-Eng, Hamilton and Drager, so that we can go on a massive scale. Our expectation from BFIs are simple. In order to get into Europe, we would like to understand the regulatory access for the same. Secondly, we are trying to create a clinical and evidence strategy for the same. And finally, partnership with the OEM, so that different parts are currently being exported from the Europe itself. So we would like to have a good partnership with them. So this is the team behind the product. Myself, Abhishek Gaikar, I'm the founder of Medex. We have Geet, who is a designing product designer for us. We have Shubham and other parts. We also have a team of advisors who are helping us in different way, essentially from different MNC companies. Thank you.
Hi, thank you. You say that your plan is to partner with manufacturers, ventilator manufacturers.
Yeah.
Okay, have you had any conversations with them? Because I wouldn't be surprised that they tell you that their business is to sell their ventilators separately from any other device.
Okay. Essentially, ma'am, I would like to point out that getting this particular BFI Biome Fellowship from Venture Center, our 6-month task was to understand what these people are expecting from any kind of a startup like us. So we have spoke to JetEng, Hamilton, as well as Medtronic also, and essentially Dragger, to understand what they expect from our product. Essentially, JetEng has given a positive response on the product for the collaboration with them. In fact, they have asked us to apply for one of the clinical research grant that they have to sponsor our clinical trials along with their ventilators in a due course time.
Are you raising any funds?
Yeah, currently we require almost 1.5 million euros to get into the market with all the regulatory clearance and all. Currently we are at a stage we have established our proof of concept. So yeah, we are actively looking for the investment to get into the process of manufacturing and other aspects, including clinical trials.
Congratulations. How you manage the risk on Medtronic developing an automatic version of what they already have?
Okay, so essentially our product, whatever concept I have explained to you, it has an WIPO published document. Our product already, it is while doing the research report, the international search report, Medtronic and the Philips, we haven't some closeness into that, but still our product is better than that. Just for a simple reason, we are not having another tube for the suctioning. It is ventilation and suctioning together. We have also patented our designs on a world level, on a global scale also, and we are going ahead with individual.
Sorry, and the clinicians and the people working on it says that this particular point is clinically relevant. What you just say, the differentiation.
Yeah, essentially, because what happens in case of a Medtronic and other Philips, whatever product they have developed, they have additional suction line to take the secretions out whenever it is needed. But essentially, as due to capillary action, these tubes are getting filled by themselves, and they are getting blocked completely. So after a period of time, this cannot be used for suctioning. But in our case, we have ventilation and suction in the same tube itself, which is smartly calibrated. That's why tubes are continuously active and not taking the secretion, not getting blocked actually. That's important.
Sometimes, in ventilated patients, we need to take samples from suctions. How would this allow for that to happen?
Essentially, the whole system is a closed loop. So whenever we want to take the secretions out, we can directly remove the small. We have a connector actually to take a ET sampling every day in the morning as well.
Allow for that even in situ.
Yeah,
Okay.
absolutely. Thank you.
Okay, thank you, Abhishek. That was all with the live pitches for today. We have 2 recorded videos where the last 2 startups on the list. We'll just pick them up.
Now we have 2 stocks. So take 12. So 3 hours.
Yeah, I think we have time to finish.
How long? Here to the airport?
Let me just check the estimated time.
1 hour.
Yeah,
Yeah? 1 hour.
1 hour, 10 minutes.
Sí, però va d'arribar a la sortida i demanar l'Uber. Anem també.
Abnormal screen okay, folks, we are unable to play the video there, so I'll show the video to the jury separately, and then we can deliberate and discuss. And all the folks, the finalists who are still around, I request you to be around. We hope to make the announcement in what? 15 minutes? 15-20 minutes. So, yeah.
15.
Yeah, 15.
Ah, vale, aquí. Ah, yeah. Sound is here. Ah, okay. It's fine. It's not playing on my laptop for some reason. So I'll try to share it.
Okay, you don't like Centella either.
No.
And he didn't learn.
No, like science.
What about and what about this? The one that we... Ah, yeah, I remember this one. This one.
Ah, you have picked that up? Ah, okay, thank you. So, okay.
At what time?
5 minutes late.
Yeah. 5:15, yeah.
5:10. 5:10 we should leave.
5:10 we leave, yeah. Okay, thank you very much.
Thank you.
You will work with us?
Thank you, perfect.
wow.
Yeah, that's because, everybody's facing off. Yeah.
Okay.
Okay, so we all agree with number 2. Okay. How to take 4 hours.
3 hours.
3 hours.
And then we are agreed that 14 is in, and this one is in. Okay. So then, okay, so I brought these 4 names. For your business.
Yes.
Are we agreed on these 4 and we say one of them?
Yes.
So you're announcing it now?
Yes.
So, are you agree with that? Are you agree with that? Do you have any other to add to this list? Now is the time that we can add another one. We think there's another one that is candidate not to go to the patient. have?
Well, for me, I don't like much CLRNA, not for the science, but for the. I agree. Okay, not the father. Definitely
He's asking which one? What is big gap?
Basically, machine-free diagnosis.
Yes.
First one, Intignis, who I believe had to unfortunately leave to make their flight. Then there's CLRNA Therapeutics. Please come towards the dais. We'll have a picture. We have OpenMed Labs. Then we have CRISPR Bits. We have R&D Health Insights, also people who couldn't make it in person here, but they are part of the cohort. We have Biology. We have ForceMedX. We have Bioscan. We have Centella AI. And Ignosis. Serigen Mediproducts, I believe they also had to leave to make their flight. And that's that. That concludes our cohort. And to the others, especially, I'll make this announcement here. Nishant, hang around. We do need to speak to you. You are not part of this cohort, but there may be some possible collaboration. So this is it. This is the cohort. Missing a couple of them. And I request Dr. Gaurav, Dr. Mark and Dr. Pilar are here. Dr. Pooja. I also request Dr. Sanchita if she's around. Okay. Rajesh. And other BFI members, please do join us. Shivani, Sana, Vaibhavi. Dr. Shweta, please. Shantanu. आप वो सेलेक्टर हो आ जाओ
When are you leaving? What are you doing? So everybody is going to Bangalore. Congratulations. We'll be in touch, and then we'll start the cohort online sessions. The mentors are already selected from their end, so we match and then the first session will happen for the initial 1 month, which will be online, and then there will be another selection for 5 cohorts, 5 people.